You can start, sir.
Okay. Good evening, one and all. On behalf of D Club, it's an honor to welcome the distinguished faculty, the speakers, and the delegates for our second edition of Virtual Diabetes Complications and Comorbidities Conference, DCC Con 2022. The theme of this edition will be the neurological manifestations of diabetes, which has been coined by our founder secretary, Dr. S. Chandrasekhar, as neurodiabetes. Well, I will not go much further into the subject as such because we're going to hear from all the distinguished speakers about the same. Since the COVID has been quite rampant in this month, we have few of our speakers caught up with their work and also have fallen ill. There will be some changes from the original agenda of our program. So now I welcome our founder secretary, Dr. S. Chandrasekhar, who is also the professor and head of Department of Medicine, Stanley Medical College, executive member, Chennai API chapter, treasurer, Tamil Nadu API, zonal executive member, South India. He has published 22 articles in various journals to have the introductory lecture and then continue the scientific session and empowering the knowledge in diabetes. Thank you, one and all. Dr. Chandrasekhar, sir.
Yes, sir. Yeah, good evening, everyone. I welcome all the faculties and delegates for this the DCC Con on neurodiabetes. Professor Palani is supposed to talk on the cerebral thoughts on neurodiabetes. Because of its unavailability, I have taken up the task of delivering this neurodiabetes, and I've been made as a ready-made speaker. And I am just trying to give some insight into the neurodiabetes of it, because most of the things would be covered by the rest of the faculties. So we know that the brain is a unique organ, so it does have many functions. But what is its relevant to the diabetes and its various pathophysiological factors? Say, for example, insulin resistant and hyperglycemia, how it's going to cope up with these kind of stress. And of course, a little bit about the hypoglycemia and summary part of it. So let me begin with this wonderful organ, that is brain. So we know that the brain, it's a very peculiar organ. So it requires almost all the time the glucose as a fuel. And most importantly, though it accounts for 2% of the body weight, it utilizes only the 25% of the body's glucose. We all know that it takes almost 15% of the cardiac output and 20% of the oxygen utilization. The other peculiarity what we see with the brain is it doesn't intrinsically produce glucose, unlike some of the other organs like it. So that is another peculiarity we see with the brain part of it. So initially it was thought that the neurons, they take up the task of metabolizing glucose, but with the recent advances, we come to know that the astrocytic food processes, particularly which contains the GLUT1 receptor, which are non-insulin dependent receptors, and the GLUT4, which acts in a glucose insulin dependent way. So these receptors, in fact, the food process around the capillaries, they does the work of regulating the glucose absorption and storing little bit of glucose. So that's what the astrocytic food processes does. Unlike other organs, the brain has got a very little endogenous glycogen storage to the tune of 0.5 to 1.5 gram. So that accounts for almost 0.1% of the brain weight, and it hardly it can cope up for 1 to 1.5 minutes of hypoglycemia. Beyond that, we need to depend on other sources. Of course, the brain can use glycerols, lactate, and ketone bodies during starvation. That is important. The the measure the brain does during starvation. But of course, again, this cannot meet out all the metabolic demands of the brain. That's why, like the people who are having prolonged hypoglycemia, they get into neuronal death, apoptosis, and sometimes coma and consequences, so on. So I'm going to talk about how does this the diabetes influences the brain through its hyperglycemia as well as the insulin resistant. So let me first take you to what is insulin resistant. So the thing is like, so when somebody is taking high triglyceride or high in saturated fat, obese person taking fructose and excess glucose, branch chain amino acids, all these things, like it can result in carbohydrate responsive elevated binding protein and the steroid responsive elevated binding protein. So these things will in general generate like or activates the lipogenesis. So once this lipogenesis happens, in addition to the free fatty acids from the white adipose tissue, so because of the insulin resistant, you get a impaired signaling and you get a defects in the fatty acid oxidation, culminating in accumulation of the diacylglycerol and ceramides in the tissues. So this again results in the insulin resistant, increases the insulin resistant part of it. And what happens in certain organs, because the insulin resistant happens in almost all the organs in our body. When it happens in the liver, like it increases the hepatic gluconeogenesis and decreases the skeletal muscle glucose uptake, and brain leptin level goes down. So all these things can happen. So in addition to that, like there is another pathway, like wherein these the lipotoxicity, which can trigger another the pathway leading on to the escalation of the lipopolysaccharides and toll-like receptor signaling, which again culminating in a inflammatory state. So this is what happens in a patient with insulin resistant. So in normal insulin metabolism, what happens? The most of the tissues, they take up the glucose through the phosphoinositide 3 kinase, that is PI3K pathway, where it activates endothelial nitric oxide synthase, which results in vasodilatation and increased blood flow in tissues, and increased delivery of the glucose and insulin to the tissues, and which helps in the disposal of the glucose. Whereas in patients with the insulin resistant, like what happens, instead of this PI3K pathway, like it takes up the MAP kinase pathway, that is mitogen activated protein kinase pathway, which produces endothelin 1, which promotes the vasoconstriction, and it produces vascular adhesion molecules, results in clumping, microthrombi formation, and increased WBC and endothelial interaction and growth of the vascular smooth muscle, and decreased disposal of the glucose. All these things, because it happens when a person is having an insulin resistant, it happens in every organ in our body. So that is the problem. So this is what takes up as a consequence of insulin resistance in our system. So let us see what happens in insulin resistant when it happens in the brain. So as I already told you, like you get insulin signal impairment, and it promotes amyloid beta accumulation and tau phosphorylation. I think these things can happen, and it can result in the decline in the cognition and dementia and so on. Of course, it also creates an inflammatory milieu in the brain tissues. Now let us see on the other end, like we have got two components. One is the insulin resistance. The other component of diabetes is the increased excess glucose. So the hyperglycemia. So it can result in advanced glycation end product. So these are all nothing but heterogeneous macromolecules, which are mainly due to the non-enzymatic glycation of the plasma proteins. So which eventually can disrupt the structure and the function of each and every cell where it deposits. So it not only binds to the protein, but also to the lipids and the nucleic acid. And it also binds to the receptor. So that we call it as a receptor advanced glycation end product, which can elicit a pro-inflammatory and pro-atherosclerotic mediators, including nuclear factor kappa B. And so inside the cell, it causes the nuclear factor kappa B, and increases the genes which are responsible for the pro-inflammatory and pro-atherosclerotic actions. So something like it activates the monocytes, basement membrane thickening. It causes increased permeability, endothelial permeability to macromolecules, and blocks the nitric oxide synthase. So not only you have age products, but also the hyperglycemia, chronic hyperglycemia can result in oxidative stress. So which can result in increased superoxide production, particularly in the mitochondria, and you get elevated polyol pathway and protein kinase C pathway. And it also, most important, it blocks two important anti-atherosclerotic enzymes, that is nitric oxide synthase and prostacyclin synthase. As I already told, like these stress and hyperglycemia can result in the damage with the mitochondrial DNA, mainly because of the release of the nuclear kappa factor B. And that can result in a pathological memory of defect in the microvasculature that can persist even after the glucose normalization. In addition to that, the insulin resistance also can contribute to the oxidative stress through the formation of excess generation of the free fatty acids and free fatty acid oxidation. Eventually, all these things again culminating in the increase in the vascular smooth muscle proliferation, endothelial cells, and macrophages. Not only that, it also can result in low-grade inflammation. So this continuous sustained hyperglycemia provokes monocyte adhesion to the endothelial cells and production of the superoxide. And more important is like it also can lead on to matrix degrading metalloproteinase. So what does this do is like it is the one that causes the plaque rupture. So that one has to understand in the presence of a low-grade inflammatory state. In addition to that, it also causes vascular smooth muscle proliferation. Also, like as we see in any inflammatory state, it also tends to raise the CRP, hsCRP, fibrinogen, and PI1 levels. The last one is like the neovascularization. That is also another characteristic thing which we see in patients with hyperglycemia. So that is nothing but the proliferation of the vasa vasorum in response to a hypoxia. So hypoxia-induced growth factor, not only the hypoxia-induced growth factor, there are various other growth factors also can go up in patients with uncontrolled hyperglycemia. That is vascular endothelial growth factor, fibroblast growth factor, hepatocyte growth factors. So all these things, like in fact, this neovascularization can happen from both the outer layer as well as in the intimal layer, inner layer. And this is the one which interconnects the micro and macro circulation in patients with the diabetes. So this we all know, like how hyperglycemia through various pathways, like how it results in oxidative stress, endothelial dysfunction, resulting in nerve dysfunction, and subsequently nerve damage, segmental demyelination, axonal loss, and neuropathy. So I think most of these, the hyperglycemia part of it, I hope the rest of my speakers would be dealing with that. But I thought like I just take a moment of time on the hypoglycemia, what really happens during hypoglycemia. As I already told you, like it's the obligatory fuel for the brain. So the actual interruption of the glucose supply can result in functional brain failure and eventually lead on to coma, sometimes death also. And there is a relationship between the severity of the hypoglycemia or recurrent hypoglycemia and long-term cognitive dysfunction also, particularly in the older age group. And it has been proved in autopsy studies of the patients dying after an episode of severe hypoglycemia, the superficial layers of the cerebral cortex, hippocampus, caudate nucleus were reported to be affected. Now let us see how the hypoglycemia can cause a neuronal damage. So there are certain areas in our brain in the order of severity, I'm telling. So like subiculum. So that is the inferior part of the hippocampal area. Area CA1, that is the outermost part of the hippocampus, tendenate gyrus, and small and medium-sized caudate neurons, and superficial cortical layers and substantia nigra. So these are all the areas which are vulnerable to develop a hypoglycemia-induced neuronal damage. Interestingly, the cerebellum suffers least insult because of the greater efficiency of the cerebellar glucose transporter. Again, another peculiarity what people have observed is there appears to be some damage due to hypoglycemia that is closer to neurons around these CSF spaces. So these are all some of the things like how the hypoglycemia can affect a brain and resulting in damage. And what happens, the pathophysiology part of it, again, I go back to the little bit of the biochemistry part of it. Like, so you have less glucose to be available as a substrate for acetate. And as a result, the glucose is not available. Like you have more increased oxaloacetate. and that can result in the generation of aspartate and glutamate production. So in fact, the Krebs cycle would be truncated. So the oxaloacetate would be converted to the aspartate, and alpha glutarate, ketoglutarate would be converted to glutamate. So that's what happened in patients with experiencing hypoglycemia. So we all know that like aspartate and glutamate are excitatory amino acids. In fact, the aspartate increases almost to the tune of 4-fold, and CSF increase to 16-fold. Similarly, the glutamate receptor activation also happens in patients who are experiencing hypoglycemia, resulting in the activation of the NMDA receptor, causing excitotoxicity. So this is more important. So the slide may look a little bit complex. I just try to make it very simple. So the one on the left side is the synapse, the pre-synapse and post-synapse. One on the top is the pre-synapse, the lower bottom is the post-synapse. And on the right side, you have the capillary, and in between is the astrocyte. So when the glutamate enters, it enters along with the sodium, and it leads to the activation of the sodium-potassium ATPase. And this can activates in turn the phosphoglycerol kinase, which begins which steps up the glycolysis. So the glucose is utilized and the lactate is released, and lactate is again taken up by the both presynaptic and postsynaptic. This is what happens in patients with normally. Okay. So when there is less glucose, like you have more glutamate. So that's what it happens. Eventually, the sodium and water influx would be retained into this because the sodium travels with the glutamate. So that being a little bit hyperosmolar, it tends to drag the water inside the cell, eventually can result in cerebral edema. So in addition to that, it is also followed by calcium influx and causes the dysfunction of the intercellular processes and a release of ROS. So eventually what happens, like when there is a hypoglycemia happens, three things gets released. Hypoglycemia can lead on to depolarization. Once the depolarization happens, like you get more aspartate, more glutamate, and more zinc. So this results in the activation of the, again, reactive oxygen species. And one more thing is the PARP1. So that is poly-ADP ribose polymerase, which gets activated, which is the one which is causing apoptosis of the neurons, resulting in neuronal death. So all these things happen. So already I told you that like there are certain areas in the brain are more prone, in particularly the cortex. So that's why the people with the hypoglycemia, they get more seizures. Almost the literature say that 20 to 30% of the hypoglycemic patients who experience a seizure is because of this phenomena. Not only that, the tissue also goes for alkalotic environment because there is no glucose. The brain tissue try to utilize the protein as a substrate, resulting in the nitrogenous waste product like ammonia accumulating, resulting in brain alkalosis. And it also consumes lactic acid and ketone bodies in profound hypoglycemia to a certain extent. So how do we differentiate like hypoxic brain from a hypoglycemic brain? So hypoxic brain, the redox is reductive, and hypoglycemic, it's oxidative. And hypoxic brain, you get an acidic environment, whereas an hypoglycemic brain injury, you get alkalosis. So more important thing is, in patients with the hypoglycemic encephalopathy, they'll have some changes. Like so, usually what happens, hypoglycemia, it spares the axons, whereas hypoxic injury can result in the entire neuron can get damaged. Again, the hypoglycemic encephalopathy can affect neurons, whereas the hypoxic injury, in addition to the neurons, it also affects the glial cells and the endothelial cells. So these are all some of the differences, like how we can differentiate hypoxic from hypoglycemic encephalopathy. So coming to the clinical manifestations on brain, like so the how does hypoglycemia when it happens, like what are all the manifestations we do expect? So the insulin secretion stops at 81 milligram per deciliter. The counter-regulatory hormones like glucagon and adrenals start secreting at 68 milligram per deciliter. There is a chronological thing. It varies from patient to patient, but there is a range. It's not exactly 81 or 68, something like that. Sympathetic nervous activation, like the sympathetic symptoms like sweating, irritability, tremors, it happens around 54 milligram per deciliter. And the glycopenic symptoms occurs at 45 to 50 milligram per deciliter. And the coma or flat EEG and neuronal death happens when the blood sugar is less than 18 milligram per deciliter. So one of the other manifestation which many patients with hypoglycemia, we say that like a minor hypoglycemia, where they experience headache. So first recognized in 1933. We all know that like fasting and hunger can have a precipitating effect on the migraine effect. The similar thing is being extrapolated in hypoglycemia induced headache also. So there is a criteria 10.5. The thing we can diagnose with certain characteristics also, like usually the headache would be on the frontal location, diffuse pain, non-pulsatile, mild to moderate in intensity, and the patient should have had some fasting for more than 16 hours. And there are some obligatory criteria, like the headache should develop during fasting and resolves within 72 hours after resumption of the food intake. So this is also another manifestation which we see, clinical manifestation in patients with hypoglycemia. What happens when we take a EEG in patients with hypoglycemia? We don't do EEG in most of the patients, but in patients with prolonged neuroglycopenia, sometimes we do take a EEG. So what happens? So when the glucose is between 36 to 63, we get predominantly theta wave predominance. And when the blood sugar goes further down to less than 36, delta waves takes upper hand, and we do see more of delta waves. And the patient also would become stuporous and drowsy by that time. The flat EEG usually it indicates the neuronal necrosis. And eventually the neuronal necrosis and apoptosis and neuronal death happens when the when the blood sugar level is between 12 to 24 milligram per deciliter. So hypoglycemic coma, when somebody is having hypoglycemia, sometimes we see many patients, we receive many patients in an unconscious state said to have hypoglycemia. But this has been a kind of a big prize for this gentleman, Dr. M. Sakil. So we incidentally found that when he was treating the schizophrenic patients with insulin, he was shown that like, so the patients do recover within 30 minutes of treatment from the coma. So for which it fetched him a Nobel Prize also. And beyond 30 minutes, like if the intervention is done when you attempt to treat that patients, it would be the coma would be irreversible. So that's what he has mentioned. And there are a number of studies which are done with the hypoglycemic coma, particularly using the anti-OHAs. So this is a study which is a bit old study, but it's worth recollecting. So it was a study done over a period of 7 years, evaluated 102 patients admitted with coma and with their blood sugar levels below 49 milligram per deciliter. And all these patients were type 2 patients taking glycemic agents. Most of these patients were taking OHAs. And they have shown that like some of the risk factors, like the age more than 60 years, renal dysfunction, decreased energy intake, infections, all these things were the precipitating factors for these people to develop hypoglycemia. And they have shown that like some of the patients, like they had a physical injury due to the fall, 8 had seizures, 1 had coronary artery disease, 1 had stroke, and 5 patients had death, and of which like almost all the patients who died had other serious medical conditions also. So interestingly, the 62 patients responded within 12 hours of the treatment, and 40 patients took almost 12 to 72 hours to improve. So this has to be remembered. It's a old study, but it's worth remembering because these are all the situations we clinically do see. Again, another study, which is again, it's a bit old study, but it's worth recollecting that like sometimes it may take more time for the hypoglycemic patients to recover. So one has to wait for some more time. But the thing is, we need to have some investigations also to be done to rule out other conditions. One of the most important tool to rule out other conditions or to diagnose hypoglycemia is the MRI, and particularly the diffusion weight imaging has been reported to be more sensitive, and because it can detect the early alteration in the water diffusion resulting from the cellular dysfunction, identifying early neuronal damage. So in fact, it can represent the neuronal loss or proliferative astrocyte loss or some paramagnetic substance deposition. All these things can be shown in DWA. So there was a study which was done in Korea, again showing done in patients with the hypoglycemic encephalopathy with coma, where they have shown that like the involvement of the internal capsule was the common site in patients who had hypoglycemic encephalopathy, followed by hippocampus, followed by centrum semioval, and cortex in 73% and corona radiata in 64%. So these are all the illustrative picture where the T1 weighted and T2 weighted images where it's shown the changes, what is happening in hypoglycemia. So how long would it take? So all these hyperintensity changes, which we classically see in diffusion weighted images, how long would it take to reverse? Does it reverse? The answer is yes. Like it takes at least 14 days to 15 days for this patient to have the normality to be restored. So what is this prognostic value in MRI in patients with hypoglycemia? So it can spell out some prognostic importance also. Particularly, it may show some good prognosis when the hyperintensity in white matters, particularly the coronary radiator and internal capsule were seen, and hyperintensity regresses on follow-up imaging. So these are all some of the good prognostic things. Whereas the lesions which were detected in the cerebral cortex, basal ganglia, and hippocampus are not regressing on the follow-up MRI, where said to be the poor prognostic factors. Similarly, the gray matter damage is also said to be a poor prognostic factor, where the patient is unlikely to respond to your therapy or may not recover also. So do we have any the biomarkers to say that to identify which patient is likely to develop more poor outcome? So there are some markers are there. One is neuron specific enolase, and another one is the S100 protein. So this neuron specific NSE is markedly elevated in patients who died of hypoglycemic brain injury. So it doesn't get elevated in patients who are not having a brain damage or a neurological deficit for that matter. So these things can be, but still in the research phases, we don't do measure the NSE or the S100 to detect the neuronal damage. So the another marker is the hypothermia, so which is a frequent sign of severe hypoglycemia in patients with diabetes. Again, there was a study which was conducted, published in Elsevier. It's a nice, elegant study which shows that it's again retrospective study done on 128 patients with severe hypoglycemia, where hypothermia less than 35 degrees Celsius was identified in 30 out of 128 patients in severe hypoglycemia, not affected by age, type of DM, season, or time of the day. So this hypothermia may be a marker of hypoglycemia severity or the duration. Why the patient develops hypoglycemia? It could be an important compensatory mechanism in patients with severe hypoglycemia, reflecting the decrease in the energy demand during the glucose deprivation. So these are all some of the interesting facets which we see in patients with hypoglycemia-induced brain injury. So what are all the predictors of poor outcome in patients who is experiencing a hypoglycemic encephalopathy? Again, this is another study which was done in 165 patients, where they have shown that there are set factors. The low initial sugar value predicts poor outcome. The longer the duration of the hypoglycemia, again, predicts a poor outcome. The higher the body temperature. I already told you that hypothermia is the compensatory mechanism. When there is a defunct, when the patient is having elevated body temperature, then that can spell out a poor outcome. Similarly, the low whole blood lactic level, because the lactic acid could be used as a fuel in times of the starvation by the brain. So low whole blood lactic level also can spell out a poor outcome. To find out, particularly these things would be of quite a handy tool to predict the outcome in prolonged neuroglycopenic patients. Again, there have been many animal studies which have shown how the prevention of hypoglycemia-induced neuronal death by hypothermia. This concept is fast emerging. So that's why the patients with the stroke, they'll have better outcome in the presence of a hypothermic environment. So similarly, the prevention of acute and severe hypoglycemia-induced neuronal death by lactate administration was also been done in animal studies, but yet to be implicated in human trials. This is my last part of it. I already told you that hypoglycemia does so many damages to our brain tissue, particularly in a patient who is having a chronic hyperglycemia, which can result in chronic inflammatory, which in fact can deplete the antioxidant response, eventually resulting in a massive oxidant stress injury, where this overwhelming oxidant stress injury, the brain is not able to tolerate. And it exposes the vulnerable areas of the brain, resulting in oxidative stress and mitochondrial dysfunction, oxidative damage, again, it perpetuates the chronic inflammatory things, perpetuates. So what I am trying to show is, so not only the hypoglycemia does more harm, even during the recovery phase, during the glucose reperfusion phase, the person can develop a mitochondrial dysfunction, oxidative damage, and chronic inflammation. So this is why, that's why like we are a little bit worried about the glycemic variability part of it. If somebody is experiencing both the hypo and hyper, intraday observations, where like I said, to be more risk factor for developing more cardiovascular or neuronal complications. So this is a very important thing, like one has to remember that, like one has to at least avoid this glycemic variability part of it. To summarize, the both the hyperglycemia, insulin resistant, can result in the neuronal damage, but one has to remember the orchestra of the carbon contributing factors, particularly the presence of associated diseases like hypertension, lipids, coronary artery disease, chronic kidney disease, metabolic syndrome, obesity, all these things, infections can contribute as well. Most of the complications are proportional to the duration of the hyperglycemia and the magnitude of the poor glycemic control. This is a very positive thing, like the glucose glycemic control improves the outcome. So that is a very important thing to remember. The micro and macrovascular complications are the two ends of the same spectrum in continuum, particularly in brain tissue. So with this, I conclude my talk, and I thank again all the delegates for their patient listening. Thank you.
Thank you, Dr. Chandrasekhar, for an excellent presentation of the overview of neurodiabetes. Are there any questions in the chat box?
So what is the reason for the recovery of neuroglycopenic symptoms lately recovering, sir? Is there any reason why it takes time?
Neuroglycopenic?
Recovery symptoms, it takes a longer time. You said no, sir. Sometimes they take longer time for it to recover and all. What could be the reason?
Yeah,
is
so
it taking time
multifactorial, in fact, like, so not only the, I already told you that like hypoglycemia is the obligatory fuel for the brain. Like once the glucose is infused, we expect the patient to improve. So that's what's happened in most of the patients. We expect the patient to recover in a matter of 5 to 10 minutes to regain consciousness or to relieve from the symptoms. But in certain individuals, the prolonged neuroglycopenia happens when the intervention is not done. So that is because of the, already I told you, like it can result in oxidant stress and inflammatory milieu and the escalation of the inflammatory pathway and so on. But not only that, these patients, particularly people who are developing hypoglycemia or having longer the duration of the diabetes, they do have already damaged the blood vessels. The macrovascular component is also, the damage attributable to the macrovascular component is also said to be present in most of these patients. And the one study which I have shown that like most of these patients would be having other risk factors also, the diabetes, lipids, and other organ dysfunction also. So all these things put together can result in the delayed recovery of the neuronal tissue. So that's what the thing is, like not a single factor which is responsible. It's usually a multifactorial thing. Like, and moreover,
as what has been said is right, that the duration of hypoglycemia and the severity of hypoglycemia dictates the time to recover. Two things, both are important. See, what happens is when the neurons are damaged to a limit, they do recover, but it depends on the extent of damage. As Dr. Chandrasekhar has very vividly brought out in his slides. What happens is that when that decay is there, apart from hypoglycemia alone, there are some tissue damages which are some mitochondrial induced. The mitochondrial damage do not recover that easily and that fast. It takes time to recover. To a certain extent they do, but they do leave a significant residue in the long run. That is what is also one of the postulations for the so-called small vessel ischemic disease, very often seen in diabetics. That's also an important parameter. Like what Chandrasekhar said, that if a patient is already having multiple risk factors, he has got a significant small vessel ischemic load, the recovery is likely to be more and more delayed. So we need to have that's what I do in my emergency is that when a patient comes in an unconscious state, non-diabetic, sugars 100 or less, I tell them give 25 first, then call me. That's my instruction to my ER. 100 ml 25% dextrose should be infused forthwith and then call me. Then I get into the picture before when they come out, when they don't come out, and other things are happening. So what happens is it not because by the time the patient presents, there is some compensatory mechanisms. The body tries to shore up glucose and it does shoot up to some extent, but it need not necessarily be that low. So what is important? Hypoglycemia can mimic stroke. It has happened many a time that I'll cover up slightly when I come to my talk. Hypoglycemia can mimic stroke. Focal deficits have been documented in hypoglycemia, which on correction disappears. So these are all certain points that we should keep in mind. Any patient who comes to the ER, look at the sugar. If the sugar is 100 or less, I always tell them give 25% dextrose. In a diabetic, it's not going to matter much if this thing is sustained. In a non-diabetic also, by giving 100, I say 25 grams of glucose into the circulation, we are not going to cause much damage to the circulation.
So in fact, it causes some kind of metabolic imprint. It causes a bad memory in the mitochondrial tissue, which can result in, even when the glucose normalizes, it is able to, the damage is going to persist. So that would happen in patients with hypoglycemia. And the elderly individuals and people who are having the prolonged, the multiple comorbidities are more prone to develop prolonged neuroglycopenia.
Sir, can I talk?
Yes, sir.
Yes. Thank you for an excellent lecture. I have seen patients recovering after 6 weeks, 6 days. Type 1 diabetics after 6 days. This type 1 diabetic was eating whatever, even cork of a bottle used to swallow. And such a behavior I have not seen in my life. This hypoglycemic memory, what you have said is very correct, and your lecture was excellent. But the recovery of the patient with the glucose, if it takes longer time, you can think that there is damage in the brain. That's what we have understood in those days. And today, Dr. Chandrasekhar has given the complete pathophysiological and biochemical view of the events that are taking place. But how far we have seen, you are practically seeing and making the patient to recover fast is our aim. So sometimes we are given continuous glucose. And sometimes patients who have not recovered, I have given subcutaneous adrenaline. It is not written in textbooks. And we used to give dexamethasone IV injection for a rapid recovery. I know Chandrasekhar, any opinion on that? But we had this. People have recovered.
Yes,
So the
so,
adrenaline and corticosteroids, maybe the patient may have already some adrenaline insufficiency also. So these people may respond better to corticosteroid also. So sometimes we have to see associated polyglandular disorder also in hypoglycemia with diabetes.
Sir, that is a different thing, sir. In cases where they are not responding, the hepatic glycogenolysis is
I
caused
accept your practical views,
and
which we have also followed.
and steroids.
Yeah.
Dexamethasone.
Yeah.
so it's very common to see patients. Yes, sir, please, sir.
Yes, go ahead.
It's very common to see patients, particularly long-standing diabetes, to have some kind of defective sympathoadrenal response to hypoglycemia. So wherein, like what you said, like the steroids, but though it's not been advocated in the standard textbook, but by virtue of our experience, like we can have that kind of thing. That would be probably the plausible explanation we can offer, sir.
Chandru, the lecture was very nice. Thank you.
Chandru sir, there are some questions in the chat box. Can I read that?
Yes, sir. I think there are some atherogenic index and small millets. That's not in the purview of my talk, but anyway, like we do have very simple thing. Like so, when we do the lipid profile part of it, the non-LDL HDL component, like what the lipoprotein, what we measure, that would be in addition to the LDL. Like that would be the excellent tool to cover the atherogenic, the burden of the thing. It not only takes care of the LDL and other things, but also the apolipoprotein B and other things. So that would be a very simple tool, like in addition to the LDL, like in non-HDL also, would be another tool to measure the atherogenic burden. So of course, another question is millets. Of course, we can have a separate session on that. Like, of course, millets have got a role to play. So we talk about the nutrition part of it later.
Can we move on to the next topic, sir?
Yeah, we can move on to the next topic, sir.
Thank you, Professor Sundaram, sir, for your practical points, always the golden words from your golden experience, sir. Thank you, sir. Thank you, Dr. Chandrasekhar, for your excellent presentation. Now I welcome you to introduce Dr. Jayant K. Pandey, who is going to speak on diabetic neuropathy.
So next we'll have a erudite talk, erudite speaker, in fact, like Professor Jayant Panda with us. He is the professor and head of the Department of Medicine, SCB Medical College. He's a consultant diabetes and metabolic medicine and in critical care medicine, and serving the Odisha medical education for more than 24 years. He is accredited with so many fellowships, and he has been a very active member in so many associations. But one which I would like to say, the hospitality which we have experienced during his one of which to show its organizational skin during the 45th RSSDA, which was happened in Bhubaneswar in 2017. So it was a very unforgettable moment for all of us. The hospitality which Dr. Jayant Panda has shown, and is not only has got a good organizational skill, but it is good academicians, and published more than 71 national and international publications to his credit, and contributed several chapters in textbooks and updates in monograms, and contributed chapters in articles in various journals. And he is the editor of the Orissa Physician Journal, and he was the editor of Orissa Medical Journal between 2010 to 2016. And he is the editor, member editor, editorial board, JAPI and IJDCC. And he is also a principal investigator for many international and national trials. And he is going to talk on the diabetic, the peripheral neuropathy part of it. So it's one of the very common complications which we get in patients with diabetes. Over to Dr. Jayant Panda.
Thank you, Professor Chandrasekhar. It was so kind of you for this elaborate introduction. I'm really excited to be invited by the D Club, and I congratulate all the members, the president, Dr. Dhanamithiran, you as secretary, and then all our team, treasurer, Dr. Mohan, and Sundaram sir, and all team for this initiative. During this COVID challenge, you have taken this session, the DCC Con, the neurodiabetes, which is very beneficial. I asked all my postgraduate to watch, and it will be a good experience, because everybody discusses diabetes, but discussing the neurological complications separately, I have seen everything is there, starting from the sleep disorder to the autonomic neuropathy to the neurodiabetes. Everything is there, and best of the presenters. So congratulations for this nice session, and sometime it will be our pleasure to invite your team, the D Club team, to Odisha in some event after the COVID, so that we can share our experiences here. And thank you for telling about our events, and definitely will wait for the opportunity to host you all here in the beautiful city of Bhubaneswar. I think my slide is visible.
Yes, sir.
Yes, sir.
Yeah. So the commonest complication a diabetic presents with is diabetic neuropathy, because by the time the people present first time as diabetic, around 10% patients, they have neuropathy in some form or other that we have come across. And if you take all the complications, common complications, the retinopathy, the coronary artery disease, the diabetic kidney disease, all together, perhaps the commonest will be neuropathy. And if you take a history, examine the fit, invariably in everyone, there will be some form or other affection of the central, peripheral, or the autonomic nervous system causing the deficiencies. Because it's a very broad topic, I'll start with a case and I'll show how varied can be the presentation. This is an elderly man, 70-year-old man, was admitted with proximal wide swinging movements, distal semi-purposive flowing movements in left limb and repetitive twisting movements in right upper limb for a week. These movements were exaggerated during emotion and absent during sleep, and these involuntary movements were more in left limb than the right. Yet he was a diabetic, and for last 5 years was on oral drugs, but not on regular follow-up, and had a very poor control. On admission, the patient was found to have chorea and hemibalismus involving the left face, arm, and the leg, and dystonic posturing of the right hand. Other neurological examination was normal. This is a real life case, and I'm unable to share the video which we have taken, but because of the technical issues, not sharing here. Initial biochemical values were done, and the blood glucose was 580 milligram per deciliter. And without the ketone body present, the sodium was 138, the potassium was 4, and the urea was 48. The osmolality was calculated, and it was 316 milliosmol per liter. A CT scan was done, and it was showing the hyperdensity in the bilateral putamen and globus pallidus. And this was the patient's presentation. And after this hyperglycemia was corrected by insulin and followed the treatment with oral hypoglycemic agent during the hospital stay, the involuntary movements also decreased as the serum glucose approached the normal levels. And this shows a follow-up CT scan, which also shows the resolution of hyperdensity and the congestion of the brain relieved. So reviewing the literature, the osmolar hyperglycemic state, how the neurological deficits they're presented, we found the hypothesis is related to depletion of inhibitory neurotransmitter GABA, which is metabolized in the brain as an energy source in HHS, and the deficiency of GABA in basal ganglia lead to this hemichorea and hemibalismus syndrome. Another hypothesis shows the involvement of the transient focal cerebral ischemia caused by the hyperglycemia is also important factor. And the cerebral hypoperfusion results from an increased cerebrovascular resistance due to the higher brain water content during the hyperglycemia, or to a loss of flow regulation caused by impaired metabolism. So this hyperdense lesion in putamen on CT brain is commonly found in this hemichorea hemibalismus with HHS, and the literature supports this type of involuntary movements in these patients presenting with HHS. And the functional alteration could be associated with some degree of Wallerian degeneration as well. And the internal white matter of the putamen is affected, and the protein desiccation occurring in the course of Wallerian degeneration explain the CT hyperdensities as well as the variable evolution of imaging features with time. This was published in the JAPI. And with this case, you leave aside the distal symmetric sensorimotor polyneuropathy, which all of us see every day. You leave aside the stroke, you leave aside the meningitis, you leave aside the cranial and the cranial mononeuropathies and the single mononeuropathies. but diabetes is responsible for a wide range of neurological manifestation. And this can be direct result of the metabolic disorders itself or treatment, which you heard Dr. Chandrasekhar speaking. The hypoglycemia is one of the very common cause with so many neurological presentations, and it can present with secondary manifestations as well. So overall, I'll touch upon these four categories. One is the acute metabolic decompensation. Second is the neuropathies. Third is the cerebrovascular disease. And fourth is the infections. So overall, the cranial knobs, roots, plexus, brain, spinal cord, peripheral knob, almost every structure of the CNS and the PNS can be affected. We know diabetic ketoacidosis, and though the person can be drowsy, but that the unconsciousness is very uncommon, but the patient can have seizures. We saw a case of hyperosmolar encephalopathy. Here, there can be involuntary movements, there can be seizures, and because there is some circulating insulin, we don't get the ketone bodies, the ketogenesis, but they are the people who present with the higher blood glucose, with drowsiness, with coma, convulsion, and also different neurological deficits like movement disorders. It may be adrenergic or it may be neuroglycopenic presentation, but can be associated with so many neurological factors, starting from the tremors, palpitations, headache, to the confusion, convulsion, coma, hemiplegia, and the restlessness. So all are possible in hypoglycemia. And you heard an elaborate discussion on this commonest complication of diabetes, which has involved so many neurological deficits together. One of the most common presentation is peripheral neuropathy. The leading cause is diabetes, and we see in 7 to 80% patients of diabetes with this peripheral neuropathy. Longer the duration, we get this deficit in type 1 as well as in type 2, and around 15% of patients have symptoms and signs of neuropathy, 10% present at the time of discovery of diabetes, and half of the patient have evidence of a neuronal damage by nerve conduction study. That is so common. And all of you see this story that the people have come after 5 or 10 years of the duration. The large fibers show loss of vibration and joint position sense, and the small fiber loss of light touch, pain, and temperature sensation. The pain, paresthesia, and allodynia persists. Weakness persists, and the ulcers and joint disease persists. So we see peripheral polyneuropathy, we see autonomic neuropathy, we see radiculopathy, we see plexopathy, the cranial neuropathies, and the compression mononeuropathies. So all type of presentations, varied presentations, and if you know that the person has diabetes, anything and everything in the nervous system will be possible. If you classify, you already we have seen the hypoglycemic neuropathy, the neurodiabetes description we have heard. The generalized neuropathies includes the sensorimotor polyneuropathy, acute painful sensory neuropathy or autonomic neuropathy, which will be listening after this talk. The focal and the multifocal neuropathies include the
Sir, your voice is not audible, sir.
I think he lost his internet connection.
Please call him over phone.
Priya madam, call him Jayant over the phone.
Sir, I have spoken to him. He is joining again, sir.
Chandra sir, அவர்கிட்ட பேசுனீங்களா?
பேசிட்டேன் சார், சொல்லிட்டேன். நீங்க ரெடியா
Okay,
இருங்க.
sir.
He said he would be joining.
Some technical issues. So he asked him to go to the next talk, so he'll join after that.
Okay, sir. Okay, sir.
Oh. Shall we go, sir?
You can proceed to the next talk, sir, please.
Thank you, respected D Club, for the wonderful opportunity, and also thank our president, our chairperson, our scientific committee, and also my dear friends for this opportunity. Now we are going to the next interesting topic, so-called as distress, diabetes, and depression. Why this topic is very important? This topic is totally interrelated, integrated, and interlinked. See, if this is the hypothesis of hominous octet by difference, so all the other 7 factors are spoken everywhere in all the symposium, but we are almost missing the neurotransmitter important hypothesis, because this depression will have the impact on the sympathetic activity and will lead for the chronic inflammatory state, metabolic dysregulation, neurohormonal dysregulation. It's bidirectional. Depression will provoke for diabetes, and diabetes will provoke for depression. So to talk upon more on this topic, we having a young and a dynamic speaker, Dr. Gauri Shankar now. So there are no need for any introduction by Gauri Shankar, because Gauri Shankar is a known friend for all of us. He's one of the chocolate boy for everybody. Without Gauri Shankar, there are no forum in Tamil Nadu. It's almost in all the forum in Tamil Nadu. It's a great pleasure and honor to introduce our close friend and my younger brother Gauri Shankar in this forum, in this August audience.
Yes, sir.
It's a major. I don't know when you wanted the AK-47, PK-47 like that, but he's wanted a lot of mics. It's a great physician diabetology institute of IIT Madras. He completed MBBS at Government Medical College, Chennai, and he served in Indian Army. Military decoration of 4 medals was. He's had a postgraduate training in Madras Medical College, Chennai. He did his IMA course of diabetology for the postgraduate, and more than that, he's a member of this one Indian Society of Anesthesiology, then AP and RSSDI. He has been a regular contributor to our prestigious Diabetes Journal Club, and also the Chennai Diabetes Forum belong to RP Rajesh. He has been training 20 paramedics in Chennai every year. As one of the prestigious organizing secretary of one of the prestigious conclaves, so-called as Bridge. There is every year they are conducting in IIT Madras, and he's almost since 7 years is conducting. So it's a great pleasure and privilege to welcome you, Dr. Gauri Shankar. Over to you now.
Sir, thank you, sir. Thanks for all those nice words, sir. Thank you, sir. Thanks a lot. Sir, thank you, sir. My screen is visible,
Yes,
sir.
yes,
I'm
no,
audible,
you are
sir.
audible,
Yes, sir.
visible,
Sir.
slides are visible.
Yes, sir. Thank you, sir. Thanks a lot for all those nice words, sir, Kannan, sir. So, respected senior faculties, Sundaram, sir, and everyone around there, I would like to sincerely thank Chandrasekhar, sir, for giving me this opportunity. My sincere thanks goes to Dhanamitran, sir, UV Mohan, sir, Natarajan, sir, Parandaman, sir, and everyone over there for this opportunity to talk on this topic, distress, depression, and diabetes. Over the next 25 minutes, when we are discussing on this topic, we will just roughly go through the history of Mrs. Ramanamma. This is again a real life case. She is aged about 62 years, diabetic for the past 8 years. And she's on OHS and premix insulins with antihypertensive and being treated as stable cat. Her fasting postprandial blood sugars, whenever she comes for an examination or whenever she comes for a review, are all normal. But her HbA1c roughly hovers around 10 to 12, which shows that there is some non-compliance to therapy. So this is what is going with her for past an year or so. Her personal history goes like this, like she has lost her son who was 8 years old then. Means when about 50 years back, like when she was 45 years or back when she was young, she lost her son, and she keeps remembering him every time she visits for her during her review. Recently, she had a physical assault by her husband, and she was on bed for quite some time, and she suffered by fractured D4, but now she is recovering well. This is her condition a year back, and a month back she went for an ophthal review, and the ophthalmologist said there are some bleeding vessels and she needs to undergo the procedure. She's much worried about the cost. So these are the other histories as far her personal life is concerned. So what are we dealing with our patient? Is it just a grief, an extended grief because of her son lost? Or is it a distress? Is there a dysthymia or a post-traumatic stress disorder? Are we just handling with depression? So how to differentiate all these things? These are almost synonymous terms, and we need to know what is the different DDs for this, like so that we can just go with whether the patient is just going for a depression or not. Grief is something like which lasts for a very shorter period of time, especially when someone near and dear is lost in the family. Grief goes on for about 3 months or so, and the patient generally recovers on their own. One differentiating feature of grief from depression is generally the self-esteem is very much preserved in grief. So self-esteem preservation is lost in depression. So that is the most important thing that we need to know. Does she has distress? So distress is something like whenever there is an acute untoward event happening. So it could be just the ophthal review as it happened in this patient. So distress is very short-lived. It lives for about, it lasts for about 15 days or so because of some underlying event, and it is an emotional response. It could be just a food complication. It could be just a fight with some of the family members. It could be just something unpleasant happening in the workplace. So distress doesn't last for a longer period of time. Typically, it doesn't last for more than 15 days. So distress is very sort of an emotional response lasting for a very long period, a very short period. Rather, on the other hand, dysthymia is something like a mild depression. So a mild mood disorder, but it persists for a very long period of time, say about 2 years or so. We don't call it as dysthymia if it lasts less than 2 years. So, but it is a very low mood disorder. So generally their quality of life is not lost, but they look slightly withdrawn and all. Post-traumatic stress disorder happens with some trauma in the life. It could be just an accident or exposure to violence or some traumatic events. And the people keep waking up in the night with lots of palpitation, sweating. And whenever they think about the event, again, they will present with these autonomic symptoms. And they try to withdraw the place. Say if there is an accident, they will avoid car. If there is a bus incident, whenever they see the bus, they will remember the events, or any sort of physical abuse or anything. So they try to forget the evoking factor or the provoking factor of the incident. So this is what post-traumatic stress disorder. Whereas in depression, it is something which negatively affects how an individual feel, think, and act. So depression is totally a different thing. It negatively withdraws the patient. So from everything that they do, that they think, that they respond. So everything, it is affected, and the quality of life is taken for a toll. It totally affects them. So for some of us who want to really appreciate what depression is all about, I would urge everybody to watch this small video. It's just a 4 minutes video by the name I Had a Black Dog. His name was Depression. So black dog and depression, as we go into Google, this 4 minutes video comes in. It just looks at how the black dog is taken as a symbolism of depression in this video, and how this black dog, the depression, engulfs the individual and makes him to sulk and to get withdrawn. So that is how it is shown. A beautiful video for us to understand what a depression, or how a person with the depression feels or looks or withdrawn from the society. So why all these things comes about. So this is something which we all must watch. So this is what depression is all about, and we can differentiate between the various things. But why should a diabetologist be worried about depression? Why should I need to know about depression? So any chronic medical disorder, it could be just an hypertension or a CAD or a heart failure or a CV or a stroke or end stage, any chronic medical disorder, when they present, any medical disorder, there is a higher predisposition for, or a higher odd ratio of developing depression in the patient is always there. So here, as you see, like any medical disorder, the odds ratio is about 2.61. If there are many medical conditions, the odds ratio increases. If there are three or more conditions, they are 6.5 times more prone for depression than a single condition, like be it, say, hypertension alone. If the patient has 3 or more medical conditions, they will be more prone for depression. So with this understanding, diabetes is not something like just a medical disorder, because diabetes and depression coexist. So there are beautiful meta-analysis which all review at it, how the incidence of depression is increased among the people with diabetes, and if in depressed patient, the incidence of incident diabetic is also increased. So either way, it is true. So diabetics are more prone for depression, and depressed patients are also more prone for diabetes. So it shows there is some common soil hypothesis which is happening between diabetes and depression, but we are not able to see at the molecular level what is the reason. Some of the reasons, like Chandrasekhar sir earlier said, it could be mediated through HPA axis, where the steroids coming into play, or there is an activation of the innate immunity and the inflammation which happens, which predisposes to both the things, both diabetes as well as depression. Or it could be just mediated through circadian rhythms, or the cellular changes which happen because of insulin resistance. So any of these things can predispose, but we really don't know till now what is the reason that depression and diabetes coexist. But what is important is, when depression and diabetes coexist, so as shown in this data, when a person has diabetes alone, when we see the mean health score, so people with normally who present to the practice, it is a huge robust data of about 240,000 people across 6 continents and 60 countries, and 5 Asian countries were involved, including India, where they looked into the mean health score of the people without an ailment. Like it could be the baseline is taken as 90 over here. When the patient presents with the diabetes, the health score is about 78. When the patient has a depression, the health score is about 72, almost similar. But when the patient presents with both the depression and diabetes, the quality of life takes a big toll, where the health score dips by 20 points to 58.5. So it is very, very important for us to recognize when a patient has got a diabetes, whether the individual has got depression or not, because if depression exists, his quality of life is getting very much impaired. So not only the quality of life, it is important for us to recognize depression in a patient having diabetes. So if 100 patients are visiting our clinic every day, 70% of them won't have any problem at all. So neither they will have, I'm talking about the diabetic patients, so neither they will have a distress nor they will have a depression. But 15% of them will have a distress. So this distress, this acute response, as I said earlier, so this distress can be addressed either by the family members or friends, or by self-education, self-motivation, or by when we reassure our patients when there is a distress, the patients come out very, very well. So these are the people who are having distress and has to be addressed with good psychotherapy or a motivation. The patients do very, very well. But what is important is the remaining 15% of the people who may have a coexisting depression. We need to know that these people have depression and we have to treat them. So why is it important is because of this vicious cycle which happens over here. If the patient's glycemic control is poor, like it happened in our patient with an HbA1c of 12, he goes for a diabetes distress because the doctor says like you have an ophthalmic problem, your sugar has to be controlled, you have a bleeding vessel, and also your sugars are not controlled for a longer period of time. So the patient develops distress. So there is a direct link between distress and glycemic control always is there. So this leads to this and this leads to this. That is always there. But the association between glycemic control and depression is indirect, because if the patient has a depression, what is happening is it affects indirectly through diet, exercise, medical adherence, and sleep, because the patient is not going to take food adequately. Either he is going to overeat or he is going to undereat. Overeat will cause hyperglycemia, under will predispose him to hypoglycemia, reactive changes, and he may overeat again. So he's not going to maintain. Exercise he may not be doing because of the coexisting depression. And medical adherence, obviously, like it is happening in our patient, will not be there. Sleep is going for a fix and the quality of life is going to get affected. So depression causes through this pathway, and then it causes a poor control of glycemic control, and then it takes a bearing on the diabetic distress, and this becomes a vicious cycle. At some point of time, we need to address this. So to screen the individuals at this stage and address their depression. That is very, very important. So this is the reason why we need to know whether the patient has got a depression or not. How am I going to screen in primary care? So the screening in primary care is very, very important. We can go by this famous mnemonic like SIG-E-CAPS. SIG-E-CAPS is the one famous mnemonic which we all should know. S stands for sleep, I stands for interest, G stands for guilt, E stands for energy, C stands for his concentration, A stands for appetite. Appetite may be increased or decreased. P stands for psychomotor disturbance. Again, that can be increased or decreased. S stands for suicidal tendency. So this is a mnemonic which is commonly available in the net. So when we take a history in our patient, so we can ask about all these things. How is your sleep? How is your interest? How is your guilt? How do you feel energy? So we can take a simple history, but this is not the objective way. Just to see whether our patient is having a depression or not, we can involve all these 8 things in our patients when we take a history. So SIG-E-CAPS is the mnemonic that we can practice in our patient. 2 things we need to know is whether the patient has got a bipolar disorder. So bipolar disorder, whenever we suspect, like we should understand, the patient may have in a bipolar disorder a complete manic episodes. He might be feeling all the time manic. So that is, again, it is called manic bipolar disorder, or without any depression. The patient may not have any depression, but constant manic episode. Still, it is a bipolar disorder. It is not a unipolar disorder. Or the patient may have one episode of mania, but several episodes of depression. So 1 episode of mania, several episodes of depression, still they quantify as a bipolar disorder. So what is important is whether the patient is having a manic episode or not is very, very important, because the treatment for the bipolar disorder is totally different, because they have to be given mood stabilizers and we cannot treat them in primary care and in a diabetic clinic. So recognition of bipolar disorder makes a huge difference for the treatment of patients. And second thing that we need to ask our patient is whether there is a suicidal thoughts or not. Just by asking, the patient will not be predisposed to have any suicidal ideation and all. Please ask specifically whether they have suicidal thoughts. Whenever we ask suicidal thoughts, also ask whether you have plan. If so, what is the plan? So these three questions has to be again involved. Or we can go to this PHQ-2 questionnaire. So either we can go by the history as we said, or PHQ-2 questionnaire. PHQ-2 questionnaire has got a good sensitivity of about 96% and specificity of 57%. Very, very valid score. Only 2 questions we need to ask and fill up where the patient fits in the past 14 days. So when we ask, how do you feel? Do you feel down, depressed, or hopeless? So are you feeling depressed? And for the past how many days you are feeling? So in the past 14 days. So we can fill up over here as it is given here, like not at all severe, more than off days, nearly every day. Or do you have little interest or pleasure in doing things? So that is the second question. Whatever you feel happy about, it might be bathing, cooking, talking to your wife, talking to the kids, watching YouTube, whatever that gives you pleasure or in interest in doing things, is it giving you happiness or not? So when we fill up these things, when the score is more than 3, so for both the questions, if the score is more than 3, we have to do either by history or by PHQ-2, we have to fill up this elaborate questionnaire, which is called as PHQ-9, which is very widely available in the net, validated for all the languages. So we should ask people to do this PHQ-9 depressive questionnaire. So if you do Google that, they can fill up in the net itself, and it comes up with a score. 1 to 4 is normal, 5 to 9 is mild, 10 to 14 is moderate, 15 and above is severe, 20 is very severe. So this is how we have to know. But definitely one thing we need to do is PHQ-9 questionnaire, depression questionnaire has to be filled. It helps in the diagnosis, it helps in the management, it helps in the prognosis of the patient. So which is very, very mandatory to do all these things. When it comes to treatment, we can choose among the various drugs which are available. Tricyclic antidepressants like amitriptyline, we can choose when there is a coexisting unexplained headache or when there is a neuropathy. Other than that, we don't use tricyclic antidepressant much for depression nowadays. We can choose between SSRIs and SNRIs. Citalopram and escitalopram is after the STAR-4D trial, STAR-D trial. We have so much confidence. Very well studied drug is citalopram. Sertraline is amazingly good. Most studied antidepressant is sertraline. Because the duloxetine and fluoxetine also finds a very good acceptance among our patients, especially when the patient has got some foot complication or there is a fibromyalgia associated duloxetine scores than other drugs. So we can choose between these 4 or 5 drugs. Venlafaxine we have been using for smokers and all, and the suicidal tendency with venlafaxine has been now cleared without any doubt. So among these 5 or 6 drugs, we can choose 1 or 2 drugs and start using it and gain confidence of using which drug suits the patient and which drug suits ourselves also. There are meta-analysis to show that there is much difference between all these drugs. We need to know like which drug we are confident of using and how to use it. The 3rd generation drugs between mirtazapine and bupropion, both the drugs are amazingly good. Whenever there is an associated sleep issue, if the patient is not able to sleep, mirtazapine scores over the other drugs. So sleep is a problem. Mirtazapine, among the 3rd generation, mirtazapine scores. But also we need to understand in our diabetics, it may make the patients to gain weight. So it may not be preferred drug if they are going to gain weight. But bupropion, when there is no sleep problem, because it makes them awake. So bupropion is extremely good. There is no weight gain with the patients. So as far as the sleep is concerned, it doesn't cause sleep. So if sleep is a problem, if the patient is not able to sleep, then mirtazapine is the choice. If the patient is able to sleep well and sleeplessness is not the problem, then bupropion scores. Bupropion is weight neutral, rather it makes the patients to lose weight also. And the 3rd thing is bupropion acts very well, especially these SSRIs and SNRIs have an associated erectile dysfunction. Even like putting the patients who are on sertraline or duloxetine and causing some amount of erectile issues. So bupropion blocks that effect. So it makes it nullified. So that is the biggest advantage of bupropion using in healthy people than among the other drugs. So when we choose these drugs, citalopram has become very much accepted. Every one of us have started using like 10 drugs, 3 diabetic drug, 3 cardiac drug, antiplatelets, 3 multivitamins, and 4th, 11th drug or 12th drug. Most of the prescription pattern has in such a way that they started writing some Nexito plus Nexito, all these things. So it has become so common in our practice without even knowing like whether the patient is going on for depression or not. People have started putting it just like that. So citalopram has become so much of acceptance, but we need to understand there is a risk of QT prolongation, and torsity point is always there with citalopram, not to exceed 40 mg, and if elderly, 20 mg is the accepted dose. And always use citalopram when there is a congestive cardiac failure, bradyarrhythmia, or hypokinesia. So remember that when these problems are there, we should not use citalopram. The difference between mirtazapine and bupropion, we have already told. The incidence of sexual effects is more than 30% with cetalin, but then that can be blunted with the use of bupropion. So when we call a drug as failure, so we have to use it meaningfully, at least for about 10 weeks or so before calling the drug as a failure. And the maintenance phase should be at least for an year whenever we use this drugs. Recently, even 3 months back, there was a study in NEJM which said like when antidepressants are used by primary care physicians, they try to withdraw it earlier, thinking that the depression has been addressed. So that is a point where they make a biggest mistake. So at least give for a meaningful period of 9 months to 1 year for a meaningful effect in the patient. Don't try to withdraw it in a early phase. And PHQ-9 questionnaire is one thing where we can use this questionnaire for monitoring the patient, see whether the score falls by 5 or so in a period of 1 month. So always we have to call the patient in 14 days to assess how they are doing. They might be still anxious. So because these drugs are so prone to cause anxiety also. So it is okay to reassure them if they are feeling anxious, because for anxiety also we use the same drugs. So, but reassure them, even if there is an anxiety, reassure them that it will become normal. So it becomes normal over a period of 1 month or so. So give a meaningful period of 1 month for the drug to take its effect, and see whether the PHQ-9 is falling by 5 or so. So if it is falling by 5 counts, so it means that the drug is counting well. If the score reduction is less than 2, you can consider either upgrading the drug, or there can be a change in the drug from one SSRI to another SSRI or an SNRI, or we can add another group in the 3rd generation with bupropion or mirtazapine. This based on the confidence we can go about it. So there are some treatment gaps. So having diagnosed, having screened, having started on the drugs, there is some treatment gap which always exists on that. The treatment gap is cognitive behavior therapy. Whenever we talk about all these things, we always, when we look on the guidelines, something which is being missed is, or something we just overlook is, the treatment for depression or an anxiety or most of the psychiatric illnesses, cognitive behavior therapy. So, but we don't, not many psychologists are doing that. Many psychiatrists don't have time to do that. I will just briefly, for the sake of interest of the audience, I will briefly tell what does this cognitive behavior therapy is all about, and why is it not being practiced? Because it is a very structured session. So cognitive behavior therapy, every week the patient is made to sit for 1 hour, and it goes in a very structured way how the counseling is done. It is not like a counseling where negative thoughts are replaced with the positive thoughts, or the thoughts are identified and they are replaced, or counseling where only advice is being poured on which the patient is not able to accept. It is not that way. It is a very, very structured way to see how the patient thinks, acts, and does the work and executes the work. So that is how cognitive behavior therapy goes. Now let us see, like let us presume an example. So some idiot is there is one day when I was taking bath. So when I was taking bath, I was getting a call. So who is calling me over the bath, like he's not letting me to take bath. So again, after 2 minutes, I'm getting another call. So I was a little bit getting irritated, like, why is he calling me again? So after 3 minutes, again, I get a call, like I become furious, like, who is the hell who's calling me repeatedly again and again? And after 3 minutes, again a call. So I'm thinking like someone is not, is calling me again and again. I become very furious and come out of the bathroom and to see the phone, like what is happening. So when I come to the bathroom and see, it is 3 or 4 different people who have called me. It is not from the same number. So what is the problem which is happening over here is, I am into a prefixed belief that if the call comes regularly, it is from the same person. So I am presuming, it is my thought process, it is my belief that I am thinking that it should be from the same person, which is the reason for my furiousness, angry, and tying the towel and coming out and see like who is calling me again and again, and I'm so furious. So what is the reason for this furious? It is my belief, my thought process. So there is an antecedent thoughts or fixed beliefs that I believe that somebody is calling me again and again, and I become furious, and the consequences, I come out and see like who has called me again and again, and become cool within a minute. So the reason why I become furious is all because of this thought process or fixed belief system which had happened in the mind, and the moment it is cleared, all my furiousness has gone down. So this is what cognitive behavior therapy tells about. So everything that is happening as a consequence is all because of the belief or the fixed thought process which happens in our mind. So these fixed thought process are made to be identified by the psychologist or the psychiatrist, by the patient, and they try to identify these thought process and look into the real effect that it happens when these thought processes are identified. So for that, the patients are made to monitor something called as thought record. So how does the thought record comes? It is something like a migraine record for our patients. So the patient, whenever they feel irritated, depressed, annoyed, whatever the worst emotions that they undergo, the patient at the end of the day are made to mention those thought process, like I am feeling annoyed, deprived, or irritated. So there are some situations where the patient might be annoyed, irritated, or depressed. So the situations the patients are made to mention, and the automatic thoughts or the belief system that goes in their mind are recorded. And the psychiatrist or the psychologist later sits with the patient and makes them to understand what is going on during that time. I'll just take a simple example. So here comes this is a real life patient. The patient comes with a broken floor wash. I think I have 2 more minutes. The patient comes with a broken floor wash, feels very irritated. Why am I not able to even shift this floor wash? So am I not able to even do this small thing in my mind? So that is an automatic thought that goes in the patient. So the meaning of this automatic thought is, I am helpless, I am out of control. So that is the meaning that the patient drives out of this. So the belief system happens. So just because I am not able to lift this floor wash and shift it to another place, and I have got it broken, I'm helpless, I'm out of control, I'm not able to do all these things. So this is the core belief. Because of this automatic thought, they start believing that I'm helpless, I'm worthless, I'm useless. Then the patient starts having coping strategies. What coping strategies the patient develop? If I avoid doing this work, so let me not lift this floor wash anymore, or let me not cook anymore, let me not wash anymore, I will be worthless, I will not be able to do this work, I will not be able to wash this cloth. So they start withdrawing from their productive work. So one single trigger had made them to feel helpless and out of control, and they are start withdrawing from everything. So this is what is happening in depression. So what should we do? Here there comes a strategy called as a Socratic thinking. Socratic thinking is identifying this scene and make them to introspect and ask, has it happened every time with this floor wash? How many times have you lifted this floor wash? How many times you have done the productive work? So making them to realize this is an one-odd event. So this need not be carried, I'm not always helpless or worthless. There are many good things I have productively done. And to understand this thought process is what Socratic thinking gives. So when we do all this questioning, so Socrates was questioning everything, no? So like that, we try to make the patient question their thought process, and this questioning makes them to feel the other side of the thought process, that they are not so worthless, that they are not so useless, that they are not so unproductive, and make them to gain confidence. So this is what goes in a cognitive behavior therapy. It takes about 1 or 2 hours for us to explain the entire process, but this is the gist of cognitive behavior therapy. So if you want to really know about CBT, one movie that is worth seeing is Dear Zindagi, where Alia Bhatt, who is a Generation Z female, is helped by a young dynamic psychologist, Shah Rukh Khan, who poses very clear, intelligent Socratic questioning and make her to understand and come out of her depression and thought process. But if you want to professionally learn something to learn about this is a book which is written by Judith Beck, the daughter of Beck, who invented this cognitive behavior therapy. Extremely good book and worth knowing. So when having done that, so we need to refer the patient when their patient is not responding to different drugs, 2nd generation or 3rd generation. When they are not responding, we have to refer. If there is a suicidal ideation, as I said earlier, has to be referred. If there is a bipolar disease, has to be referred. Psychotic features has to be referred. Comorbid, other Alzheimer's or other coexisting medical conditions are there, or if there is a patient preference, the patient has to be referred. So the last minute, the patient, with what happened to our patient, so she was started on antidepressant, she was doing very well, but the prognosis was really not as marked. She was started on the 2nd drug after 3 months, and she improved, and within 6 months her life is back. And without modifying any medications, her HbA1c came down to 7.8 or 7.9 with good amount of cognitive behavior therapy. It didn't extend beyond 6 weeks, and she was doing well, and the drugs were withdrawn, and she is extremely productive even at the age of 63 and 64. So diabetes and depression coexist. PHQ-2 is the questionnaire we need to use for screening or SIGI caps. PHQ-9 for diagnosis and follow-up. Know the drugs. So what drugs we are going to use. So second and 3rd generation, which one we can choose. And CBT is a very, very useful tool, which may help even in our brief intervention, but it is worth knowing and reading about all these things. With this, I conclude and thank for the opportunity. Thank you.
Thank you, Gauri, for the wonderful talk. It's an elegant talk and the informative talk also. And also you nicely alluded the pathogenic link between the depression and diabetes. I think in 17th century itself, Professor Thomas Villaric highlighted the importance of diabetes and depression. He told that diabetes is a consequence of the prolonged sorrow. It is linked to the mental illness and diabetes. Our Indian RSS, they also they're making some conclusion over, because last November only they made as the glucose as the 5th vital sign. They're considering the depression also one of the 6th vital sign in the diabetic patient. Very informative lecture. We enjoyed the lecture. We have given all the important markers regarding the scoring system in the depression, and also you covered the important pathophysiology link between the depression and diabetes by means of hypothalamic pituitary axis and neuroendocrine mechanism of action, and also metabolic dysregulation. Thank you, Gauri. Chandra, any questions from you, sir?
Yeah, I think it's a good talk, nice talk, illustrative talk by Dr. Gauri Shankar. In fact, it fills up we are getting some awareness on the treatment gaps, like in the management of patients with diabetes. I think if we have that kind of holistic approach, definitely it would help us to improve the outcomes of the patient. I think we have some questions with us, diabetic neuropathy and hypertrophy. I think. Okay, yeah.
Gauri, can I have one question?
Yes, sir.
You were telling about the scoring system for the depression. Any scoring system for the distress you have, Gauri? Distress.
There are some scoring system like WHO5 and all, sir. So these are all we cannot basically score it, sir. So means it lives for a very short period. So distress is something where the emotional factors come into role. Say something untoward happens, we become distressed. So something unpleasant happens. So we become distressed. So the scoring system like WHO 5 and all, it looks into the various parameters, but very difficult to score it and attribute it to diabetic distress. So generally it is attributed to the coexisting illness. Say if the patient comes with a foot ulcer, or if the patient has got an MI. So the 15 days he will be distressed, but he will come out of it. So if he has a foot and it is not healing, he will be distressed, but he will come out of it. So distress is something like emotionally how we look into it, but it is very difficult to quantify. That is what literature says. Though there are some scoring systems, doesn't help actually.
Gauri, in type 1 diabetic patient, I think it is very difficult to go for the psychologist opinion, psychiatrist opinion, because that patient will not tolerate the antipsychotic molecules. So in that case, the behavioral thoughts, you told about the negative thoughts and positive thoughts also, any relationship between the thoughtful messages for the type 1 diabetic patient to overcome the depression, because most of the type 1 diabetic patient will have some sort of depression because they have to take insulin 3 times, 4 times, they go for hypoglycemia, they couldn't be able to eat anything. So in that case, whether the positive thoughts and negative thoughts, I think will may be helpful to overcome the depression and distress also among the type 1 diabetic patients.
Sir, there are some online CBT manual also. There are good books on CBT doing for self. So it need not be intervened by doctors. So we can also get trained in CBT as an individual and we can work on that. So self CBT, that is possible. So there are good courses on it. Great Courses has got a CBT course. There are some good CBT books on CBT for dummies, or there are books like Feeling Good, which works on CBT based principles for self. Like Feeling Good is a very good book. So something like that, the patient can read and reorient their thoughts. So this is also possible. It need not be always like if the patient has got depression, a counselor will help. If the patient doesn't have depression, but they want to control their thoughts, their attributes to the consequence, so they can undergo a self-CBT. There are some online portals also available. Some European portals are available for free. So they can just enroll and it helps them to find out the wiring, where the mistake happens and how to identify and how it can be controlled. So it can be done on self also. So CBT has not been spoken a lot, which should be.
I think what Gauri has said, right? Like, so we would be concentrating more on the therapeutic part of it. Like, so we'll be when somebody is looking distressed or depressed, like we'll be more concentrating on the anti-anxiolytic or antidepressant part of it. Like, of course, it does have some metabolic adverse effects also in the long run too, which already Dr. Gauri has mentioned. Dr. Sundaram sir would like to say anything, sir?
So you are muted, sir.
Unmute, sir. Sir, your voice is not heard. Kindly unmute, sir.
All right.
Yes, sir.
Gauri, it was a very nice lecture. You opened the eyes of all the physicians.
Sir, thank you, sir.
And Dr. Banting and Best, when they were in the lab, the dog goes in for hypoglycemia, they thought in the evening, say late before going to bed. Both of them are in the lab. At that time, they have given the hope, and they were in depression, and Banting was sitting on a chair and sleeping, and this fellow Best was on the operating table, and he was sleeping. And around 5 a.m., the dog gets up and wakes them up. At that time, you can see the joy in them. So there will be always a joy. Only thing you'll have to wait for it. So one Dr. Sekhar from Coimbatore and Dr. A. Ramachandran, both of them have psychiatrist classes for diabetic patients weekly once. And newer patients or older patients, whoever require, they're asked to come on a Sunday. And these two doctors, they will give opinion on them. They will tell stories and then make them all right. So I think they also form a part of our treatment team. Not only educationists and others, dietitian and things like that, you must have these people also. Regarding hypoglycemia, this dog hypoglycemia reminds me of whenever we see a patient with hypoglycemia, we should not reduce the blood sugar to near normal level. You should keep it always around 200 milligrams. Okay, around 200 milligrams for 6 weeks. So the recovery of the cell, somebody was asking you the questions, why it was so much delayed and all. It takes for the neuroglycopenia to be recouped, it takes about 6 weeks. At that least called hypoglycemic memory. I just wanted to add. Thank you. Thank you for the opportunity.
Thanks, sir. Sir, one point as Chandrasekhar sir has told, so that we need to remember is we always concentrate on drugs. So there are very, very good, fantastic studies, good randomized controlled studies which have shown exercise is as good as pharmacotherapy.
Very good.
As far the depression is concerned. So exercise without any drugs, exercise has shown a good exercise of physical activity has shown a good control on depression, good randomized control trial. Second thing is cognitive behavior therapy is as good as exercise and as good as pharmacotherapy. So
very good.
All these three things are very important. We should not, just because we have the power, we should not build only on the drugs. We should ensure that the patient is walking or doing some physical activity under supportive cognitive behavior therapy. So the drug requirement also will come down. So this is something which we always remember as far as depression is concerned in our patient.
The extra few minutes we spend with the patient definitely will make the patient to do well. Like, of course, non-therapeutically, we can approach those patients with some kind of behavioral therapy and exercise and indulging in some mind exercises and so on. Like, definitely, it's a worth doing in our busy clinical schedule. Like, so I used to engage one of the successful patient as the teacher to the patient group meeting. Like, so they would be instead of me talking to the patient, like a successful patient would take good take-home messages to everyone. So I think it's a wonderful lecture by Dr. Gauri. We move on to the Dr. Jayant Panda's lecture, which got disconnected due to some technical issue. Over to Dr. Panda.
Yeah, thank you, Dr. Chandrasekhar. Actually, I had some technical glitches. I'm very sorry for that. But I enjoyed the presentation by Dr. Gauri Shankar, eye-opening lecturer on diabetes and depression. We come across these issues daily, and as rightly pointed out by Dr. Sundaram, a psychotherapist, a psychologist has to be a member of the team. Like we keep a podiatrician, like we keep a counselor, educator. So somebody has to talk to them, and it's very important that we understand their minds. So I'll be very quick. I find most of the questions are meant for me only. People thought that the neuropathy talk is going on. So we'll finish up the presentation and take up the questions. Maybe another 5-10 minutes will be adequate for me. My slides are there.
Yes.
So symmetric polyneuropathy, we're discussing the distal sensory or the sensory motor, small fiber, large fiber, and autonomic. And asymmetric neuropathy, cranial, truncal, limb mononeuropathy, asymmetrical, proximal, and motor. And if when there is a combination, it's polyreticular neuropathy, diabetic neuropathy, cachexia, and polyneuropathies, which all of us have come across. This more or less discussed by Professor Chandrasekhar, the hyperglycemia leading to the capillary pathology, increased nerve glucose or fructose leading to increased nerve sorbitol, ionocetal, and the nerve sodium potassium ATPase, the decreased axonal transport leading to the axon atrophy, decreased nerve condition velocity, and the tingling and the numbness gradually deteriorating in the diabetic neuropathy, and the metabolic alterations leading to the vascular dysfunction, leading to reduced endoneurial oxygen tension, and the hyperglycemia together leading to increased polyol pathways and the oxidative stress, and the non-enzymatic protein glycation leading to the alteration in the neurotropic support causing the diabetic neuropathies. We know this mechanism very well, and the hyperglycemia, I'll spend half a minute here. Hypoglycemic neuropathy, the patient newly diagnosed, we see a very high blood glucose, like 500, 600, uncontrolled glucotoxicity. So these people are poorly controlled and they experience uncomfortable dysesthesia or pain in the feet and the lower leg, rapidly resolved with the establishment of the euglycemia. Once the blood sugar is controlled, there are many abnormal subjective and objective findings, they subside. And then the diabetic nerve is known as to be hypoxic. And experimental studies has already proved this, and the nerve conduction velocity is reduced in poorly controlled diabetic patients and recovers rapidly with the correction of the hyperglycemia. So clinically, we get large fiber neuropathy, the painless paresthesia, decreased vibration and joint sensation, and absent deep tendon reflexes, small fiber neuropathy like burning, shooting pain, the decreased sensations, and preserved deep tendon reflexes and the autonomic changes. So broadly, you can again classify them as large fiber and small fiber. And this is a very common presentation, the Brown-Garland syndrome, where you get asymmetrical proximal motor neuropathy in an elderly patient, acute or stepwise progression with severe pain, low back, radiating to anterior thigh, and the nerve conduction shows reduced amplitude and femoral lobe. So the truncal neuropathy is very common and affects T4 to T12 roots. The cranial neuropathy affects third, common with pupillary sparing, sixth, fourth, and seventh cranial nerve also involved. There are questions related to this. I have already shown in the chat box. The limb mononeuropathy, like mononeuropathy affecting acutely, the entrapment neuropathy gradually, the classical example is the carpal and the tarsal tunnel syndromes, and the mononeuritis multiplex, all of us have seen. This is a patient with sixth cranial nerve palsy, and this cranial neuropathies result in diplopia and very common, this painless neuropathies we see in our patients. So acute painful diabetic neuropathies are uncommon syndrome, which is distinct from the diabetic sensory polyneuropathy. It's of acute, subacute onset and characterized by burning or aching pain felt mainly in the lower extremity, and because of the long axons, it starts from the foot, rarely in the hands over the upper limbs, and then its accompanying neurological signs are often not obstructive with only slight distal sensory loss. The treatment is by strict glycemic control, even in those cases where there is a precipitated by treatment. After we start treating and controlling the blood glucose, few cases it requires insulin therapy because of worsening symptoms of diabetic neuropathy. But the recovery usually occurs over a period of 6 to 9 months. And the most important message goes that the blood sugar control, the patient when becomes very euglycemic, most of these presentations are controlled. So we have the presentation of autonomic neuropathy, which is following. I'll just take 1 minute to touch upon, because so many important features, clinical presentations and complications are associated with autonomic neuropathy. The painless myocardial infarction or acute coronary syndrome, the postural hypotension, syncope and arrhythmias, the abnormal esophageal motility, the gastroparesis, and the bladder dysfunction and sexual dysfunction, the dry skin and decreased sweating. So many presentations affecting almost all systems are because of autonomic neuropathy. And these clinical features, they prompt you, maybe any of this which you have already discussed from all the systems, skeletal, eye, respiratory, GI, genitourinary, pseudomotor, cardiovascular, neuroendocrine, all presentations may point you to the autonomic involvement, which is more common. More is the A1C, more is the blood glucose, poor is the control. So maybe postural hypotension, resting tachycardia, or sudden cardiorespiratory arrest, the dysphagia, fullness, bloating, constipation, nocturnal diarrhea are very common. You may give tons of PPI, but patient keep on complaining the dyspepsia and the bloating, and then you suspect, can it be a case of diabetic autonomic gastroparesis? So the incontinence, the impotence, the anhidrosis, the dependent edema, many times we think of diabetic kidney disease, but the whole thing is because of the vasomotor autonomic dysfunction, and you get dependent edema. So there may be meiosis, there may be delayed light reflex, and many other related symptoms. So with this, we'll come to the treatment part. We know that the treatment is very unsatisfactory, and I have told about the glycemic control. It focuses on slowing the progression of the disease, relieving the pain, and managing complications and restoring the functions. So generally the blood glucose and the different parameters like blood pressure, thyroid, lipids, they are put on the control, and the patient is asked for a restricted lifestyle, especially when a patient has a fluid neuropathy regarding the morning walk and his regular habits. He has to be doubly careful. So what helps to slow the nerve damage? You have to follow the good foot care, because the neuropathy starts from the foot. You have to reinforce that. You have to follow the good foot care, keep your blood pressure under control, the healthy eating plan, plenty of physical activity, maintaining a right weight, stop smoking, avoid alcohol, and then if at all the person is taking, to take in moderation. So the tricyclic antidepressants like amitriptyline, the desipramine and the imipramine provide relief from mild to moderate pain. And remember, they give relief from the pain, but the pathology may not be reverted very soon. The patient may complain of dry mouth, sweating, weight gain, constipation, and dizziness once you start these tricyclic antidepressants. The SNRIs like serotonin and norepinephrine reuptake inhibitors like fluoxetine can relieve pain, and we have all successfully used this, but it can have nausea, sleepiness, dizziness, decreased appetite, and constipation. You have to ask the patient to continue with patience for some time, and it may disappear. And the anti-seizure drugs like gabapentin, the pregabalin, the carbamazepine are used to treat the neuralgia, and again they can have drowsiness, dizziness, and the swelling. The alternative therapies, the capsaicin, the counter irritants made from the chili peppers, the physical therapy, the acupuncture are also used for this very debilitating neuropathic pain. But the central theme is the good diabetes control, and the paresthesias, the tricyclic antidepressants, the imipramine and amitriptyline and newer antidepressants are very useful at times, and the shooting, stabbing pain are subsided by carbamazepine, phenytoin, gabapentin, and pregabalin, and these are the mostly used drugs in diabetic neuropathy, especially the peripheral. The symptomatic orthostatic hypotension, you have to keep the head up, tilt position, give increased salt, the elastic body stockings, and the fludrocortisone. You'll listen in detail in the autonomic chapter. The gastroparesis, the prokinetic drugs, the diarrhea, you can use tetracycline, and the atonic bladder, the bladder neck resection is recommended in important patients. The sildenafil, the papaverine injections, and the penile implants are used at times. So last few slides regarding the other forgotten neurological complications of diabetes. Stroke is very common. It's the third killer in the US, and 4 to 6-fold increase in the risk in diabetic patients. And we know how many stroke patients we treat in our medical wards daily. It causes almost 25% of diabetic deaths. 1/4 of diabetic deaths are by stroke. The worst outcome and the increased mortality in the stroke patients with diabetes, and the hypertension, the hyperlipidemia, the cardiovascular illness, the smoking, the joint diabetes in killing the patient. The hypertension and atherosclerosis are basic pathology. The lacunar stroke is most common, and then patient have silent stroke in many often, and then this particular people have the cognitive impairment, which we are discussing in elaborate sense, and we'll be discussing in future topics as well. So I'll end with the infections. The infection of the central nervous system and the different CNS structures are not uncommon in this COVID time. You've seen the mucormycosis, and the diabetic ketoacidosis is a predisposing condition where you get facial pain, swelling, nasal obstruction, the proptosis, and tend to invade the blood vessels and leading to thrombosis. And then the malignant external otitis is again a common complications, and then very specially accompanied in diabetic patients. The emphysematous infections, the external otitis, and the mucormycosis, they cause the mastocytitis, the intracranial extension occurring, leading to the multiple cranial nerve paresis, the sinus thrombosis, and the meningitis. Many times we don't realize this is the sepsis which has resulted. We think it's vascular, but it's very common. And here is a case with which I'll be ending. We started with a case of involuntary movement. Here is a young man, a 15-year type 1 diabetic, who had the purulent foul-smelling discharge from the nose, presented for almost 3 months, presented with halitosis, the diplopia, the double vision, the headache, and had ptosis of the right eye and right third knob palsy. Pupil was 4 millimeter right, and then the extraocular movements restricted in upward and the medial direction in the right eye. You can see the picture of the child, and the hard pellet was perforated. There is a 1 into 0.5 centimeter opening with the foul spelling discharge. Blood sugar was very high and ketone was positive. The patient MRI showed the right PCA, MCA, and ACA watershed infarct, and then the ICA partial occlusion in the cervical and the proximal intracranial part. You can see the occlusions in this MR angio, and the patient was rehydrated, given amphotericin along with the antibiotics and insulin, and was subjected to the surgical debridement, and the patient biopsy was taken, which showed accepted fungal hyphae and suggestive of mucormycosis. We saw so many patients in our center. We treated more than 200 patients of COVID who were on steroid or diabetic. It's long ICU stay on mucormycosis, and then with timely intervention, amphotericin has saved life. Surgery was required for most of the patient, almost 80%, and then people recovered with a high mortality. This is the same child after the treatment. So there may be many congenital malformations also. Before I end, I tell almost 3 to 8% of all birth to the diabetic women may be associated, the commonest being the anencephaly, the spina bifida, and then you have to be very careful intrapartum to rule out these malformations, those affecting the nervous system, especially in diabetic mothers. So diabetes affects the nervous system in multiple ways. Diabetes definitely increase the risk of stroke. Both very high or very low blood sugar can result in confusion, coma, and possibly seizure. Neuropathy is very common in diabetes. The symptoms are not limited to pain and numbness. Good control of diabetes can reduce the risk and slow the progression of neuropathy. That's my take home. I thank Dr. Chandrasekhar and all the members of D Club for this opportunity, and I wish there should be more sessions basing specifically on a single complication or single comorbidity or a single system, like what we are doing now for the central nervous system, or the diabetic and the central nervous system. And this is very informative, very educative, and I congratulate them for the effort, and will be taking the questions happily. Thank you all.
Thank you, Dr. Jayant Panda, for your elaborate talk on the diabetic neuropathy. In fact, you have covered the entire spectrum of the complications of diabetes. Just some of the practical points, what we see, because there's sensory neuropathy, distal sensory neuropathy, the painful neuropathy is quite common in our clinical. Though we do have various drugs like TCAs, we have anticonvulsants, we have opioids, NSAID. How do you select your therapeutic of choice based on the symptomatology?
Yeah, actually, when the patient presents with the symptom, usually we assess objectively the grade of damage of the knobs. Routinely, I see the reflexes, I see the sensory status of the patient, examining the foot and hand and different cortical as well as the primary sensations. And we go for a nerve conduction study as well. And those who are starting, you see, if there is only positive symptom of tingling, we start with gabapentin or the pregabalin symptomatically. But if patient has developed numbness, then there are some neurological deficit. We become more aggressive in controlling the blood glucose and then replenishing the neurovitamins in the higher doses, along with controlling the symptoms. But the quantitative, the qualitative assessment and the assessment of the grade of damage of the knobs is very important, because they are the people who are more prone for the foot ulcer, diabetic, painful diabetic leg syndrome, and subsequent sepsis and complications.
Yes, sir. Like also, we take it in a sense that like somebody with lancinating pain, like so it's preferable to use amitriptyline or duloxetine. Like with the burning sensation, like we can use amitriptyline and again pregabalin. With the kind of gnawing pain, sometimes the opioid have got a better efficacy than rest of the drugs. We need to be a word of caution is whenever we use the TCAs, particularly tricyclic antidepressant, we need to be very careful, because most of the time these peripheral neuropathy patients, they do have concomitant autonomic neuropathy also. So it's likely to cause orthostatic hypotension, and then particularly patients with CVD, like we need to be very careful. And moreover, like patients with painful peripheral neuropathy with a depression, like I think duloxetine and venlafaxine would do a wonderful job, I think.
In my personal experience, I've used duloxetine in many patients, and I've used the combination of pregabalin and duloxetine as well. And that has helped in many ways, not only in symptomatic control, helping the depression part of the patient, as rightly you have pointed out.
Yes, sir. Thank you, sir. I think for one of time, Kannan sir, would you like to ask?
Jay sir, any words on the aldose reductase inhibitors for the management of neuropathy?
I'll restart.
Yeah. Actually, they are little high cost drugs without any clear evidence of reverting the neuropathy. If patient is able to afford, you see, the common pathway of diabetes complication are intervened by aldose reductase inhibitors. So it's not only neuropathy, but the common final path can be inhibited. If the patient is able to afford and you want to support the patient, like qualitative care like methylcobalamin and aldose reductase inhibitors and other supportive drugs, that's fine. But if you quantitatively assess, we don't have much evidence of working, and the work and the publications on these particular agents are not very satisfactory. I don't use routinely in my patients.
Sure. Thank you, sir.
I think we can move on to the next talk. Dr. Parandaman sir, can we have Dr. Vijay Shanmugam as next speaker? Yeah. Or you would like to, because you are in Delhi. Hello. Your voice is breaking, sir.
Am I audible, sir? Am I audible?
Yeah, you are audible, sir. Yeah.
But your network is not so stable, Parandaman sir.
I'm audible, sir, now?
Parandaman sir, you can cut your video, then the audio will be.
Okay. Now audible, sir? Now audible?
Now it's better, sir.
Now it's better, huh?
Yeah, yes, sir.
Now it's better. Now I'll finish up, sir, because otherwise sometimes I may have to go rush into it. If,
Yeah,
if
yes,
no
sir.
other,
Because you are in the airport, like I thought, like you can talk.
yeah,
to me.
yeah. Finish
Yes,
up.
sir.
You finish up. Yes,
Yes, sir. Yes, sir. Yes, sir.
Yes, I will.
I share slide, sir.
So shall I introduce?
Yes, sir. Yeah, Dr. Jay.
Yes, sir. The next topic is autonomic neuropathy in diabetes. A small introduction. Autonomic neuropathy can affect the cardiovascular system, causing resting tachycardia, orthostatic hypotension, silent MI, exercise intolerance. It can affect the GIT, causing constipation, diarrhea, incontinence. It can affect the genitourinary tract, causing bladder dysfunction, as well as it can lead to recurrent UTI pyelonephritis. It can lead to erectile dysfunction. Metabolically, this autonomic neuropathy can lead to hypoglycemic unawareness, brittle diabetes, and pseudomotor system. It can affect, leading to anhidrosis, hyperhidrosis, and it can also affect the pupils. This small introduction to the topic. I will introduce the speaker. The speaker is Professor Dr. Parandaman sir, MD FRCP. He received Talented Physician Award by City Physician Association, Chennai in the year 2001. Also received the Best Doctor Award by Dean, Kilpack Medical College in 6 years, 2011, 2013, 2016, 2017, 2020 and 21. He has also received the Independence Day Award for Best Doctor by District Collector Thiruvarur in the year 2014. Also received the award from the Honorable Health Minister, Government of Tamil Nadu for his dynamism and proactive approach in the management of COVID in 2020. Confirmed FRCP Glasgow in the year 2018. He is a chief editor of the Manual of Toxicology and Indian Perspective. This is a very big book for doctors, particularly who was working in the ICU. Currently, he is a professor and the head of the Department of Medicine in Government Medical College. It is a very honor for me to introduce the speaker, as he is my teacher in my UG days. So over to you, sir, Professor Parandaman, sir.
Yes, sir. Thank you very much.
So, your voice is not heard, sir. Kindly unmute, sir.
His connection is not good.
Both audio and video out of bounds. Yes, it has come out.
I'll just cut down the speaker. I'll cut down the speaker. And now it's audible, sir?
It's better, sir.
Okay, sir. Okay, sir. I'll proceed, sir. Respected chairpersons for a nice introduction, Dr. J. And I respect to all my friends, most respected the secretary, president, and the chairman of this club. I honor talk in this forum, in the diabetic autonomic neuropathy. So with all these difficulties, I thank Dr. Chandrasekhar has been taken a lot of effort to organize, and organizing team, Dr. Nagarajan sir and Dr. Dhanamitran sir, taken so much effort in conducting this program. To go into my topic, this autonomic neuropathy occurs in individuals with a long-standing type 1 diabetes and also type 2 diabetes, but also can occur in 9% of the patients with pre-diabetes. Usually it is a long-term complication, the complication of longer duration. Usually it takes 2 decades to develop neuropathy, but sometimes it may take a few hours or a few years. In type 2 diabetes, even pre-diabetes, 9% of people may develop autonomic neuropathy. It involves cholinergic, like acetylcholine, noradrenergic, like adrenaline, noradrenaline, and peptidenergic, that is called pancreatic polypeptide, and substance P. So it involves 3 systems: 1 cholinergic, 2 adrenergic, 3 peptidergic, which is mediated by pancreatic polypeptide substance P. It can also involve the multiple systems, as alluded by the introductory speech by Dr. J. It has got the serious manifestations. Is a serious manifestation of autonomic neuropathy is a debilitating complications of diabetes. GI manifestations are the disturbing complication of diabetes. Genitourinary system are the secret complications of diabetes, and pseudomotor is a distressing complication of diabetes, whereas the metabolic complications like the hypoglycemic unawareness or the fearful complication of diabetes. So many complications. The diabetes is a disease of complications. So as you all know, the sympathetic nervous system and parasympathetic nervous system involves the autonomic nervous system. Among the parasympathetic nerve, we know the 3/4 of the parasympathetic distribution only by the vagal nerve, which is the most important nerve, which innervates the lung, salivary glands, heart, stomach, and small
Sir,
intestine, large
greetings,
intestine
this is
also.
Dr. Chandrasekhar, sir. How are you, sir?
Yes, sir. Yes. So if you see the sympathetic nervous system, it involves T2 to T12, the spinal cord segment, which is distributed as in this picture. But the autonomic nervous system not only affects
No audio. Chandru? No audio.
because of the obesity and the other updates of bone marrow. This can Is it okay, sir? Is it audible, sir?
So, Paranaman sir, your slide
Hello?
not seen. Paranaman sir, your slide not seen, sir. You please share the
Slides.
slide.
Screen is not seen.
Oh,
Sir, Parandam,
one sec.
watching the screen, sir. The audio alone will help, sir, because the connectivity is not good.
Yeah, just I'll go through. Yes, one second. Now slides visible, sir?
Not yet, sir. No.
One sec. I'll leave and come back because
Jaykumar sir, why don't we communicate Professor Paranaman sir? Communicate பண்ணி பார்க்கலாமா? என்ன network problem?
Yes, sir. Can the technical team meanwhile share his slides, sir?
Yeah, sir, you can WhatsApp to our group also. I can share it, sir, from my side.
Wait, Madi. Yes, come. Sir has come. Yeah. Paranaman sir, are you using dongle?
பரந்தாமன் சார், நீங்க அந்த குரூப்ல நீங்க போட்டுட்டீங்கன்னா கூட நான் ஷேர் பண்றேன், நீங்க பேசுங்க சார். நான் ஸ்ரீபிரியா பேசுறேன்.
சார் நீங்க சார் யூ அன்மியூட் பண்ணுங்க சார். ப்ளீஸ் அன்மியூட் சார்.
மியூட்ல இருக்காரு சார்.
Sir, Paranaman sir, unmute, sir.
Yes, sir.
Yeah.
Yes, sir.
Yes. Oh, it's okay, sir.
No.
Oh,
Yeah, yes.
right, saying, sir.
Yes, sir.
Yes, sir.
Yeah.
Now it's okay, sir. Okay, perfect.
Okay, sir. So the mechanism of neuropathy, there are so many mechanisms are there, but the emerging mechanism is the hyperglycemia leads to epigenetic changes that influence the gene expression in the affected cells. So the hyperglycemia inside the cell, it affects at the gene level in every cell. So that is what the current hypothesis is. But there are like the hyperglycemia resulting in advanced glycemic end product, which are nothing but glucose pain, pentazidine, carboxymethyl lysine. These are the advanced glycemic end products which binds to the receptor, resulting in non-enzymatic glycation of proteins, which cross-links the proteins inside the cell and extracellular as well, resulting in accelerated atherosclerosis, endothelial dysfunction, glomerular dysfunction, altered extracellular matrix composition. So the advanced major important factor that is causing the cellular dysfunction. The yet another mechanism is that the increased glucose metabolism by sorbitol pathway, that is aldose reductase pathway, that increases sorbitol, it increases the osmolality of the cells, and the cells is short shrinking and also decrease the myoinositol that is necessary for the formation of the myelin. So that is being decreased. And also the increased formation of diacylglycerol, that is the one which activates protein kinase C, which alters the transcriptional gene, which is necessary for formation of fibronectin, type 4 collagen, contractile protein, and extracellular matrix. And also the increased flux of glucose into the cell, resulting in the activation of exosomin pathway that leads to increase the production of glucose 6-phosphate, and as a result, the nitric oxide synthase, the protein isn't taking place, so nitric oxide synthase does not work, so nitric oxide production is not there. So, and also they found that there is increased growth factor such as vascular endothelial growth factor in diabetic retinopathy, that is a which major damaging substance which is produced in the retina. So this is a nutshell the mechanism of the neuronal injury by diabetic milieu. So diabetes, not only by hyperglycemia, polyol pathway, protein kinase C activation, AGE formation, it also decreases the neuronal growth, and because the glucose is not being utilized, the increased oxidation of the fatty acids, metabolism of the fat, the resulting in increased worsening of the toxic milieu of diabetes. It also can trigger autoimmune mechanism. That autoimmune mechanism may be the one another mechanism attributed for the diabetic neuropathy. Not only that, we know that reactive oxygen species, which is more dangerous. Actually, the lesser amount of reactive oxygen species very, very important for the protection, and the activation of the gene expression and gene translocation. Whereas if it is present in excess amount, it might cause the damage to the mitochondria, which is a powerhouse of the cell. So the lesser amount of reactive oxygen species is essential for every cell function, whereas increased amount causing mitochondrial dysfunction. So hence the diabetes is caused by the mitochondrial disease. It is considered as a mitochondrial disease. That's the one which is necessary for the cell growth and the myelin formation in the nerve tissue. As a result, the nerve cell necrosis takes place, nerve hypoxia, and nerve cell apoptosis. And also it affects the endothelium, resulting in the microvascular complication, occlusion and endothelial damage, vasoconstriction, decreased blood supply, so autonomic neuropathy. So neuropathy may be the direct injury to the neurons, and also the injury through the microvascular capillary occlusion, resulting in nerve dysfunction. So if you go to the first metabolic complication of autonomic neuropathy, is a cardiac autonomic neuropathy. The cardiac autonomic neuropathy is a serious but unrecognized complication of diabetes. It is not only a serious, it is a debilitating complication of diabetes. It is associated with abnormalities in distribution of cardiac sympathetic innervation. It may be subclinical for several years, but the early presentation can be detected by decreased heart rate variability. So even though it's a subclinical for several years, but manifestation, before it manifests, we can detect it by decreased heart rate variability during breathing, Valsalva, hand grip, and so on. And also, the increased triglyceride may be related to the myelin fiber loss, as already alluded to. Therefore, the cholesterol reducing agent, such as statin, and triglyceride reducing agent like fibrate, may reduce the progression and severity of diabetic neuropathy. Of course, the prevalence of cardiac autonomic neuropathy increases with the age, not only the age, the duration of diabetes, and also the duration of the poor control of diabetes. So more the poor control, more the complication, and earlier the complication. And among the two systems or three systems of autonomic nervous system, the vagal denervation is the most commonest to occur and most earlier to manifest than sympathetic innervation. The reason is we all know in mantra of neurology, the nerve fibers, which is the longest fibers, are early to get affected than the shorter fibers. So this is considered to be the longest, the parasympathetic fiber, which is supplying right from the parotid gland down to the rectum. Hence, it is a long course. So hence, this is the one which is early to be affected in autonomic neuropathy. So hyperglycemia also leads to reactive oxygen species, and of course already alluded to, and also advanced glycated inventory, which is formed by the carboxyl group of the reducing sugar and the free amino acid of the protein, that is called Maillard reaction. That is the one which is very, very important in production of all toxic substances in diabetic patients. There are tests to assess a sympathetic nerve functions like blood pressure variation. So if we have the orthostatic fall in blood pressure, that is, you call it as sympathetic dysfunction. So if anyone has the orthostatic hypotension, that means there is sympathetic nerve damages occurred. And also we can assess a sympathetic nervous system function by sustained hand grip. If you give a sustained hand grip for 3 to 5 minutes, the increase of blood pressure, systolic blood pressure, at least 15 at the peakest. If anything is less than that at the grip, it is called as autonomic dysfunction. Parasympathetic testing is usually for the straight deep breathing and heart rate variability. If you deep expiration of 5 seconds, measure the peak rate during deep inspiration, peak rate during deep expiration. There should be more than 15 heart rate per minute, but if it is less than 10, you consider it as parasympathetic dysfunction. And also the standing, the pulse rate variability during standing also considered as a test for vagal nerve dysfunction. Why should you worry about cardiac autonomic neuropathy? Because the cardiac autonomic neuropathy, even though it is asymptomatic for many years, without knowing that, it might increase the risk of sudden myocardial ischemia and sudden myocardial dysfunction. It may result in fatal arrhythmias and sometimes maybe sudden death. So it may be asymptomatic for many years, but can suddenly lead to sudden cardiac death. That is the problem with the cardiac neuropathy. That is the reason why should we bother about this the dysfunction of cardiac. So it is also mediated by the so many other factors. How to assess this? More severe the peripheral neuropathy, more severe the autonomic neuropathy. So before you understand, before you test for autonomic neuropathy, you test for this dysfunction and through the other functions. There are so many tests you can do. The tests can you do or heart rate variability for deep breathing. So deep breathing, normal variation is 15 seconds, and if it is anything less than 10 beats, then it is called autonomic dysfunction. If on standing, within 15 seconds, you will have variability of more than 15 pulse rate. If anything less than 12 heart rate, that is abnormal, and also during Valsalva like that. Like that, you can test for the blood pressure variability. That the blood pressure is mainly for a sympathetic nervous system function. If normal drop is less than 10 millimeter mercury while standing, whereas if it drop in blood pressure, systolic blood pressure, more than 30 millimeter mercury, that is considered as systolic, that is autonomic neuropathy. So the advanced heart disease, but these are the things which occurs in early of autonomic neuropathy, but in advanced heart disease, it can result in resting tachycardia and vagal nerve, that is a result of vagal nerve dysfunction, and sometimes you can have fixed heart rate. So what is the uniqueness of the diabetic cardiomyopathy is that the orthostatic hypotension. You may get orthostatic hypotension in so many conditions like dehydration and volume depletion and so many other conditions. Whereas in diabetic autonomic neuropathy, if at all if you get orthostatic hypotension, there will be hypotension without appropriate increase in heart rate. It is the most unique feature of diabetic autonomic neuropathy. So whenever you look for orthostatic hypotension, you should look for the pulse rate. Is there appropriate increase in heart rate? That's very specific. And sometimes you may have sudden death, maybe attributed to the cardiac autonomic neuropathy. It may limit the individual exercise capacity. So anyone, even though asymptomatic, if you are longer duration, it might limit the individual exercise capacity and increase adverse event during the exercise. So anyone, a diabetic patient, suddenly develop arrhythmia and complication during exercise, think of autonomic neuropathy. And one another peculiar character of diabetic autonomic neuropathy is even in the absence of ischemia, arrhythmic rate is very, very high. So you may have arrhythmia even without ischemia. That is one another important contributing factor, or the important factor to consider it is cardiac autonomic neuropathy due to diabetes. So importantly, the ACE inhibitors and ARBs have been proved to be useful for cardiac autonomic neuropathy. So what is the important tool is that the early detection is one, the clinical, as you already mentioned, is postural fall and the heart rate variability during standing, during deep breathing. In addition to that, we can do ECG. ECG can see the QT prolongation. If any interval is more than 430 milliseconds, it is a feature of diabetic autonomic neuropathy. You early can detect, you can identify and stratify this, and you can prevent the complications by tight control and other advanced measures. And also you can see respiratory variability or variability in the ECG during deep breathing and also during Vascular. So you have to do quantitative autonomic nerve function testing and should be performed in all patients whenever you plan for exercise program for any diabetic patient. So any diabetic patient, if you're planning for exercise, you have to do quantitative autonomic function testing before you advise them exercise. And also better you do, if facilities are available, you can do MIBG scan. It will be very much a decrease in a patient with diabetic if HbA1c is more than 7.6. If MIBG uptake is decreased in a patient with diabetes, these are the candidates more prone for cardiac autonomic neuropathy. Hence, before exercise, you advise you do MIBG scan if patient is available. Next, you go to the GI, genital urinary tract abnormality. The earliest abnormality in GIT is a postpartum fullness and bloating, which is the most distressing complication for diabetes. And this is due to the slowing of the gastric peristalsis, which is not only the frequency and also propagation of antral pressure wave is decreased because of the vagal nerve denervation. The abnormality of the gastric pacemaker, you know the gastric pacemaker, which is situated in the pylorus, it is early to be affected in, so you can assess the autonomic neuropathy by the fullness of abdomen and the dyspeptic symptoms. And also you can see the erratic blood sugar control with the abdominal UGI, these upper UGI symptoms. So erratic blood control with the belching or dyspepsia is an indicator of, the clinical indicator of the autonomic dysfunction of GIT. In addition to that, you may have another complication, diarrhea. The characteristic feature of diarrhea in diabetes is, which is painless, which is nocturnal exacerbation, which is in contrast to IBS, irritable bowel syndrome, where no nocturnal symptoms in IBS, whereas in diabetic, you will have nocturnal exacerbation, you will have painless, there is no painful. If at all painful, it is infective, painless, it is autonomic neuropathy of GIT. So yet another important, and also you may have the distressing complications of fecal incontinence. So this is a gastric, motility, the gastric, the pacemaker is placed at the pylorus, where there's the origination of the antral and propagation of the pulse wave in the GIT. So these are the organs which is normally affected. Is the esophagus, stomach, small intestine, the vascular system, colon, and of course anorectal region. Of course, the diagnosis of GI autonomic neuropathy, the gold standard test for the diagnosing gastroparesis is measurement of gastric emptying with the scintigraphy of digestible solid at every 15 minutes for 4 hours after intake. So you have to give the digestible material which is stacked with the radionuclide give for them, and every 15 minutes you take the photograph and for 4 hours and see the delay in the gastric the cavity itself. So the suitable alternative, if the gastric scintigraph is not available, we can do for carbon-13 autonomic breath test, which is an suitable alternative for the gastric neuropathy. So yet another complication of the diabetes is diabetic autonomic neuropathy, which is the most common in females, or the neurogenic bladder, which is commonest to being the urinary incontinence, nocturia, increased frequency, urinary urgency, and of course weak in males, the weak stream of urine may be there, and in females, recurrent urinary infection. So these are the most disturbing complication, which is shameful complication, which is secret complication. Sometimes patient may not reveal. So you have to look into all these complications by history elicitation. So in addition to the bladder dysfunction, you have yet another complication is the sexual dysfunction, which is most neglected and secret complication of diabetes. More than 50% of the diabetic males are prone, as much as 70% of the male are affected with the sexual dysfunction, but it's often neglected. And also in addition to that, they may have retrograde ejaculation. Whereas of course in females, only 30% are affected. The commonest being decreased sexual desire, vaginismus, and decreased sexual arousal. So just to rapidly go into the physiology of the tumescence, to have a tumescence, you should have a nitric oxide. Nitric oxide is a vasodilator. That is the one which increases the blood flow into the corpora cavernosa and muscle, thereby increases the tumescence. So this, we all know the nitric oxide is generated by the endothelium. But in addition to the endothelial release of nitric oxide, the nerve terminals from the parasympathetic terminals in the corpora cavernosa, it releases nitric oxide. So nitric oxide not only released by endothelium, it is also released from the parasympathetic nerve endings in the corpora cavernosa. That's the one which increases the nitric oxide, that stimulates guanylate cyclase, that resulting in increased cyclic GMP. The cyclic GMP is the one which is most important substance which causes a relaxation of smooth muscle, and probably it is mediated by opening of the calcium channels in the corpora cavernosa that results in relaxation of smooth muscle, that tumescence. In addition to that, you need to have the penile and sexual stimulation, which is released by acetylcholine. In addition to the nitric oxide, acetylcholine is also important, which is again stimulates the guanylate cyclase and also increases the cyclic GMP, resulting in tumescence. Why it's important is because in a treatment of the sexual dysfunction, we need to understand this to give drug according to the nature of this disease. So in addition to the erectile dysfunction, which is occurring in 50%, the vascular smooth relaxation occurs in smooth muscle, as already alluded to, and therefore this erectile dysfunction in diabetes not only to the endothelial dysfunction, it is also due to autonomic neuropathy, autonomic dysfunction. So the two things are playing a role in the patients with erectile dysfunction. What are tests you do? The test you do is measurement of nocturnal penile tumescence, and also you can do the measurement of penile and brachial pressure. That is regarding the sexual dysfunction. And regarding the bladder atony, you have to go by urodynamics and uroflowmetry, so that you can assess the function and can approach the drug according to that. So yet another complications of the diabetes is the pseudomotor dysfunction. It is a characteristic abnormality. What are the characteristic abnormality in diabetic neuropathy is hyperhidrosis of the upper body, that is increased sweating of the upper body, but dryness of the lower limb. So upper body sweating, lower body dryness. The dryness that is resulting because of the sympathetic nerve dysfunction, and sympathetic nerve dysfunction resulting in dryness. The dryness leads to the cracks in the foot, that is acts as the nidus for the infection. So in addition to the hyperglycemia, we some one entity called gustatory sweating, that is provoked by eating. So whenever you eat, patients start sweating over the face and upper body. That is called gustatory sweating, which is one of the characteristic feature and one of the early feature of diabetic autonomopathy involving pseudomotor dysfunction. And yet another feature of diabetic autonomopathy is nocturnal sweating. You may have nocturnal sweating in a patient with diabetes, usually associated with hypoglycemia, but if you measure the blood sugar, if it is more than normal or the higher level, but still you have sweating, that means that is an indicator of nocturnal sweating, indicator of autonomic neuropathy of pseudomotor. So nocturnal sweating without hypoglycemia is yet another important feature of diabetic autonomopathy involving pseudomotor system. And also, you can see there are some patients, you can see the bounding or engorged veins over the dorsum of the foot. Again, that is due to the denervation of sympathetic nerve over the foot, resulting in dilatation of the arteriovenous shunting, resulting in dryness. And also, you will have shiny skin, you will have thin skin, shiny skin, and sometimes you can see the lower half of the legs will have hairless. So you can see typically lower half of the legs will have no hair, and that is due to a lot of nutrition supply. And the most important, very, very important complication or characteristic feature of pseudomotor is that you can feel the tips of the toes as like the appearance like overcooked baked potato. If you feel the toes tips in a female, especially female of long-term diabetic, you typically feel like overcooked baked potato, very soft, just simply can peel off. So much of soft skin will be there, especially in toe tips. That is very, very characteristic of pseudomotor involvement of diabetic neuropathy. And yet another feature of the diabetic autoimmune neuropathy is metabolic complication. The most important metabolic complication, most dreadful complication of autoimmune neuropathy is hypoglycemia unawareness. Sometimes it may lead to fatal, and they may be sometimes dead in a bed. That can occur in a diabetic, long-term diabetic because of hypoglycemia. So one should be aware that any person who is having features of diabetic neuropathy, which should be detected early, thereby you can prevent dead in a bed complications like usually induced by hypoglycemic unawareness. And also the people abnormalities you get, there is a decrease in pupillary size, resistant to mydriatics, delayed or absent light response. But now we have one of the sophisticated investigation to detect the pupillary response even during dark. Is that high resolution infrared cameras is available. It is very costly, but that can measure the pupillary diameter even at dark. So that's one other thing. So if you rapidly go to the management, diabetic gastroparesis, you just give small and frequent feeds and small particles. That means gruels, rice kanji, like that you can give. And you can give prokinetics like cisapride, domperidone, metoclopramide. The problem is metoclopramide should not give beyond 12 weeks. Erythromycin problem is that it is only tachyphylaxis. It can work for a shorter duration. It may not work for long because of the tachyphylaxis. The most important, very, very new drug in the pipeline is that cepiapterin, which is the one which acts as a gastric peristalsis, which is a drug which is new drug, which is being FDA approved drug, which is a very effective drug for diabetic gastroparesis. And also, if that also fails, probably you can use gastric electrical stimulation and surgical implanted device also available. So for diabetic complications, you can use as usual laxative, Senna, Delcolex, and so many other osmotic diarrhea is also available. For osmotic diarrhea, you can use loperamide, codeine, tetracycline, erythromycin. Most importantly, codeine. The codeine sulfate is the one which acts centrally, and it might reverse the diabetic autoimmune neuropathy on the colon, whereby diarrhea will be improved. So most important drug in treatment of resistant diabetic diarrhea is clonidine, which is available to treat in hypertension. So the neuro complications of neurogenic bladder complication can be managed by manual pressure, intermittent self-catheterization, of course, antibiotics to prevent infections, and pseudomotor dysfunction, emodin can be used, and scopolamine, atropine sulfates, and glycopyrrolate can be used. And of course, most importantly, botulinum toxin can also be used in a severe sweating, which is caused due to the dysfunction of the pseudomotor. We can use botulinum toxin. And postural hypertension. The postural hypertension is the most important preventable complication. The idea of treatment is not to aim at the normal blood pressure. To aim is to minimize the postural symptom. That's the most important than trying to maintain the normal blood pressure. So what you do, the head and elevation, gradual raising from bed, and of course you can use pressure stockings for the legs and abdomen. You can use the fludrocortisone, 100 microgram QID can be used, up to maximum dose of 1 milligram per day can be used, and the new drugs like Vidodrine, 2.5 to 10 milligram per day can be used, and of course yet another new drug for the postural hypertension is droxidopa, which is approved by FDA and recently, so that also can be used. For erectile dysfunction, sex therapy, psychotherapy, sexual counseling is essential. Regarding the drugs, I'll be alluding to the next slide. And apomorphine is yet another drug which is used for erectile dysfunction, which acts on the D1, D2 receptor on the hypothalamus and improves the erectile dysfunction. If that also fails, probably you can use intracavernous injection of prostaglandins, and of course the papaverine can be used. And if that also fails, we can use prosthetic devices. So just I rapidly go into the drug management in erectile dysfunction. The most important and most commonly used drug is sildenafil. That should be taken in empty stomach. The most important points are just like to invite is that should be taken in empty stomach at least 1 hour prior to the coitus. So the sildenafil should be taken in empty stomach. That's one point I like to insist. And the second point is the daily tadalafil for psychogenic dysfunction, psychogenic erectile dysfunction, and complete activation. So daily tadalafil of 5 milligram, 2.5 to 5 milligram is very, very useful, even in the case of psychogenic erectile dysfunction in a diabetic, and also even complete erectile dysfunction, where the tadalafil is very useful. So the daily tadalafil may also be used for urinary symptoms like lower urinary symptoms in benign prostatic hypertrophy. So tadalafil is the most important drug, which is commonly used drug for the erectile dysfunction, complete erectile dysfunction, and erectile dysfunction due to psychogenic. That's a point I like to insist here. And also you have vardenafil. Vardenafil is a more rapid onset of action that is very effective in a fed state with a high fat meal. So anybody who has already taken food, high fat food, probably vardenafil may be very effective. And yet another new drug is that avanafil, which is more onset of action, more rapid onset of action, which acts as quick as within 15 minutes. So these are the drugs that are available. So you can very well treat in the early stage itself. So at my last presentation is the gist of my presentation. What are the gist of my presentation? Diabetic autoimmune neuropathy is common in long-standing diabetes and poorly controlled diabetes, but still it can occur in pre-diabetics of type 2 diabetes. So cardiac autoimmune neuropathy is a serious but unrecognized complication of diabetes. Cardiac autoimmune neuropathy may be asymptomatic for longer duration, but may lead to fatal arrhythmias. Cardiac autoimmune neuropathy can be detected early by heart rate variability during deep breathing and Valsalva. Even though it is asymptomatic, even in asymptomatic stage, if you do this test, you can detect it early and prevent the complication. Cardiac neuropathy can lead to fatal arrhythmias even in the absence of ischemia. That's very, very important. And cardiac neuropathy, it can cause postural hypertension without appropriate tachycardia, which can occur with the other causes of autonomic neuropathy. Of course, ACE inhibitors and ARBs may be more useful in patients with diabetic autonomic neuropathy. GI autonomic neuropathy is the early symptom is postprandial bloating and posterior fullness, which with a high blood sugar. That's a one characteristic feature. Due to the abnormal antral pressure wave, which is a pacemaker of the GIT, that is a pacemaker of GIT is pylorus is a pacemaker of GIT. A metaclopramine may be used and should not be used more than 12 weeks. Azithromycin, the azithromycin causes easy tachyphylaxis. A new drug already mentioned. The gastric sweating is a characteristic feature of early diabetic autoimmune neuropathy involving pseudomotor nerve dysfunction. And pseudomotor changes in diabetic neuropathy: upper body hydrosis, lower body dehydration, upper body sweating, lower body dryness, and sympathetic denervation resulting in engorged veins over the legs. And we can look into particularly important clinical points. And of course, the severe complications of diabetes is not only by the autonomic failure of decreased nitric oxide release, and also it is mediated by acetylcholine, decreased acetylcholine by parasympathetic nerve. So we need to address both the nitric oxide as well as acetylcholine levels in the body. And of course, hypoglycemic unawareness is a fearful metabolic complication, hence to be avoided. So the message here is, even though diabetic autoimmunopathy, the secret complication, serious complication, blissful complication, and dreadful complication, these are asymptomatic. They are asymptomatic for many years. And fortunately, these can be detected early by simple clinical tests and also simple ECG. Unfortunately, this can be prevented by early detection, early control, and early prevention of complication, and we can prevent the death of a dreadful complication of diabetic autonomic neuropathy. Thank you very much for patience. Thank you. My heartfelt thanks to all the organizers, like the president, founder secretary, chairman, the treasurer, and of course all our team given me this wonderful opportunity and taken so much of strain to conduct this program, even in this crisis time. Thank you very much for patience.
Sir, excellent presentation, sir. Sir, I have two doubts. One, what is the importance of the pre-operative cardiac autonomic neuropathy testing before any surgery, sir? Because we do ECG echo and all before any surgery. What is the importance of cardiac autonomic neuropathy testing, sir? This is my first question, sir.
Yeah. Because the autonomic neuropathy, these are the people may develop complication during surgery. So sometimes the patient may develop acute LVM because there may not be ischemia, but still they develop LV dysfunction. There may not be ischemia in the ECG, but still they develop acute myocardial infarction. There may not be findings in the ischemia in the ECG, still they make cardiac death. So when you do an ECG, look for the QT prolongation. If anything is more than 430 milliseconds in ECG, but usually we consider more than 450, whereas in diabetic autonomic neuropathy, more than 450, that's very, very important finding. We can prevent, we can postpone, we can be very careful in conducting the surgery and following the patient following surgery. So that's very important. So what a simple test. You can do the heart rate variability. So for while standing and deep breathing, Valsalva, you can do the hand grip pressure measurement. You can do simple postural hypertension. If any of these things are positive, you should be very, very careful, alerting the surgeon, alerting the anesthetist to be careful because anytime you may get even during surgery. So that's very, very important. That's actually, I'm very happy about raising this question because with the lack of time, I could not concentrate on this operative and post-operative. It's very, very important to be addressed.
Another question, sir. A patient with diabetic with recurrent UTI with having neurogenic bladder, what is the role of anticholinergic drugs like oxybutynin, silodosin or miragabran, sir?
Yeah, see, that's simple. You understand the physiology. So where is the problem? The problem is autonomic neuropathy where the increased tone, that is autonomic bladder. If we have autonomic bladder, that means the bladder overfilled bladder. That is overfilled bladder with more than 2 liters or 1 liter, where you give parasympathetic drug like the Euroflow, that is acetylcholine derivative, Urotone. Urotone can be given to, that is a cholinergic drug which increases the contraction of the fundus of the bladder and that contracts the bladder. So when we have autonomic neuropathy having autonomic dysfunction involving the autonomous bladder, you give Urotone, that is cholinergic drug. If we have the problem in the contraction of the sphincter, they can give oxybutazone. Oxybutazone is a sympathetic drug. It's supposed to contract the sphincter. If we have incontinence, which is secondary to the sympathetic problem, you give the oxybutynin or celestrozine that can be given. So these are the drug which acts on the sphincter, whereas the Urotone is a drug that is acetylcholine drug which acts on the bladder. So you have to assess the bladder dysfunction. That's why you have to do urodynamic study. You assess whether the bladder function is due to parasympathetic or sympathetic. If you have a parasympathetic problem, you have to give the acetylcholine drugs. If you have a sympathetic problem, you give sympathetic drug.
Thank you, sir.
Thank
you, Dr. Pandaman, for your excellent talk. Despite your personal challenges, and got held up in Delhi, the airport. So you've done a dedicated lecture on the autonomic neuropathy part of it. I think you covered most of the things. I just wanted to add 2 more points. One is these people with the autonomic neuropathy, they also can develop the gallbladder stone. Nowadays, it says that autonomic, the alteration in the ejection fraction of the gallbladder.
Yes. Because it's not been commonly discussed. That's why I did not look into it.
It's a very
contraction. Yes. True. Agree.
Yes. Second thing is somebody with the cystopathy, it is imperative that they also have impotence. Some of the things I thought I just.
Yes, sir. This is the point. Wherever there's a contraction, there is the autonomic system function involvement. Bladder contraction, there is gallbladder contraction, is urinary bladder contraction, intestinal bladder contraction, even the whatever area the lumen contraction, there the autonomic plays a role. Yes, sir. Nice.
Thank you, sir. Thank you for the wonderful lecture, sir. I think we can, for want of time, we move on to the next talk on vision and diabetes. Can I have the introductory slide of Dr. Vijay Shanmugam? Yeah. So Dr. Vijay Shanmugam is a good friend of mine, almost for more than 30 years. He's my classmate, and we both of us joined government service on 1995. And currently he is the professor of ophthalmology in Madurai Medical College. And he has got a great deal of interest in the research and done some wonderful research.
Chandra, hi Chandra. Enough.
Yeah.
Don't lie, Chandra. I'm not so interested in this. I'm just another teacher. I'm just very happy to be in this elite crowd. This is one of the rare crowds. We have always been with ophthalmologists. Very rarely do we come across such elite crowd like a general physician. Chandrasekhar is all lying. All this is just for. We'll just move on to the presentation. Chandra, thank you for your. How are you?
I'm fine, Vijay.
Very nice, very nice. We're meeting across like this after some time.
Yeah.
We just move on to our review because we think we are running short of time now. Can everyone have an empty slide there? Can you see?
Yes.
We will start, Chandra, with your permission and the permission of all the delegates there and all the organizers. Thank you for calling me. Usually, I never get called to all this kind of diabetic symposiums. It is always an ophthalmic symposium. Very nice to see, even though I don't understand most of them. But I think I will just give you a gist of what we are trying to do, playing a part in diabetes now. As an ophthalmologist and from an ophthalmologic point of view. Shall we start? We'll go on. If you all can hear me. Yes? Yes, thank you.
Yes.
Yeah. Okay. Yeah. Okay, let me start. For us, human eye is everything, no? It is better than seeing the sky, no other God. So everything is just a window to the world. Whatever you see, diabetes, as you all know, no? Diabetes, everything you can see through the eye. It is the only place where you can see the vessels directly and whatever is happening to the vessels. So I think you guys should send all our patients to us for first screening because we can see the diabetics easily for you. I will just run through a few things about diabetes and eye. So you guys can just take out your direct ophthalmoscope, put it into the eye. Anything you see, you can send. Okay. I'm Dr. Vijay Shanmugam. Now I head the Department of Ophthalmology at Madurai Medical College. After bouncing, I've ended up in Madurai. I'm only very near to Sri Lanka. So probably in the next counseling, I'll be ending up in Sri Lanka only, most probably. Let's see. So I'll try to finish within 21 minutes. I've started my stop clock. We'll be talking about the epidemiology, when and where, and why there is vision alteration in diabetic individuals. We'll try to see a minimum of them. And treatment from the physicians and the ophthalmologist point of view, how you can also help, and all the levels of physicians, how we can help right from the primary to the tertiary level, whatever we are doing to increase or improve the morbidity of patients who are suffering from diabetic deprived visual loss. Let me tell you something. Why don't all you people can put up this small chart which is found in the net? You just put it up 6 meters. Nowadays, you get even 3 meters chart. The first chart this is the logmark chart. This I don't think is necessary for you all, but this is a Snellen's chart, which is an e-chart, which comes even in numbers, which comes in vernacular languages, which comes in our English. You can just put it up in 6 meters and ask the patient to read. Anybody who is deprived of vision, you can just put your scope inside. You will be seeing thousands of diabetic patients. This ETDRS chart is an early treatment diabetic retinopathy chart, which is like a Bible. ETDRS is a evidence-based medicine type of treatment for us, and it is Bible and a guide for us for treatment of diabetic deprived visual acuity. This visual conversion charts, you see, most of the research is done in the Western world. They'll give us 20 and 20. Most of our guys don't understand because we follow the metric system of chart. And here there is a logmark chart. Logmark chart will give you even better visual acuity determination. Visual acuity is nothing but the minimum resolution power of each eye, how you can see each contrast as a minute to an hour. Let us leave all the techniques and all now. First of all, when you put the patient in front of the vision chart and you ask him to read, suppose he reads fully, okay, but if he doesn't, you know, diabetes itself can affect his vision. And if you control diabetes itself, it can increase vision. For example, this is what I found out. See, 2017, he had around 0.5 spears. And then 2019, he's plus 2.5. That is because his HbA1c was 12.6. Here, why does this occur? This is because of the osmotic changes of the lens. Like, for example, the sorbitol pathway, there is accumulation of sorbitol inside the lens, which will draw the fluid alone from the extravascular space. It will build up the lens. It will produce a more rounded lens. This is called a myopic shift, where it goes towards the minus power. Most of the things we will see a myopic shift. Sometimes if the lens becomes smaller or it becomes detergents or it reduces in size, you can have a plus power. For example, the patient had plus 2.5, but when his glucose was treated by great guys like y'all, it had come to plus 0.5 or minus 0.5. See, it is reduced. So you don't rush in and give glasses for hyperglycemic or hypoglycemic patients because of this. After you give him a good glass, the guy is a very rich fellow because diabetes, they eat a lot, they're very rich. They go outside, buy a glass for 20,000 or 30,000, come back to you after 3 weeks saying that it is not, my eyes are not seeing well because there can be a normal or euglycemic level which could have brought down the refraction of the patients. This is now commonly you can see. That is the visual acuity. This is the anatomy. Normal fundus, I don't have to tell you guys, optic disc, these are vessels, the venules, the arterioles. This is the macula, diabetes, where the central 30 degrees, this is the 30 degrees. This is the most important part. This you can easily see by throwing your ophthalmoscope inside, a direct ophthalmoscope. I'm not talking about big visions like slit lamp biomicroscopy or some advanced investigations like RETCam and other cameras. No need, just a simple ophthalmoscope you can put. This is the fundus fluorescent angiography, which we were doing previously. We are doing now, but only for a few indications. Before, this was used to guide our treatment. Now, no. This is what guides our treatment. This is a normal retina, this area here, about 6 degrees over here. You can see this is an optic coherence tomography, an OCT machine. This gives a histology of your retina. You can see the retinal layers. Just cut like a cake, you can cut and you can see, my God, what wonders everybody has produced now. Thanks to all the biometrists and engineers who have got this wonderful machine. You just have to put the patient across, non-invasive, just 2 seconds or 3 seconds, maximum 8 seconds, it gives you a fit photo like this. Here you can give individual levels. And now, mind you, diabetic retinopathy is a microvascular or microangiopathy. So now in this level, you can get all the problems or even small pathologies which you can pick up now. Had the price of been blindness, I would have looked. I'm taking this as a literal sense. Maybe Ralph Ellison was more he was more of a, but what I am taking this, my guys, it should be that you have to look if you want to prevent blindness. What death is to a physician, blindness is to an ophthalmologist. If it's going to reduce, there's no point in studying 5 years in ophthalmology. See, we'll just go, what is this diabetic retinopathy and ophthalmology? I'm leaving out all this. You guys will be much better knowing how many million cases of diabetes in India. And see, prevalence of diabetic retinopathy in type 2 is around 17%. So 17% of this guys can have diabetic retinopathy. And blinding complication, that is his lost vision, less than 3/60, is around 3.5%. Males are more. Why? Not that diabetes is more in males. It is because they have more access. That is what the studies have said. More than as elderly individuals. Why more than 50? Because that you can see is more the duration of diabetes, the more chances for diabetic retinopathy. Number of studies have told that. And type 1 diabetes, this is important. 1 lakh children per year are added for type 1 diabetes. 37% has diabetic retinopathy. And mind you, this diabetic retinopathy can be a proliferative type of diabetic retinopathy. That is a more advanced stage. Nearly 25% is more than type 2 diabetes. And 50 lakh people, out of 7% are diabetic retinopathy. So there is an increasing prevalence. This is a very worrying sign for us, because before they thought all the people in the villages, they used to work hard. So the diabetic level is very small. They'll have less amount of diabetic complications. No. Everybody is having diabetes. The patients who come to us for CAMs and other CAM surgeries, most of them have diabetes. He doesn't know. Actually, in rural urban population, at least we go to the doctor. Those guys don't know what is this diabetic retinopathy. I mean, diabetes itself. So you can have a lot of people there. And I'll be introduced into one more terminology. I showed you, central 30 degrees. That edema over there, that's called a diabetic macular edema. That is the most important cause for visual loss. Around 2/3 of people have lost their vision because of this diabetic macular edema. And we try to treat this, or we try to attack this complication so to reduce the vision. Risk factors you'll be knowing better. More poor control of diabetes. Most important is hemoglobin, HbA1c, and the duration of diabetes, because a lot of studies have done into this, and poor control of diabetes, pregnancy, systolic pressure. Okay. I'll just give you a few photographs of diabetic retinopathy, what we are talking about. All you have to do is just throw your ophthalmoscope inside, and you can see this is a venule which is dilated. Normally, this should be 2:3 or 1:3 or 1:1. But here you see the venule is dilated. Sometimes you can have segmentations here. All these yellow things are cholesterol deposits. They are called hard exudates. See these small things, these are called dot hemorrhages. These are all deep hemorrhages. These are superficial hemorrhages. Sometimes here you can see these flashed hemorrhages. These are called flame-shaped hemorrhages. All these are problems of diabetes. When you just inject fluorescein into this, say to a 10% fluorescein or 2% fluorescein, you can see these small dots which are glowing like stars in the night sky. These are microaneurysms. These are less than 20 microns. This is the important, because diabetic retinopathy microvascular complication, two things. One is microvascular occlusion and neovascularization. Because of occlusions or microvascular damage, you can see loss of pericytes, all those things, whatever you guys know much better than what we know. You can see these small outpouchings here. These are called aneurysms. You can have this leakage because there can be fluid coming out here. This is the problem for us. This is the macular, this is the edema. Macula somewhere down here. Now you grade it as mild, moderate. You guys will see most of this, because higher levels will come to us directly because of the visual reduction. You can see these kind of problems because the patient will not pick up type 1, type 2 diabetes. Immediately he would have been diabetic for the past 7 to 10 years without him knowing. But then you can see these are few stars here. You can see few stars here. This is called a hypofluorescence because there's blood over there. So underlying fluorescence you can't see. Here you can see the fluorescence become directly, it's called. This is hyperfluorescence. So these certain things, there's something called autofluorescence also now, and all those things. So this is the veins. You can see the veins. You can see one small track over here, and you can see this full. So arteriole is full, vein is filling. So this must be a little later stage of angiogram. And you can see this is the macular area. Here, macula is black in color. This is called a normal foveal avascular zone. This can increase. Sometimes there can be occlusions here. So this dark can be in anywhere areas. These are called vascular occlusions or any microvascular occlusions, capillary occlusions they can have. So two things, they can be leakage or they can be ischemia. So these are the two things can cause reduction in vision. Microvascular leakage, God has given it unto our hands, we can treat. But microvascular ischemia, God knows. He still has that. Whenever he's going to give it to us, God only knows. After you advance, those are the non-proliferative stages. But when you go for proliferation, that is prolonged occlusions, can form hypoxic areas, which can throw out vascular endothelium growth factors or angiogenic factors. These angiogenic factors can increase vascularization in order to improve the hypoxia or improve the areas of hypoxia through vascularization. One, you can have neovascularization, or two, you can have opening up of previous capillary channels. Here you can see this is neovascularization. It's more associated with fibrosis. Here the vascularization can be associated with fibrosis. These are areas of capillary dropouts. This is an ischemic area. These are areas where microvascularization with leakage. You can see a leakage over here also. This is the neovascularization which is leaking. These are new vessels. So two things you will have. This is the neovascularization of the disc area. This is a disc area mainly. Why does it occur here? Because here the internal limiting membrane. No theory, all this stops over here. Neovascularization elsewhere. Here, two things I would like to tell you is, one is neovascularization is because of hypoxia. Another, it occurs in the layer of the retina. So it acts as a scaphoid. The posterior vitreous phase acts as a scaphoid for it to grow. Now, and all those things. And then you can see vascular proliferations here. This is called a proliferative vitreoretinopathy, which occurs on the surface of the retina. You can see all the neovascularization with fibrosis. This is a pseudo hole, numb and all those things. So this is a later stage of diabetic retinopathy called the proliferative diabetic retinopathy. There is one important studies for us, which is the early treatment diabetic retinopathic studies. This studies has differentiated or reclassified diabetic nerve and all those things. So I've already shared about diabetic macular edema. This is one of the causes of visual reduction. So you can see prevalence of diabetic retinopathy is around 10%, and depends on the type of diabetes and duration of diabetes. Both, the problem is in type 1 diabetes, 20 years duration, it comes to 30%. Both type 1 and type 2, it approximately 30%. So after we miss or we catch the patient later, after 7 to 10 years, he's probably bound to have diabetes mellitus. This Wisconsin study, they've reported that 32 patients have diabetic macular edema after 20 years, not earlier. So less than type 1, less than 5 years, they seldom have the macular edema. You cannot pick up. But in type 2, even if you're less than 5 years, first time coming to you, please put your ophthalmoscope inside. See for macular edema or for diabetic retinopathy. In other study, 5% of patients of diabetes show macular edema 5 years after diagnosis, which becomes 28% after 20 years. So 5% after 5 years itself, you can get some form of diabetic retinopathy. Whereas type 1 diabetes, seldom you can see before 5 years. This early treatment diabetic retinopathic study, this has first introduced us to this diabetic macular edema. They have given us few terminologies: diabetic macular edema, early treatment diabetic retinopathic study, and something called a cystoid macular edema, something called different types of macular edemas they have described for treatment. Because of these studies, we've got certain treatment modalities. And now we are more focused on something called clinically significant macular edema. Okay, that was given by ETDRS. And they produced a chart, which I showed you previously. And they have also defined what is this rate of moderate visual loss, mild visual loss, and severe visual loss. So if you lose 15 letters, then it is a moderate visual loss. Here, over 3 years, the rate of moderate loss was 8% in ETDRS. In 3 years itself, 8% of people the vision has reduced. Simple things, binocular stereoscopic ophthalmoscopy is with the slit lamp. It comes as a 90D lenses. There are various kind of hyper convex lenses, which we can see the retina directly through the pupil. You can see, because of a stereoscopic vision, you can pick up small things. This is more a trained, it needs a lot of training to see this. Optical coherence tomography, I've already told you, and FFA machine. A lot of my ophthalmoscopes which have come up, if everybody who has got an excellent practice can buy ophthalmoscopes, which you just have to put your scope in front of it and the camera captures and gives you the image, which can be transferred over the net to other people over there, and everybody can easily pick it up. Okay. And this is called teleophthalmology, which now they're putting it under diabetic projects now. These are the types of macular edema which ETDRS has described. Here you can see, because of the capillary diffusions, you can see a lot of fluid gathering over here in the later stages. This is a diffuse macular edema. This is in the central macular area, I'm telling. And this, sorry. This is a focal. You have a central microaneurysm here, which is throwing all the fluids outside. There is accumulation of cholesterol in a succinate pattern over here. And this is called a focal macular edema. This is the area of the macula. This is the fovea. And you have in the parafoveal area, you have this focal edema. For here, you just put a laser over here. This will resolve in 3 months. This is called a cystoid macular edema. Okay, you can see in the retina, when you put the cut section of the retina, you can see these cystoid sponge-like spaces over here. Because of this modern treatment, which we have followed now, we have got through all these epidemiology studies. See, what was like this had become like this in course of treatment. This is called a cystoid because it looks like a flower pattern. On fluorescent angiography, it looks like a flower. It's called a cystoid macular edema. This is one of the type of macular. So most other types of macular edema is ischemic macular edema, which is very difficult to treat. Treatment for macular edema, not for diabetic retinopathy, for macular edema, just to improve your vision. These anti-VEGF drugs, they are a boon for ophthalmologists now. We are giving it in dozens, even though it is very expensive. We are giving it in dozens, and a lot of people are benefited because of this anti-VEGF factors like pencabamide or bevacizumab and ranibizumab. And in government hospitals, we do have bevacizumab and ranibizumab. Effervescent and contrivit are very expensive, they don't give, but this we have got. Wonderful drug, this ranibizumab, and it reduces macular edema. You can see all the hard exudates here and the macular edema over here, which is resolved on treatment with bevacizumab. This is Avastin, a drug for colon cancer. By chance, they picked up the reduction in macular edema in case of diabetes. Comparative trials, after 3 years, all drugs act as the same. That is important for us. So now it depends on the cost of treatment. Ranibizumab is pretty expensive, around 30,000 rupees, whereas bevacizumab is pretty cheaper. It's around 8,000, 9,000. Effervescent will cost around 60 to 70,000. And whichever you treat with anti-VEGF, 60.7% have a better anatomical outcome. I'm not talking about the physiological aspect of it, but when you put an OCT machine, you get a wonderful anatomical result, which you can show the patient, say that after you give this drug, he would have spent 30,000 to 40,000 rupees, maybe himself or through insurance, and you can put up the chart and you can tell him. And after 2018, it's become a standard care for all developed countries. Whereas unfortunately for us, because of the cost, only 2.1 injections per year each one is getting, which is much less than 8 or 9 injections which each one should get. Okay. This is a focal laser. I told you the focal, when you put this is a microaneurysm over here. You just put lasers over here. 2 types of lasers usually you have in our setup. We usually have this argon green laser. Sometimes microdiode lasers are very nice because they can even pass through hemorrhage, but it's a bit expensive. Everybody has argon green laser. So you give few spots over here, this will resolve. See, wonderfully resolve. Here, ETDR has shown us that 2 types. One is focal laser. You just give it in areas where there is microaneurysm and edema, or grid laser. You can give it in pattern like this, one square. They have a square over here, and we have to give it as a square there. And the ETDR has shown that the risk of moderate visual loss was reduced by 50% in eyes treated with immediate laser photocoagulation. There is the Bible for us, which is written by Sir Duke Elder, who was a Moorfields physician. That was the Bible till 1960s and 70s. And in 2000 also, in 90s also, whoever has not read Duke Elder cannot pass ophthalmology. In Duke Elder, he has written that diabetic retinopathy is a non-treatable disorder. But see, after 40 years, we are talking about 50% increase after laser photocoagulation. Treatment of diabetic retinopathy, macular edema, and treatment, microvascular damage, ischemia, we already talked about this. Many complications. This is important for all. Many patients with ocular complications can be prevented by optimization of systemic risk factors. You guys will know much. Everybody, you reduce the risk factor, good or tight glycemic, even diabetic retinopathic study, DRS study, or has shown that in type 2 diabetes, strict diabetic control. Some people have used even subcutaneous insulin, and they found that the reduction or prolongation of diabetic retinopathy. Ophthalmologists play an important role in motivation and cooperation with general practitioners, internists, and endocrinologists. These are all taken from Western books, probably because they have this system from the lowest to the highest level. So general physicians, we have to send it back to general physicians and give them the dates for referral. For example, there are charts given by American Association of Diabetologists and Ophthalmologists sitting together. They've given us saying that if the patient has got a pre-proliferative or a proliferative diabetic retinopathy or a non-proliferative diabetic retinopathy or a mild proliferative, non-proliferative diabetic retinopathy or a proliferative diabetic retinopathy with high risk factors, it should be referred to an ophthalmologist within 3, 6, 9, 12, how many months ever. All those charts are available with the nets or good books also. For generalized diabetic retinopathy, instead of focal laser, we will give PRP. This is called a pan-retinal photocoagulation. We just leave the area of the macula and within the vascular cascades and burn the whole area. The whole area is burned. What is the role here? It is to produce anoxic retina, to convert the hypoxic retina into anoxic retina so that it does not throw these vascular factors and the reduction in all the anti-VEGFs and other VEGFs. So the neovascularization and macular edema is reduced. You can see this was a proliferative diabetic retinopathy. After PRP, see the reduction of new vessels here. So argon green and subthreshold micropulses. And diabetic retinopathic study established the benefit of pan-retinal photocoagulation. That is 26% of severe visual loss by 2 years was reduced to 9%. What wonderful benefit we are getting. See, 26% has become 9% with PRP. This has become very easily accessible. Every clinic has a argon laser machine. Cost of treatment will be 1,200 rupees per sitting. If you're going to corporate hospitals, maybe 3,500 per sitting. You have to go for 2 or 3 sittings. Chandra, please tell me if I'm exceeding my time, okay? Because I tend to talk loud.
Yeah.
Just give me 10 more minutes, I can finish. Past planar vitrectomy. This is a very nice surgical, and the diabetic retinopathic vitrectomy study has shown that there are certain things called high-risk PDR and macular detachments and other things where we cut all this fibrosis and try to tamponate the retina, putting it back by say oils or high fluorocarbons. You can see we have cut all this over here and then put the oil. That's why you can see the image over here. And then after 3 months, see wonderful result. What this has become this. Here itself will tell you how the vision would have improved. Even though it looks normal, the vision would be 660 only. But that is a life-giving vision. Because here the patient would have not even gone to the toilet by himself. Here he can see people entering here. So diabetic vitrectomy study had told us that the vitreous hemorrhage and severe PDR treatment, early vitrectomy gives wonderful results. That is all you need to know. Recently published reports, the preoperatively attached macula and recurrent with 40 to 60% of cases up to 660. This one. Here 660 is wonderful vision. And just think that the other eye is also, they've lost vision. And this is the only seeing eye. This would be a God-given gift for them. In advanced diabetic, we still see patients like here, advanced diabetic, very difficult to treat. We have to cut through, see numerous vascularization. Vascularization will come down, but numerous fibrous tissue. When you pull itself, the retina will come out. Here also, we try to clear only the macular area here and try to increase vision. I've seen even patients get 2 or 3 just letters of vision or optotypes, we call it. Maybe increases, that is enough for them to at least move around, if not. The eyes is only what the eyes, this is diabetic retinopathy. This is the most important side of microvascular complication of diabetes. Now, the other areas where vision is reduced. So unless you look for it, sometimes you can see this disorder, send it to an internist for diabetic screening also. Okay, a lot of things we have found out and sent to the internist, and they have found out diabetes and treated them wonderfully well. See, diabetic papillopathy. This is one condition. This is not a neovascularization. This is telangiectatic vessels or arteriovenous vessels which are opening up at the optic disc. This is also because of occlusion and other areas. I love this photograph because this was taken by one of our mentors called Sohan Singh Aire, who has done wonderful work in papilloedema. He's an Indian now settled in US, maybe 110 years old now, but still he is practicing. That's it. See, the visual acuity is usually 612 and better in 80%. So you will have good visual acuity, but lowering these kind of features. This is not a diabetic retinopathy. This is a papillopathy. That is an optic nerve head inflammation. This is a diabetic papillopathy, and there is another condition called papillophlebitis, which is a central retinal vein occlusion type of disorder. You will usually get confused within these two. If you're an ophthalmologist, don't worry. If you see anything like this itself, please send it to us. Vascular occlusions, as you will be better knowing, the diabetes mellitus occurs in around 50% of patients over 50 years of age. You will have two types. One is this branch retinal vein occlusion, where only branch is at large, maybe mostly inferior or superior, but mainly superior. Usually the visual acuity is 612 or better if they don't have macular edema. Suppose they have macular edema, then you can see, because it is occluded, these are areas of non-perfusion. Now, because of this non-perfusion, this will throw vascular endothelial factors and there will be neovascularization. The important here is this neovascularization will occlude in the anterior chamber and will raise the pressure, causing neovascular glaucoma. This glaucoma can reduce the vision, and this can macular edema can also reduce vision. So here we have to treat this area. Wonderful anti-VGS factors. We can improve the vision. 612. If it's less than 612, 3 to 6 months we wait, and then we can give a trial of macular laser or anti-VGS factors. All these are dictated by numerous studies like branch retinal vein studies, central retinal vein occlusion. Here you have the occlusions at the level of the optic disc, whereas branch you will have at the atriovenous crossing channels. Because of the common adventitious sheet, the arterioles press on the veins which will occlude it and which will cause venous charges and hypoxemia. Here you can see central, there is occlusion in the optic disc level where there is coming near of the arterioles and veins, and you can see this venous pooling over here. This is a late fundus fluorescent angiography. That is why we're having dilated veins, lot of capillary non-axismic areas. This treatment is, one is vascularization, neovascularization. If you develop neovascularization, laser would be the kind of treatment. If there is edema, anti-VEGF is a type of treatment. Anti-VEGF, one thing you should know how you give anti-VEGF, it's put into the vitreous cavity. Intravitreal anti-VEGF. Mainly this bevacizumab or ranibizumab, we put 0.1 milligram in the vitreous cavity, and we look for resolution. With 2 weeks to 3 weeks, we wait. We can see the resolution of new vessels and edema. Where there is no vision, there is no hope. See, there are certain conditions where the vision is reduced, very difficult to come up. The one thing is this arteritic and non-arteritic anterior ischemic optic neuropathy. As I previously said, Sohan Singh Aire has described this condition wonderfully well. This is a non-arteritic type of AION. This occurs in elderly, hypertensive and diabetic patients, and it is seen that 49 to 50% of the patients in diabetes have a strong predilection for NAION, and 30% of NAION patients are diabetics individuals. Nearly seen within 2 weeks of symptoms, 50% usually have visual acuity of 6/12 or 6/9, reduced vision only. Typical will be sudden visual reduction, painless, and an inferior altitudinal scotoma. You can see this area. This area will be a non-seeing area. Typical altitudinal scotoma. This is an anti-ischemic optic neuropathy. This is due, mainly this condition is due to stasis and occlusion of the posterior ciliary vessels, mainly the choroidal circulation at the optic nerve head level, anterior optic nerve head level. You can see this is called an optic disc edema, where the whole border is not seen. You can see the elevated areas. This is supposed to be pink, but it has become white in color. This indicates ischemia. So anterior ischemic optic neuropathy, very common. One of the most important is that arteritic duct, which occurs in giant cell arteritis, Very difficult condition, irritating condition to treat.
Vijay, you got 2 minutes more.
Just 2 minutes. Presenile cataract. Cataracts, as you know, is bread and butter for us. 2 types. One is the snowflakes cataract. This is a snowflake cataract. Typical occurs in undergraduate level. Also, everybody should pick up this cataract, immature and mature cataract. Increased level of glycosylated hemoglobin is increased nuclear and cortical. These are all types of cataracts, which is theory for you all. This is important for you all. Operative concentrations on the day of cataract surgery, withhold the oral hypoglycemic tablets on that day. Insulin dose should be adjusted because by you all. Long-term, first put it as a first case, so to reduce the risk of hypoglycemia. Finish your surgery as soon as possible. All the other and minimal surgical trauma. Clarity of vision is a key to achieving your objectives. Where there is glaucoma, as I've already told you, you can have neovascularization at the angle. This is the angle where the iris meets the cornea here. This is where the aqueous drains. So when there is occlusion of the veins, and you can see neovascles at the pupillary margin, all this is because of the vascular endothelial growth factors thrown by ischemic retina. This is called a neovascular glaucoma. So pressure rises, it can compress the optic nerve head, causing irreversible visual loss. Corneal complications commonly seen, fungal keratitis, diabetes, we have to send the patient to an internist to get for screening for diabetes. So if you have a fungal keratitis, you have to rule out diabetic retinopathy. And if post-operatively, sometimes you can see, because we are using a lot of steroid drops, you can see these areas where the epithelium will not heal at all. This is called a recurrent corneal erosions. Recurrent corneal erosions is another thing. Another thing is non-healing corneal ulcers. If the ulcer does not heal within 4 weeks, then you have to send it to internist for control of this diabetes. Mucormycosis, I don't have to tell you, Chandra would have treated millions and millions of people like him. And see, we had a lot of problems with mucormycosis, sudden rush. This is all new to us only. Our treatments was twice daily of intracorneal injection of amphotericin B. These had saved vision in a lot of patients. My God, I've seen it directly. You have to see to believe. We had wonderful results when ENT people have sent us after surgical debridement. We put intracorneal amphotericin. This eye went inside actually. Stroke, there's going to be an independent lecture. Occipital scopes, you can have a lot of things because patient will only have visual reduction. He will come directly to the ophthalmic center. He'll say there is reduced vision. I have thrown myself out 3 or 4 times thinking it was arteritic ischemic optic neuropathy. The internist asked me to take a CT. It turned out to be an occipital infarct. You can see this hemianopia. All these are all theories. The eyes shout what the lips fear to say. Uveitis, endophthalmitis is one of the feared complications of cataract surgery, which occurs mainly in diabetic individuals. And there is increased risk of anterior uveitis in diabetes also. Maternal diabetes sometimes can produce fetal segmental, superior segmental optic nerve hypoplasia. There is a segment in the optic nerve which does not develop. Retrogradely, they have seen that maternal diabetes is one of the causes. Take home message, diabetic retinopathy is the most common microvascular complication which can lead to irreversible blindness, which can be prevented and treated. A concurrent augmentation of health infrastructure, conductive health policy, improved advocacy, and people's participation. I don't know, this is the most important I felt, people's participation. An important function of eye care specialists is to screen people in order to prevent diabetes. It has been shown, this is important actually for us and for you all also, because if you ever tend to underestimate us, it has shown that many patients who fear of becoming blind is more important for them than the fear of dying. I know, personally, I know my mother told me, if I'm not going to become blind, I might as well die. I'm going to stop with that. Thank you, Chandra, for giving me this wonderful opportunity to sit across and let you know about something about, if I've highlighted 10% of whatever is vision and diabetes, I've achieved whatever I'm trying to talk today. Thank you. Because you have full vision does not think that you have proper vision. Unless you think, vision is of no use. Thank you guys. Thank you guys for your listening.
Thank you, Vijay, for your illustrative talk. I think for want of time, we'll have only one question. what are all the precautions to be taken in patients with proliferative retinopathy going for cataract surgery? There is a question for you, Vijay.
It has been shown lately that diabetes retinopathy will increase after surgery. So usually we prefer to give the anti-VEGF factors, and if we have some amount of vision in the retina, we do proceed with pan-retinal photocoagulation and then take the patient up for cataract surgery. Try to treat the retina first and then go for the cataract surgery, because studies have shown that retinopathy will progress after cataract surgery.
Yeah. Thank you. Thank you, Vijay.
Thank you. Thank you.
Thank you.
Thanks.
Next, we move on to the next talk. Over to Dr. A. Natarajan.
Thank you, Dr. Chandrasekhar. For want of time, we'll quickly move on to the next talk. The next talk is about cognition and diabetes. We know that diabetes is a vascular disease involving micro and macrovascular system. In brain, we see one occlusion of involving larger vessel leading to stroke, and occlusion of smaller vessel leading to small vessel disease and defective cognition. To talk about that, I have a great pleasure in inviting Dr. Krishna Sheshatri, a legend in the field of endocrinology. He's an American board certified endocrinology, diabetic metabolism, and internal medicine, consultant Chennai Diabetes and Endocrine Clinic, clinical and research lead in Apollo Sugar, and senior consultant in Apollo Hospital, visiting professor endocrinology and medical education board member in Sri Balaji Vaidipet and MGM Health. He's a recipient of P.N. Shah Oration of Endocrinology Society and Sam G.P. Moses Oration in RSSDI and Sindhu Pandit Oration in Medical Education. He's a president, Endocrine Society Tamil Nadu, associate editor in J Diabetes Involving Countries, editor-in-chief, Thyroid Research in Practice, member in Curriculum Expert Group, National and Medical Council. And we over to Dr. Krishna Sheshatri.
Sir, kindly unmute yourself, sir. Kindly.
Can you hear me?
Yes, sir. Yes, sir.
Good evening, and thank you for having me here. Thanks for the kind introduction. Thank all my colleagues in the D Club for giving me this opportunity. This is a very interesting topic, and I'm happy that it fits in well with your theme today on neurodiabetes. Conflict of interest, maybe I'm cognitively impaired. I don't think I have any of this particular topic. So before, we're all celebrating 100 years of insulin, and we have been so pancreas-centric about diabetes. But I want to talk about this man. His name is Claude Bernard. Many of you know from your physiology days that this is a man who did a lot of pioneering work in physiology. But he was also the first person to sort of understand and tell us that there seems to be a relationship between the brain and diabetes. He showed that if you pick the flow to the fourth ventricle in the brain, it resulted in glucosuria. So clearly, the relationship of the brain with diabetes is much older. Those of you who heard my talk on the neurological changes in diabetes, I refer you to those where I have spent a lot more time on this. So I will move on to cognition. So first, let's sort of define cognition, because it's important for us to understand what we really mean when we talk about cognitive decline. So cognition is a process this is my own definition that I've culled based on several readings. We don't see good definitions of this, so please bear with me as I give my own. Cognition is a process in which the human brain receives information from the outside world. It processes it and transforms it into internal psychological activities to acquire or apply knowledge. So clearly, there are several parts to it. One is there needs to be a source, and it needs to be processed, and then it needs to be applied either in action or an activity. So Most of us who have reviewed the literature will agree that these are the 4 components that, from a medical point of view, that are important for cognition. And these are the ones that we need to test in our patients to figure out if they have cognitive impairment or not. 1, memory; 2, learning; 3, mental flexibility; and 4, executive function. The 4th one is one that we don't really use all the time, but it's important to understand it because this is what is most affected in type 2 diabetes. Executive function is an insight into problem solving, to a particular problem solving, judgment, importantly based on information to stop or change old habits and starting new habits. An example that we can think about is, someone who likes sugar. Once they know that they have diabetes, need to consume less amount of sugar or no sugar. And that's a new habit that they have to form. If they do not have adequate executive function, you will say that they are non-adherent, but the truth is that they don't have the ability to function. I will keep this theme going because what we will learn is a lot of times when we think that patients are recalcitrant to therapy or not listening to us, and especially over a period of time, we find that they have become more difficult to manage. It's quite possible it's not that they are difficult, but they have a problem, and that could be cognitive dysfunction. Remember that while we use definitions, this is a spectrum. On the one hand, you have dementia, where you are not able to perform activities of daily living. And anywhere you can have mild cognitive impairment, where your daily living is not really affected unless you look very carefully, but certainly some activities are impaired. The other end of the spectrum also is that mild cognitive impairment predisposes you to delirium if you have an additional insult like an infection or an electrolyte abnormality. So Alzheimer's disease is the archetypical example of dementia, and clearly there is a higher incidence that is cumulative over time of Alzheimer's disease in patients with diabetes. Right? There aren't many studies on cognitive dysfunction, so I had to pick and choose, and this study is, and my talk is up to date as late as January 2022. So if you look at this carefully, this is looking at memory, executive function and attention, and processing speed. You will notice that from the time you have pre-diabetes to newly diagnosed diabetes with known diabetes and clearly established type 2 diabetes, you will see that there is clearly a decline in cognitive function. This is not a longitudinal study. We'll look at it in a moment. And these are all statistically significant. And you will notice that in patients with type 2 diabetes, executive function and processing speed are far more impaired than anything else. We'll talk about it again. The same is true of type 1 diabetes, that if you were to give scores to patients on the number of categories that you're testing, that type 1 diabetes, the hazard ratio for cognitive dysfunction is about 3.85, the upper limit of the confidence interval being almost 6.8. So any 2 plus, 2 being abnormal, in this particular study was a definition of clinically relevant cognitive impairment, and you'll realize that this was also statistically significant. In addition, this is a beautiful study that was published by Rawlings et al. In the Annals of Internal Medicine in 2014. And that looks at the 20-year decline of cognitive function, and they had patients with both diabetes and non-diabetes. And remember that as we get older, all of us have cognitive dysfunction. And what you will notice here is that of the 4 tests that were used, and most of these are commonly used tests, there is a greater decline in cognitive function in patients with diabetes, and this is important. So this is the same, looking for the, which is adjusted for the attrition, and you will notice that there is also a relationship with glucose. We will talk about it, that the greater the A1C, the greater is a cognitive decline in patients with diabetes. So what is affected? There is a slight difference in patients with type 1 diabetes and type 2 diabetes. And type 1 diabetes, these are all the things that are affected, but the most important are psychomotor efficiency, attention, and visual construction. In type 2, as I said, memory, the psychomotor speed, and especially executive function, which is the ability to change your habit, that gets changed. Over the years, we have thought about many reasons for having cognitive dysfunction. For example, hyperglycemia and especially microvascular disease, we'll talk about it. Where the macrovascular disease contributes to this is another important question that we need to ask. Hypoglycemia definitely has been linked with it. Whether type 1 diabetes worsens it, whether insulin resistance worsens it, and a lot of talk about it for the last 6-7 years. And of course, remember the absence of ApoE4 allele is something that's associated with dementia itself. So we look at the diabetic brain from diabetes onset. What we know is there are changes in the hippocampus. There can be reduction in gray matter density, change in the white matter microstructure, and atrophy, resulting in neurocognitive dysfunction. However, as I will show you, that this is not always constant. What are the risks? Constantly, I think hyperglycemia is an important risk, as I already showed you in my previous slides. Recurrent hypoglycemia seems to contribute. We'll talk about it. Whether vascular disease itself results in diabetic neurocognitive dysfunction has always been questioned. We talked about diabetic retinopathy. Diabetic retinopathy was just talked about 20 minutes ago. What you see is the relationship between diabetic retinopathy and cognitive dysfunction. And what you realize is that there are microvascular changes probably, and diabetic retinopathy can be a good marker of cognitive dysfunction. This was published in 2021. Very interesting article. This is an older study that looks at hypoglycemia and the risk of dementia. And clearly, there's an excess attributable risk for any hypoglycemia versus no hypoglycemia. You look at the confidence interval here, 1.72 to 3.01, narrow spread. And if you had 3 or more episodes of hypoglycemia, clearly there is a higher incidence of higher risk for dementia. And you'll realize that that clearly more than 2 episodes of hypoglycemia in this particular study, there was a greater risk of dementia. And clearly hypoglycemia unawareness, which Dr. Parandaman talked about in the autonomic neuropathy talk, and of course HAF, which is the hypoglycemia associated autonomic failure, are clearly higher, put the risk of dementia much more. This is looking at what goes wrong during hypoglycemia. The cognitive functions that go away, look, 4 choice reaction times, Stroop test, immediate recall, late recall. Each of these seems to come down. A much older study. What we do know is that the brain activity is altered in hypoglycemia unawareness. That there is a differential function in the brain. Different areas of the brain become over and hyperactive. But clearly, there is a different areas of overactivity in patients with both hyper and hypoglycemia. That brings us to insulin resistance. Some time ago, there was a lot of talk about it. That one of the things that is happening is that the same insulin resistance that occurs in the periphery, right, contributes to cognitive dysfunction and mood disorder. And in fact, this is a very interesting study that this is a rat brain, remember, that shows that there is differential expression of insulin receptors in the brain. On the top is the insulin receptor, the other is IRS1, this is IGF-1 receptor. And insulin action in the brain itself is different in different parts. So the brain has selective insulin resistance, right? And this can actually vary, and especially in the area of the hypothalamus, if you have insulin resistance, that leads to several things that includes an increase in the orexigenic peptides that makes you eat more, right? Many people started comparing Alzheimer's dementia to type 3 diabetes because the pathways seem to be similar. There is brain inflammation, there's activation of cell stress pathways, there is insulin resistance, and of course, memory impact. Similarly, in type 2 diabetes, inflammation is a common pathway. However, we really don't seem to have data to support this in a clinical context, although we are far away from understanding this. This is a slide, please bear with me. And again, it looks at the three things that are important in type 2 diabetes. This is the cognitive domain. There's a mediating effect. This is the executive function. This is a processing field. And you will notice there's a clear relationship between the glucose and the HbA1c in all three of these parameters. But you don't see any relationship between HOMA-IR or C-peptide or any of these. So clearly stating that it's just the hyperglycemia, maybe recurrent hypoglycemia, that is doing the damage than insulin resistance per se. Again, we haven't heard the last of this. This probably will know. So what happens to the brain in cognitive dysfunction? Many of us think that there is going to be a change in the brain parameters. But if you look at this carefully, what seems to happen is that not necessarily having infarcts or any of these is important, but more importantly is just a reduction in the brain volume. This is the gray matter volume. There's a reduction in hippocampal volume, which seems to be significant. But you will notice that there aren't many MRI features that are really consistent with cognitive dysfunction. So it's a clinical diagnosis. So I've sort of talked about the background of all of this. How does the patient with diabetes present with cognitive dysfunction? I think this is more important for us as clinicians. One, for example, memory loss. A patient who is otherwise doing well, monitoring the glucose, taking the medications, taking the insulin, eating on time, eat before exercise, or missing clinics, these can all go wrong. And there are simple ways to help these patients, right? Giving, and I'll talk about it a little more towards the end of my talk, but clearly, getting the caregivers, talking to the kids, making sure that somebody's following them. In our clinic, we actually have an adherence monitor. That is the app we have an EMR software, and the app actually has a reminder for patients to take their medications. And we also have an ability to set a reminder to the caregiver saying, look, your father or your mother has missed 3 drugs, 3 doses. So please look at this, right? So those are things that can help. Also, it's important to take one is to simplify the regimen. We'll talk about it. Decrease the number of insulin education. Make sure that the family is involved. And of course, one of the things that we do is to send reminders. If a patient doesn't come on time, there is a call that goes on from our clinic, and we will do that. Just give me so that is what is important. The second is problem-solving difficulty, right? They may forget to monitor the glucose. They may remember the instructions, but they will tell you the instructions exactly, but when they go home, they will not be able to do it. And of course, very importantly, unable to recognize or treat hypoglycemia. So important is that before we start labeling our patients as non-compliant or unable to understand or difficult, it's important to understand, are we actually having problems here? So one way is to simplify it, decrease the frequency of self-monitoring, make sure that the education is repeated again and again. And sometimes, it can be frustrating for doctors and educationists, but it's very, very important that we understand this and make some small changes at a time and clearly not avoid complex regimens. I always talk about this, that do not sacrifice good at the altar of the ideal. Don't do ideal things in older patients. This is important. The executive function, a difficulty in stopping an old behavior and starting a new behavior can be stubborn. You have to work with them. Refusing new therapies. Again, a lot of times this occurs with older people and insulin. They will just not see reason. And it's not always because that they're obstinate or stubborn. I've seen a few, but most of the time it's just that inability to adjust to something new, and that's part of the disease. So you should ask for care from caregivers with reminders and behavior changes required. Errors occur when old routines are changed. So if you think that there's going to be a marginal improvement, don't do those changes. I think that's very important for us to remember. So if the A1C is going to change by 0.2 in someone who's with this, better not change it. And please don't change brands each time. I think that's very, very important. Keep it constant. Be happy if there is no major changes. These are people who require help. There is difficulty in mental flexibility. They feel anxious. They will come back and tell you that the treatment plan is failing. Don't give very. So a lot of times, I hear people talk about these beautiful insulin treating algorithms. I don't do those. It doesn't work because as patients get older, it's difficult. I do a simple +2, -2. I tell them, look, it doesn't matter if it takes 2 months. Let's do this. The third thing is diabetes is not just life. They have other issues, and sometimes remembering them itself may have a problem. So simplify the regimen, keep it simple. Ideals can wait. Good is more important. This is a simple test that you can do in your office. I've given you the link. It's a great place to look up. It's not something complex. We do it, give 3 words, right? Ask them to recall, ask them to draw a clock with a time on it, and do a 3-word recall, call back and say, what are the words that I remember? Very simple, and if the patient's not able to do these, then you can do further tests, get other help. So the big question is, can you prevent cognitive decline? So this is looking at tight control with diabetes in the Accord trial and the Accordion trial, which was at month 80. The answer is tight control probably does not prevent cognitive decline. So it's interesting data about the use of intranasal insulin. We don't have any follow-up since 2015. This was an intranasal detamir that showed improvement. Similarly, GLP-1, which works to SIRT1, the longevity protein, seems to help. And this is GLP-1RA inhaled in Alzheimer's disease, again showing reduction in neurofibrillary tangles. But we are not going to be doing this for now because we still don't have much data. What can we do? 1, consider cognitive dysfunctions when older adults fail to perform self-care without obvious reason. 2nd, older patients with cognitive dysfunction may fail to report, identify, treat hypoglycemic episodes. To avoid poor outcomes, do what is possible. Don't put the patient at risk. Select patients at lower risk of hyperglycemia. Modify the glycemic goal. Don't use just A1C as a sole measure of glycemic control. Make sure that there is someone who's helping the patient taking glucoses at home. Simplified regimen, use mixes, sacrifice some goals to make sure stability is present. Make sure you are patient, make sure your staff is patient, make sure that you keep on asking, get the drugs back, look at what they have taken, make sure that either they have not taken it or taken it again and again. Ask again and again, did you have a fall? Did you have hypoglycemia? Get the family involved. It's there. They need to be part of the process. So if someone has forgotten to take mealtime insulin, think whether you should just use basal insulin or whether you should use a mixture, right? Make sure that the caregiver is involved in insulin. Use a pill box, or you can use what we do. We have watches that can remind patients. That's connected to our app. You could try that if you want to. So to summarize, the more important thing is don't judge your patient just because they are not compliant. They may really have a problem. And I think I'm happy to give this talk because it helps us understand. And I've understood as I prepared for this talk over time, is that it's not always that someone is difficult. It's not always that someone is not comprehensible. It's probably because we have not tried to understand their problems, and we have not understood the root of the problem. So with this, let me summarize. Cognitive dysfunction is common in diabetes. Consider cognitive dysfunction in patients before judging them as non-compliant or difficult. Simple office tools are available to heighten the index of suspicion. Simplification and support and understanding are the keys to management. I will stop here. I hope I finished well in time. Thank you very much for this wonderful opportunity. I hope we have finished enough in time for you to be able to take a few questions if you need to. Thank you again for this great opportunity. Thanks.
Thank you, Dr. Krishna Shadagri, for your excellent elusive talk about cognition and diabetes. I also would like to share, as you said in one of your slide about GLP and Alzheimer. In my clinical practice, I find using incretin-based therapy, especially the GLP-RA, is useful in improving cognition, especially in diabetic with dementia and mild Parkinson. I do find in many patients there is an improvement. Thank you so much for your excellent talk. Over to Dr. Chandrasekhar.
Yes, sir. It's indeed it's an exemplary talk by Dr. Krishna Sheshadri. Sir, what is the role of metformin, sir? Like, so since you have talked about the insulin resistant at the level of, is there any role for insulin sensitizers?
I don't think,
in particularly in patients with cognitive dysfunction.
So the important thing is that there have been no RCTs that have said that any of these drugs make a specific impact on improving cognitive scores, right? And we really don't have a way, except in an experimental stage, to see if that there is an improvement in cognition scores over time based on just a drug. I think a reasonable control of hypoglycemia, avoidance of hypoglycemia, it seems to be the key. Most of the therapy is supportive, and I think if there is one point I want to reiterate, it is that do not judge patients as being difficult or forgetful or recalcitrant. Cognitive impairment may be a reason why these are, and find a way to support. I think our healing powers are more important than the curative powers of the medication that we are prescribing for these patients.
Yes, sir. Excellent, sir. Yes, sir. That's a take-home message for your talk. I think for want of time, we move on to the next talk. Can I have the introductory slide of Major General S. Kumaravelu? Yeah, it's a privilege to introduce Major General Professor S. Kumaravelu. He has graduated from MBBS from Stanley Medical College between 1972-75. He has done his post-graduation from Armed Forces Medical College between 1983-85. He has done his DM Neurology in AIMS, New Delhi, 1993. He has got a lot of academic honors, including A&K Medal, Gold Medal in Radiology, M.G. Kinney Memorial Prize in Orthopedics, certificates of honor in Anatomy, Physiology, and Biochemistry. He is a recipient of Colonel K.K. Gupta Medal, first in advanced course in medicine. He served the Major Indian Army for 6 years and retired as Major General. He started DP Neurology in Army Hospital in New Delhi, and also instrumental in starting the same in Ramesh Hospital in Vijayawada. He is an avid researcher, has got 6 publications to his credit, and he is a referee for AAN, that is Academy of Indian Association of Neurology, IJCCM, and MJAFE. He is a former executive committee member in Indian Stroke Association, and he is a fellow of Indian Academy of Neurology and ICP. He has got special interest in stroke, movement disorders, and neuroinfections. Over to Major General Professor S. Kumaravelu.
Thank you, Chandrasekhar. I'll share my screen without much delay.
Yes, sir, you can share.
I'm not seeing my screen.
Not it, sir.
I'm not able to share. I was looking for sharing.
Nirav?
Sir, you can help. It's coming.
Network is a bit slow at his end.
Is it shared now?
Yeah.
Yes, sir.
You see my screen?
Yes, sir.
You put in the PowerPoint full mode, sir.
My slide seen? Yeah, thank you.
So the slide is straight, but you put it in the full mode, sir, zoom mode.
I'm doing that. Yeah. Now, Sincere thanks to the organizing committee for having invited me to speak. It was a pleasure. Have the slides moved to the full screen mode?
Yes, sir.
Yes, sir. Yes, sir. Sir, cut off.
His network is.
Network issues, yeah.
Priya, you can call sir.
Yes, sir.
Try to help him out. Maybe he may have to switch off his video.
Yes, sir.
He's disconnecting the line. Maybe he's trying to this 2 minutes. I'll wait and call back.
Sir has joined. Yes, sir.
So otherwise you can WhatsApp me. I will share it, sir, from the platform side.
Kumaru sir, you are muted, sir.
Yeah, you're muted, sir. Yes, sir.
Yeah.
It's coming, sir. Yes, sir. Just go to slideshow, sir.
I'm doing that. Seen?
Yes, sir.
Yes, sir. Yes, sir.
Perfect, sir.
Stroke, as per WHO, is rapidly developing clinical signs, usually focal disturbance of cerebral function lasting more than 24 hours, leading to death. Stroke caused about 143 million DALYs, disease-adjusted life years, in 2019. Contributing to about 0.7% of the global DALYs. The burden in the high-income countries have come down significantly. So we should try and take this procedure to do it for us. However, the global rising prevalence of diabetes and body mass index seems to be offsetting this downward trend. As you can see in this slide, people over 50 years, stroke holds on to the second position in the cause of DALYs, whereas diabetes has moved from 6th to the 3rd position in up to 74 and 7th to 5th position beyond 74. Now coming down to India, stroke contributes 38% of neurological DALYs, and of which Tamil Nadu, the crude DALY rates per 100,000 population is 1151 per 100,000 population, a significant number. Now let's see what happens with diabetes. Now amongst the diabetes, we are in the high economic transition level. And you can see here, Tamil Nadu is the highest bracket as far as this country is concerned, 1628 to 1825 per 100,000 population. So having seen this thing, among cause of stroke in India, high percent of stroke. This is the atherosclerotic cardiovascular disease even seen in diabetics have come down from about 110 per 10,000 population to 50, but there it remains static as far as stroke is concerned. There's a famous interstroke study which is carried out over 32 countries over 9 years, involving around 30,500 patients with equal number of controls, where they identified 10 modifiable risk factors, of which the presence of diabetes increased the risk of stroke by 36%. The contribution of hypertension and diabetes mellitus to regional stroke burden is greater in the Asian region than elsewhere. These are the risk factors which I have seen. Now, coming to the annualized rate of change as per DALYs in the last decade, what we found is that high fasting plasma glucose has got a positive increase in the exposure of the tune of 1.32, next only to obesity and ambient air matter pollution. Now, having seen this, the incidence of stroke in India is 1.29 million, that is 30 lakhs. Deaths are around 700,000, 7 lakhs. High DALYs are seen in West Bengal, Chhattisgarh, and Tripura. Age standardized DALYs have got a weak, significant negative correlation with socio-demographic index. Incidence increases with age. On the contrary, diabetes, the prevalence is likely to go up to beyond 100 million. Age standardized prevalence increases to the tune of 30%, with 3.1% deaths in India, of which 10% are from stroke. As we have seen earlier, we have a high prevalence in our state. Now, high fasting plasma glucose increases the stroke DALY to the tune of 26. Now, coming to this thing, diabetes mellitus is the 7th leading cause of death, of which 10% are due to stroke, and it is an independent risk factor for stroke, increases the risk from 1.8 to 6-fold, more common with type 1, as we have discussed earlier. Now, amongst the diabetic, they've got a 2.3% high risk of developing ischemic stroke and 1.6 times hemorrhagic stroke. And there's a high risk of death, dependence, and recurrence in diabetics. And majority of them present as acute. The risk factor for stroke in age, the number of features of the metabolic syndrome, the presence of diabetic nephropathy in both the types, the presence of and others like mental disorders, as Seshadri was alluding to a little while earlier, COPD, cirrhosis, epilepsy, traumatic brain injury, and dialysis. Hyperglycemia in diabetics are common with increasing age, obesity, and physiological stress. This the same has been reproduced in a study done by Liu et al. In China. Coming to pathophysiology, as has been said, for general, this will concentrate only on the vascular endothelium, where atherothrombosis in diabetes mellitus is increased because of hyperglycemia, insulin resistance, hyperinsulinemia, diabetes mellitus dyslipidemia, inflammation, reactive oxygen nitrogen species, endothelial dysfunction, hypercoagulability, vascular calcification. Now, cardiac stroke follow more frequent diabetics. Major source of extracranial embolism causing an ischemic stroke is extracranial internal carotid, especially with hypertension. Major arterial lesions are acute. Etiology. The commonest etiology of stroke in diabetics is hypertension. 75% of hypertension is seen in type 2 diabetics. 50% of those are with insulin resistance. In Wikipedia's trial, they found that a 10 millimeter reduction in systolic blood pressure resulted in 44% lower incidence of stroke. Accordion trial, systolic blood pressure maintained less than 120 compared to less than 140 had a 23% decrease incidence. So because of decreased incidence associated with hypertension, hyperlipidemia, platelet aggregation, and coagulation, in addition to endothelial dysfunction, which results in endothelial permeability. Macro and microvascular complications, as highlighted by Chandrasekhar earlier, increase the stroke risk. Hyperlipidemia and statins does produce an independent risk factor for stroke, possibly. We do not know. We don't have RCT guided evidence to that, strong evidence. However, in the CARDS trial, 10 milligram per day of atorvastatin versus placebo reduced the incidence of stroke by 48% in type 2 diabetics. The TNT trial, atorvastatin 80 milligram vis 10 milligram per day reduced stroke incidence by 25%. Glycemic control prior to stroke onset is an important stroke prevention and better 5.5%. With a base, 12% increased stroke risk for every 1% increase in HbA1c thereafter. Now, intensive insulin versus standard metformin groups, there was no difference in the incidence of stroke. Metabolic syndrome, it encompasses virtually everything that you have listed so far. Coming down to HDL, what they found is that hypertriglyceridemia, that is low HDL with hypertriglyceridemia, there was a twofold increase in stroke. Hyperuricemia does increase the stroke moderately. The obesity paradox we'll see in the subsequent slide. Diabetic stroke, insulin resistance is independently associated with a lower functional outcome following an ischemic stroke. Bariatric surgery, less deaths from stroke have been documented in a small study. Pioglitazone decreases insulin resistance, possibly reduces stroke incidence. This is the obesity paradox. As you can see in this slide, when you take the body mass index as an index of obesity, the ischemic stroke does keep increasing as the body mass index builds up, while the hemorrhagic stroke seems to come down. This is probably because BMI in Asian settings need not necessarily be indicative of obesity, where they found that the waist strip circumference, if taken, seems to have a more linear correlation. Now, differential diagnosis of stroke, hypoglycemia should be suspected, as has been highlighted earlier. Hyperglycemia, hyperosmolar non-ketotic diabetic coma can present with focal neurological deficit. Same with diabetic ketoacidosis as well. Hypoglycemias have been documented and treated as stroke. Now, mortality and morbidity in diabetic stroke is increased with glucose intolerance and stress hyperglycemia as well. In the admission, glucose level determines the outcome of stroke. At an admission level less than 6.7 millimole per liter resulted in increased cerebral edema, and at level less than 6.7 helped in complete recovery. Postprandial dysmetabolism leads to increased cerebral damage. Cerebral hypercellular calcium. We'll come to case, a 65 years male, non-diabetic and hypertensive, acute onset hemiparesis within the window. CT head was normal, random blood sugar 450 milligram per deciliter. What shall we do? For want of time, we'll go. We will correct hyperglycemia with intravenous insulin before thrombolysis and thrombolyze them as per AHASA guidelines. Now, the latest recommendation which is of interest to us is that hypoglycemia less than 60 should be treated in patients with acute ischemic stroke. And evidence indicates that persistent in-hospital hyperglycemia during the first 24 hours after acute ischemic stroke is associated with worse outcomes than normoglycemia, and thus it's reasonable to treat hyperglycemia to achieve blood glucose levels in a range of 140 to 180 milligram per deciliter and to closely monitor to prevent hypoglycemia in patients with acute ischemic stroke. Now, this is of very interest. This has just come out in 2019. The only blood assessment that we need to do before stroke, requiring IV alteplase, is blood glucose. All other tests you may send in, but you'll not wait for the reports. Acute management associated with hyperglycemia seen in the acute stroke setting is associated with reperfusion injury through increased inflammation, oxidative stress, and platelet aggregation. Increases plasma activator inhibitor 1, that is PAA1, decreasing fibrinolysis, worsens cerebral edema, and the American Heart Association recommends that the plasma glucose should be maintained between 7.8 to 10 millimole per liter. European guidelines, they say that initiate insulin if glucose is more than 10 millimole per liter. The SHINE trial found that intensive, that is intravenous continuous insulin infusion, is not beneficial versus subcutaneous insulin therapy. If the patient comes within 4.5 hours, exclude hemorrhage, thrombolysis with RTPA for salvage of penumbra, thrombectomy up to 6 hours for large vessel occlusion, thrombolysis for 4.5 to 9 hours, wake-up strokes in special circumstances, thrombectomy 6 to 24 hours after special investigations. Outcomes are poor, uniformly poor in diabetics than in non-diabetics with a relative risk of 0.9. Hemorrhagic complications seem to be the same. Now, coming to prevention, this revolves around these parameters, which we all know. Coming to lifestyle, the look-ahead trial, where they found that there may not be a significant difference in the incidence of stroke in diabetics. However, the fallouts are increased physical fitness, reduction in diabetic renal disease, and thereby may have an impact on stroke. Coming to bariatric surgery, it is recommended in diabetics who have a BMI more than 35 kilogram per meter square, who have undergone appropriate medical and psychological evaluation, understand the risks, have medical, social, and psychological support post-surgery. They are recommended to undergo a bariatric surgery, mark the word, by an experienced bariatric surgeon at a bariatric center of excellence. Interestingly, higher baseline fasting insulin, a proxy for insulin resistance, rather than higher BMI, best predicts groups most likely to realize lower incidence rates for type 2 diabetes mellitus and cardiovascular risk among patients who undergo bariatric surgery. Glycemic control, meta-analysis of Accord, Advance, and ADT trials show that intensive glucose lowering is beneficial for reducing composite cardiovascular endpoints and non-fatal myocardial infarction, but there was no effect on total mortality. Now, the considerations are for glucose lowering therapy, add-on therapies to metformin or monotherapy when metformin is contraindicated. Optimal selection of diabetes mellitus medication should be on an individual basis, as we shall see later. Primary prevention, the guidelines have come recently. This was come in 2014. And the second prevention guidelines have been published this last year. Diabetes, they say that control of blood pressure in accordance with the guideline of less than 140/90 millimeter is recommended in patients type 1 or type 2 diabetes mellitus. The usefulness of aspirin primary stroke prevention for patients with mellitus, but no 10-year risk of CVD, cardiovascular disease, is unclear. That means should be recommended. Aspirin, the differential effects of outcomes by treatment age and duration, as well as smoking status. We need more data. The use of low-dose aspirin.
Network
Again lost. Priya, just to call him to find out what happened.
Call பண்றேன். Sir, sir
Yeah,
is joining, sir, again.
Yeah.
Just a minute.
Yes, sir.
Okay. Yeah. So what they've said is that, am I audible now? Hello?
Yes.
Am I audible?
Yes, sir, you are audible.
Yes, sir.
So BP reduction of less than 120/80 as per the latest published trial of Sprint in 2021 is better in renal failure or increased stroke risk patients. But be cautious when using multiple drugs for want of hypotension. Just a minute, it's not moving. I am more or less finished.
Your screen is again lost.
Yeah, I'm just getting it back. So see now?
Yes, sir.
Now coming to the trial, the latest trial is that intensive BP lowering trial seems to have a beneficial effect in production of stroke, as you can see in this comparison. And statin therapy, they found that people with diabetes with up to 7.5 should consider moderate to high intensity statin depending on the severity of LDL cholesterol. PCSK9 inhibitors are experimental at the moment. And this is the overall slide where we can see that the HbA1c for primary prevention with a moderate risk is less than 6.5%. With high ASVD risk, they say that 7%. And in secondary prevention, 7% is continued with polypharmacy. This is the latest 2021 guidelines. The level and recommendation says that in patients with an ischemic stroke or TIA who also have diabetes, the goal for glycemic control should be individualized based on the risk for adverse events, patient characteristics, and preferences, especially for those less than 65 years and without life-limiting comorbid illness. Goal of 7% is recommended. Now, the other one is in patients with ischemic stroke, they say that glucose lowering drugs with proven cardiovascular benefit, that we'll see what are they. And patients in ischemic stroke or TIA who also have diabetes, multidimensional care is of the order of the day. Now, coming to the various agents, as this I've screened the slide on my own, insulin seems to increase the risk of stroke. Metformin reduces the incidence of stroke. Sulfonylureals have got either a neutral effect or increased incidence of stroke. Thiazolidinediones reduce the incidence of stroke. DPP4 inhibitors are neutral. GLP-1 antagonists reduce with semaglutide, neutral with the rest. SGLT2 inhibitors increase the risk for stroke. This is the overall gist I could get from the various studies. Now, to prevent stroke, 80% of strokes are preventable. We are interested in reduced blood sugar. In addition, we have to monitor the other 6 parameters seen in this Life Simple 7. In conclusion, Tamil Nadu and South India have higher incidence and prevalence of diabetic strokes. Diabetes and insulin resistance are associated with increased risk and an inferior outcome. The increased incidence of stroke is due to cerebral infarction, particularly lacunes. Stroke risk and poor outcome increases with metabolic syndrome, atrial fibrillation, and other risk factors. Primary and secondary prevention of stroke should be prioritized in diabetic patients. Stroke incidence can be reduced with control of atrial fibrillation and blood pressure, statin use, appropriate use of antiplatelet agents or NOACs, use of metformin, GLP-1 agonists, and thiazolidinediones. Blood pressure reduction has a linear relationship with stroke occurrence. RAS blockade with an ACE inhibitor or ARB should be used first in treatment of hypertension and diabetics. However, they should not be combined. Blood pressure less than 130/80 is beneficial. A required reading of less than 120/80 is better in renal failure and increased patients with increased stroke risk. However, avoid hypotension. Hyperacute therapy of diabetic stroke involves thrombolysis and thrombectomy as for non-diabetics. The intravenous insulin therapy in acute stroke may not be beneficial in acute settings as well. So, ladies and gentlemen, let our patients of diabetes do not land up with neurologists like me having a bleak outcome like this. Let us give them a beautiful roadmap ahead. Thank you.
Thank you, sir. Thank you for your wonderful lecture. You started with epidemiology, risk factors, and you illustrated on the various aspects of the stroke and the primary prevention and secondary prevention. Thank you, sir. Thank you for your lecture. I think we don't have any questions in the chat box. Do we have any questions on the stage?
No, sir.
No. Yeah. Okay. Thank you, sir.
Thank you. Thanks a lot, Chandrasekhar. Thanks a lot.
Thank you. Thank you, sir. Thank you. Over to Dr. A. Natarajan. We are moving on to the last lecture session.
Yeah, thank you, Dr. Chandrasekhar. The next talk in our diabetic complication and comorbidity conference is on circadian rhythm, sleep, and diabetes mellitus. For that, we have a brilliant speaker, Dr. Usha Agri. She's a senior consultant in diabetes, endocrinology, and medicine in Apollo Sugar Clinic, OMR, Apollo Specialty Hospital, OMR, also Apollo Proton Cancer Center, Chennai. She's been involved with national and international publications, poster presentations, and sub-investigator in numerous multicentric and multinational trials in diabetes and endocrinology. Over to Dr. Usha.
Thank you very much for the very kind introduction.
Recently, madam got FRCP.
Thank you. So thank you very much, Dr. Natarajan, for the very kind introduction. And I would like to personally thank Dr. Chandrasekharan for inviting me to present. This is a very interesting topic. Now, I'm going to try and keep it to slightly less than the 25 minutes allocated because I'm very aware that it's quite late in the evening. I'm going to talk about rhythms, biological rhythms in general, talk a little bit about circadian rhythms and sleep disruption, and then circadian rhythms and diabetes. And if time permits, we can discuss a little around this. So when we talk about biological rhythms, there are several rhythms: circadian in a day, diurnal synced with the day-night, ultradian shorter than a day, and intradian, which is much longer than a day. So we think in terms of rhythms, but actually our bodies have several clocks and follow several rhythms. Circa, approximately, DM, 1 day. So these are biological processes. These are two important terms: endogenous and trainable oscillations of approximately 24 hours. And I'll discuss both these terms in more detail. Now, they're nothing unique to human beings. We see them from single-celled organisms to the most complex biological life on Earth, and they clearly give us certain biological and evolutionary advantages. For example, your body temperature is lowest when you're in deep sleep. The blood pressure starts going up in the morning in readiness for your activity. Your melatonin secretion starts just before bedtime and stops in the morning, allowing you to wake up. Your bowel movements are most likely in the morning, whereas they're suppressed at night. And during the day, your fastest reaction times, best coordination, muscle and cardiovascular efficiency in our previous generations gave us a certain evolutionary advantage, for example, allowing us to hunt and gather during the daylight hours and allowing us to rest during the dark hours. Now, when I'm talking about circadian rhythms, there are 3 criteria that must be met. The rhythm is endogenous. I said endogenous and entrainable, 2 terms we need to be familiar with. Endogenous as in it is set internally by the organism, and the different tissues in the organism can have different clocks running to different rhythms. And the general periodicity in daylight living animals is just over 24 hours, 24.2 for adults, 24.3 for adolescents. And for nocturnal animals like bats, it's just under 24 hours. It's not exactly 24 hours. The rhythms are entrainable. Entrainable means that there are external influences. These are called Zeitgebers, time givers. which influence these rhythms, and the rhythms exhibit a temperature compensation. So if you and I move a few degrees north or south, or we don't go into hibernation, for example, so our body rhythms exhibit temperature compensation. Now, what this allows us to do, as I said, origins-wise, they are present in cyanobacteria, for example, which is the earliest form of life, or one of the earliest forms of life known to man. And they give us certain evolutionary benefits. So the muscle reflexes, the blood pressure, the alertness during the daytime allows us to survive. And the lower body temperature, the suppression of bowel movement and all the rest allows us to rest during the darkness hours. The rhythmicity is very important in that it coordinates your internal processes with the surrounding environment so that you're in sync with the environment. There's no point in being most alert and having quick reflexes in the dark of the night, because that's not when traditionally our ancestors survived by eating, hunting or gathering. And there is a reciprocal system. So I talked about Zeitgebers. There is one primary entrainable stimulus, which is light, but others like our environment and the feeding times can also set your clock. And there is a strong association, therefore, between circadian rhythms and disease, especially when some of these rhythms are disrupted or disturbed. Primarily, your circadian rhythms are driven by this BMAL and clock genes, and I'll talk a little bit more about them in specific relation to the beta cell in a bit, but effectively, these two are the main regulator genes. Now, I talked about Zeitgebers. Centrally, your main agent, the main stimulus that entrains your rhythm is light, hitting your retina and stimulating your suprachiasmatic nucleus, the SCN. This is your central clock that regulates your whole body. But every single tissue in your body, like your pancreas, liver, muscle, adipose tissue, has an intrinsic biological clock that allows it to control intake, food intake, temperature, your activity. So although light is the main Zeitgeber, your activity, temperature, food are other agents that can entrain your central clock. And at the level of the tissue, you have individual clocks that allow you to regulate your metabolic functions peripherally as well. So for example, your pancreatic clocks allow insulin release regulation. Your liver clock genes work on hepatic gluconeogenesis. Your adipocyte clock genes regulate appetite and plasma-free fatty acid concentrations. So at each tissue level, there are genes that act peripherally, not just centrally. Now, one of the main actions of this circadian rhythm, apart from modulating other things like body temperature, melatonin secretion, cortisol, appetite, is the sleep-wake cycle. And if this is disturbed, it can result in comorbidity. Now, how does this work? So you have two main stimuli for sleep. Number one, you have your sleep cycle, the process S as it's called. And what it does is it actually, sorry, I'm just trying to move my bar down, right? Your sleep drive increases with wakefulness. So this is your nighttime, this is your wake time, your daytime. The longer you're awake, the more your sleep drive increases till you fall asleep. And then it falls off steeply. Now, your circadian signal actually suppresses wakefulness throughout the night until it's time to wake again. And then as the light hits your retina and goes to the impulses go to the suprachiasmatic nucleus, your wake cycle, the circadian signal starts again. Now, the circadian signal is most powerful in the second half of the night because your sleep drive process wanes in the second half of the night. It's not strong enough and you may wake up, but your circadian signal is what keeps you asleep in the second half of the night. So between these two, these regulate your sleep cycle. Now, then you come to what happens if this is disrupted. There are various disorders, and with sleep, 6 are mainly recognized. 2 extrinsic, jet lag and shift work disorder, but 4 intrinsic, delayed sleep wake, advanced sleep wake, non-24-hour sleep wake, and irregular sleep wake. What delayed sleep wake and what these mean, I'll show you in a minute. So in normally entrained individuals, and remember I said entrainment is these external signals that reset your clock. light exposure during the last few hours of your typical sleep period, so maybe 4 a.m., 6 a.m. onwards, and during the early hours when you wake, resets your circadian rhythm. And light in the evening and late evening when you're supposed to be early sleep period actually pushes your circadian rhythm later. So that is what happens when your light cycle is disrupted. Now, in jet lag, which is why when you go somewhere, it takes a couple of days for it to entrain. Light again entrains your biological rhythm, and you don't stay in your old time zone when you move to a new time zone, because your signals, your circadian rhythm is entrainable. Now, advanced sleep-wake phase disorder, people generally wake up early and stay awake through the most of the day, but go to sleep early and wake up early. So this is your 4 a.m., 6 a.m. biological day and biological night here. These people wake up early, and this usually is seen with age. So it's physiological with age, and they wake up early, they go to bed early. Delayed sleep, all of these can also have a genetic basis, but most commonly this is related to age. Delayed sleep-wake phase, what happens is people go to bed very late, and sometimes this is a learned behavior or maybe a learned misbehavior where you go to bed very late and then you wake up very late. Now, remember, both these can have an adequate amount of sleep. So it's not the quantity or the quality of sleep, but when you fall asleep and when you wake up. Now, this is non-24 sleep-wake rhythm disorder, most commonly seen in people who are totally blind. Because remember, even if people have visual impairment, as long as some light hits the retina, it can still stimulate your suprachiasmatic nucleus. But in people in whom no signal goes from the retina to your suprachiasmatic nucleus, the clock is slightly more than 24 hours. So every 24 hours, it moves down, 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 down. At some point, the day-night cycle will overlap, but then it moves again. So they have a non-24 sleep-wake rhythm disorder, but it keeps moving down the clock, round the clock. Now, this is irregular sleep-wake disorder, most commonly seen in dementia, where there is absolutely no rhythm. They go to bed at odd times, they wake up at odd times, and there is no concurrence with the biological or sunlight clock, neither. Now, this can present as insomnia, all these disorders with difficulty falling asleep, staying asleep, waking up too early, or poor quality of sleep. And this has consequences from cardiovascular, musculoskeletal, GI, endocrine, respiratory, and genitourinary health. And about 80 to 90% of individuals with insomnia have another medical or psychiatric condition associated with it. So insomnia has a lot of triggers. For example, physical conditions, neurological conditions, medical conditions, medication, anxiety and depression and other psychiatric disorders. But the eventual result is sleep disturbance of some sort or the other. The reason you have these comorbidities is because insomnia can possibly increase your sympathetic activity, your systemic inflammation, and disrupts your hypothalamo-pituitary adrenal axis. This can cause problems with heart rate, blood pressure, atherogenesis, dyslipidemia, and insulin resistance. Now, with blood pressure, we know that nocturnal dipping is physiological, and yet when you see people who have sleep disorders, because of a change in baroreflex, because of maybe a resetting of baroreflex to a higher level, or a combination of these factors, including sympathetic drive, you actually see a loss of this nocturnal dipping, and you know that is increased with CVD and mortality. That's about sleep and disruption of sleep and effect on comorbidity. Now, coming to beta cells, as I said, beta cells have an intrinsic circadian rhythm of their own. If you look at sleep disorders in diabetes across various studies, and I'm just showing you data from one, less than 10% of people mostly say that they actually sleep well. From slight to severe disturbance, more than 90% of individuals with diabetes complain of some degree of sleep disturbance. Now, remember way back at the beginning, I mentioned that there are two genes that primarily drive your circadian rhythm. Well, these two genes, the clock and BMAL, are also present in the beta cell. And through a combination of the light-dark cycle cues from the brain through the sympathetic and parasympathetic nervous system to the beta cell, as well as through your feeding cycle, they keep the beta cell functioning primarily through its effect eventually on insulin granule exocytosis. But when these cues, either the feeding or the light dark cycle are disrupted, you have a decrease in insulin secretion and development of pancreatic islets. Now, the clock and BMAL genes have a huge effect on oxidation and phosphorylation at the mitochondrial level in the beta cells. Look at the whole picture. I want you to concentrate on two colors, pink and blue. In the liver cells, the blue genes, including GLUT2, glucokinase, and your endoplasmic reticular genes and your citric acid cycle genes, regulate your glucose metabolism. But at the level of the beta cell, your clock and BMAL, through their influence on your antioxidant genes and your reactive oxygen species, through their influence on the endoplasmic reticulum, and through their influence on insulin exocytosis, can give you beta cell failure and glucose sensitive insulin secretion is impaired. Now, this uncoupling protein 2, this bit of the story, has a huge effect on beta cell function, and inadequate suppression of this can lead to glucolipotoxicity. And especially in people with diabetes and a BMI over 30, disruption of your circadian rhythm fails to suppress this uncoupling protein 2, and therefore fails to, it leads to insulin resistance and glucolipotoxicity. Now, your reactive oxygen species, again going back to this slide here, the antioxidant genes are influenced by, again, your circadian rhythm and beta cells, BMAL and clock 1, and beta cells have a very low threshold for oxidative stress because the antioxidant genes are very expressed in a very low concentration in the beta cells. So any disruption of the circadian regulated food intake or oxidative metabolisms immediately has an effect on beta cell number and function, and therefore they're very sensitive. The final thing is your UPR genes are upregulated, and this is the unfolded protein response. This is necessary for your beta cells to adapt to endoplasmic reticular stress, and these are upregulated with a disruption of your circadian rhythm, and especially phase advancement, like I've shown you. People who go to sleep late and wake up late, that kind of phase advancement can accelerate beta cell loss. So that happens at this level, right? Your endoplasmic reticular level. So both BMAL1 and other genes can be implicated in diabetes, hypertension, impairment of beta cell function. Now, does this matter? So I've shown you that there are certain genes that are disrupted, but does it really matter in day-to-day life? Well, this is a couple of studies I'm going to show you that actually it matters. Now remember, when I'm talking about the beta cell decline or failure, beta cell mass is different, beta cell secretory function is different, and most of what I'm showing you is related to secretory function. So in this clinical study, they looked at glucose and insulin response in young and older participants. They looked at it baseline, then they sleep restricted them for 19 days, looked at the response, then they let them sleep properly, and then after 9 days looked at the response. Now this is the data for young. The black is baseline, and after restriction, both your glucose levels are high and your insulin levels are low. This is 19 days of sleep disruption. Let them sleep again properly, and there is complete recovery of both your glucose levels and your insulin levels. So this shows that in the young, and this is mirrored in the elderly, where your glucose levels and insulin levels, glucose goes up, insulin goes down, recovers with sleep, are both influenced by sleep deprivation. Now, another study, so this is just sleep restriction. Remember this, they just didn't let them sleep and they disrupted their circadian rhythm. So they didn't let them sleep enough and they slept at the wrong time. This study actually was really good. They looked at sleep restriction plus circadian alignment. So you sleep enough at a physiological time, you sleep less but at the correct time, you sleep less but at the wrong time. So this is what they did. This group slept well. This group slept but during the physiological time. So sort of about 11 o'clock till 5 o'clock or 11 o'clock till 6 o'clock, just less. They didn't quite get the 7 hours of sleep. Now this group didn't sleep at the correct time. You can see that in this group, they slept, but this is like shift workers, right? One day they sleep on time, one day they sleep late, they sleep late for a couple of days, then they come back, then they sleep late, then they come back. So this is typically what happens in shift work, where your sleep may be restricted, but it is certainly out of sync with your circadian rhythm. And what you'll see is when that happens, your insulin sensitivity index as well as your disposition index, which is an index of how well you burn your glucose or how well your insulin acts, basically are both significantly disrupted at baseline and after 7 days of sleep restriction. So you can see that your sensitivity index falls considerably and your disposition index also is impaired significantly. So when you have shift work or sleep restriction, be it circadian aligned or misaligned, you will see a disruption. But with the circadian misalignment, the disruption is much more severe in terms of both your insulin sensitivity and your disposition index than if it was circadian aligned. So sleep restriction was common, but in one group it was aligned, in one group it was misaligned. And in those in which it is misaligned, it is actually much worse. So shift work tends to disrupt your insulin sensitivity and your glucose disposition. So through various effects, through the SCN and the beta cell genes that we've talked about, there is decreased secretion with decreased survival of the beta cells and decreased responsiveness to oxidative stress, and therefore increase in beta cell failure. Now, I'm not talking about mass, I'm just talking about functional failure, right? Now, what are the mechanisms? They hypothesize. Now, remember, I've shown you the genes, right? That primarily through the antioxidant genes working on the ROS system, as well as the uncoupling protein genes working on endoplasmic reticular stress, they lead to mitochondrial dysfunction and eventually to beta cell failure and diabetes. So again, the same genes here at the endoplasmic reticular level and here at the ROS system level, in the beta cell, they lead to decrease in insulin exocytosis, because all this ultimately goes to a ATP-ADP imbalance and a decrease in insulin exocytosis. That is the final common pathway for all of these disruptors in the beta cell. So circadian misalignment is associated with obesity, metabolic syndrome, and increased mortality. I've shown you the CV and the blood pressure data. There is an increased risk of approximately 60% in people who do shift work for diabetes. And the risk is independent of obesity. And the longer you do shift work for, the higher, it seems to be cumulative, the higher your risk of type 2 diabetes. The insulin secretory function is under circadian control, and this is as such disrupted in obesity and type 2 diabetes. This is worsened when your feed timings, when your eating timings are disrupted. This loss of circadian rhythmicity is an early marker for beta cell dysfunction in type 2 diabetes. Now, restricted feeding time, even for shift workers, can to some degree reset these peripheral clocks and to some degree reduce your risk. So even in shift workers, if you restrict the time during which they're eating, they may have some benefit and may not have all the damage of the shift work pattern that I've shown you. Lots of factors, including circadian disruption, whether it is because of environmental, genetic, age-related, or other factors, can lead to impaired mitochondrial function in the beta cells. It can reduce your glucose-stimulated insulin secretion and can lead to diabetes. The BMAL and clock in the beta cell are autonomous of SCN control, but are also influenced through the sympathetic nervous system by the SCN. And they're absolutely essential for the beta cell to adapt whatever adaptive capacity it has to oxidative stress and to the reactive oxygen species. Disruption of this leads to impaired beta cell function. Now, can we do anything to reset and prevent? Data suggests that even in shift workers or in those in whom there is circadian misalignment, keeping feeding timings consistent, exercising, and managing all the other risk factors may to some extent mitigate these metabolic risks, but will not completely take them away. So I hope I've given you a quick overview about circadian rhythms, their effect on sleep, and the potential mechanisms and their influence on diabetes and beta cell function. Thank you very much.
Thank you. Thank you so much, Dr. Usha, for an excellent talk. And you have enlightened in detail about circadian rhythm and the normal living as well in diabetic setup. Thank you so much for your talk. Any questions in the chat box? Dr.
Yeah, thank you, Dr. Usha. I agree for the excellent coverage. Like we are thrilled to listen to your talk. Like the connecting the things, like how the circadian rhythm and how does it affect the sleep quality and how it can escalate to create a inflammatory milieu affecting the beta cells, and in turn beta cell dysfunction, how it offsets the circadian rhythm at the hypothalamic level. It's a beautiful explanation you offer. In fact, we have your talk was something reading a novel kind of thing, like illustrative thing. So I just wanted to have one question. The insomnia is quite common in diabetics. Like somebody with insomnia, diabetic, usually we check for HbA1c, poor control, and other things. Like so is there any other thing, like so you're trying to say in your last part of your talk the sleep hygiene part of it, like so if you could say something on the sleep hygiene so that everyone can get benefit.
See, when we talk about circadian rhythms, there are certain things. I mean, you remember Gowdy did a fantastic paper on this in our last journal club, right?
Yes.
There is the social clock, there is the daylight clock. The social clock is something that we construct for ourselves. Ideally, our rhythms are set to the sunlight and daylight clock, light and sleep cycles, and the light hitting the retina going to the suprachiasmatic nucleus is what wakes us. Now, until 2 generations ago, when even until 1 generation ago in the villages, people went to bed with the sunset and woke up with the sunrise, and nobody had sleep disorders and nobody had rhythm disturbances, right? All that with the introduction of artificial light, and especially in cities, has been completely disrupted. To a large extent, we need to retrain those stimuli, and 80-90% of people with diabetes complain of some degree of circadian disruption and sleep disruption. What can we do to reset it? There is some evidence to suggest that, for example, remember where I said exposure to light early in the morning wakes you up and gets you alert and awake in the morning, but exposure to light late evening and in the first few hours when you're supposed to be asleep can actually disrupt your melatonin secretion and your sleep cycle. So there is some evidence to suggest that maybe dimming the lights towards the second half of the day, making sure that the room is entirely dark when you go to bed, avoiding blue light. And the blue light evidence is a little controversial because about 18 months ago, there was a small publication that said, no, blue light does nothing. But the majority, and there is work ongoing in this space, but the majority seem to agree that blue light exposure in the 2 to 3 hours before bedtime, and look, what we are doing is blue light exposure. You and I are staring at a screen right now. And our suprachiasmatic nucleus is extremely sensitive to blue light. And this blue light exposure late at night basically disrupts your melatonin secretion and your internal clocks. So things that people can do relating to sleep hygiene: 1, eat early, because your feeding is a huge stimulus and a huge zeitgeber, one of the zeitgebers for your biological clock. Eat early. 2, do things in the evening that wind you down rather than put your adrenaline up. 3, make sure that if nothing else works, your light stimuli are appropriate, daytime appropriate, daytime not as in clock time, but in sunlight time appropriate. So maybe dim your lights towards the evening, go to yellow light, maybe make it completely dark when you're trying to sleep, avoid screen work and blue lights, kind of things. So there are a lot of things we can do for ourselves. But if all else fails, in people who have phase delay, so they're getting to bed late, you can actually try a short-acting benzodiazepine that doesn't have a hangover effect to reset that clock for 4 to 6 weeks, but it cannot be done on its own. It has to be done in combination with behavioral change. They can't just take the sleeping pill and then come back to you 6 weeks later and have done nothing. But in those in whom there is a phase, the early morning wakers, especially with age, that is much more difficult to treat because even if they delay the sleeping time, they're likely to wake up early but feel sleepy during the day. So actually the phase delay is maybe much more difficult to treat. Those that are going to bed late, we can retrain. Those that are by age, especially waking up early, is very difficult to treat. Dementia is completely disrupted, and total blindness, again, there is an advancement day by day, but mostly we are not talking about those two situations. Mostly we are talking about people who, to a certain degree, fall into certain habits that they have to unlearn, and maybe entrain is the wrong word, but entrain themselves again to their Zeitgeber. Gauri is smiling.
Madam, just one basic question. How do you account for nap when we sleep in the daylight, madam? Like, how does it make someone energetic? We are exposed to daylight, but still we take a nap and feel energetic. The REM, non-REM doesn't go for, but
when you nap, you never sleep long enough for REM sleep. I had one slide that in the interest of time I took out. So sleep-wise, you go through several REM, non-REM cycles through the night. The first one is the shortest. You get to REM sleep after about 70 to 110 minutes. But the subsequent sleep cycles are usually 90-minute kind of cycles. And you go through REM, non-REM. And phase 1, 2, 3, 4, non-REM 1, 2, 3, 4. 3, 4 is restorative. REM is literally where you clear your plaques and clean up your brain and do all the rest. During the daytime, all you're literally doing is waking up refreshed after about 20-30 minutes. There is a difference between how you feel if you sleep 1 to 2 hours and you wake up feeling totally mabu, or if you sleep sort of 20-30 minutes and you wake up. And especially for the elderly, this is very important. 1, nap earlier so that it doesn't interfere with your night sleep. And 2, short naps, because long naps in the afternoon will disrupt your sleep cycle. So I always tell my patients, try not to nap if it's really disrupting your sleep cycle, or if you have to, as in you've had really bad night's sleep and you can't stay awake the whole day, try to nap earlier and wake up after 20-minute nap. This is just enough to sort of freshen you, but not enough to disrupt your nighttime sleep.
Super.
Nice lecture. May I ask a question? Yes, I just want to know that, especially in women, around the menopause, they come to me with a lot of these problems of sleep disturbances. Does hormones have anything to play in this setting?
So one of the most obvious things, for example, your nighttime body temperature goes down by a couple of degrees. Your early morning if we take a step back, we know that in certain conditions, for example, we see an evening spike of fever, and we look for that evening spike of fever because naturally your body temperature is higher in the evening and lowest midnight onwards. For example, in women who are going through menopause, hot flushes at night are very common and their body temperature is higher. That alone is enough to disrupt sleep. So we always say, for example, keep the bedroom cooler than your ambient temperature and try not to use heavy covers, and especially try to sleep in a cool, dark, quiet environment. So, and it does affect your, there is a beautiful talk on this and it's just too long for this. But your retina, your suprachiasmatic nucleus feeds to your pituitary, and it affects your cortisol, your growth hormone, and your other circadian rhythms. And that in itself can, and your melatonin as well. And that in itself can disrupt your sleep. Apart from the body temperature fluctuations, for example, around menopause. Maybe that's a talk I can do on another occasion about the endocrine side of your circadian rhythm.
One question, madam.
Yes. Hi, Dr. Kannan.
Yeah. Madam, any message on cellular crosstalk pertaining to circadian rhythm?
Sorry,
cellular crosstalks.
Crosstalks, okay.
Pertaining to circadian rhythm to regulate the mitochondrial function and metabolic flexibility.
Oh my goodness. Okay. Look, where do I start? God. Okay. Can I ask you to rephrase your question because this is very complex?
No, ma'am.
Crosstalk as in.
Yeah, you already mentioned in your
beta cell function.
initial
Exactly.
slide, the peripheral clock and the central clock.
So there is a central clock which is primarily entrained by the light. Okay. And that's at your suprachiasmatic level. But that is a primary. You also have feeding, body temperature, environment, exercise, other things that entrain it. But from the suprachiasmatic nucleus through your sympathetic nervous system, you have stimuli to all your peripheral cells including your liver, your pancreas, your adipose tissue, every single cell in your body. That is part of the clock that entrains your peripheral cells. But all peripheral cells, if you take out a pancreatic islet and throw it in a petri dish, it will still have its own 24-hour plus slightly more than 24-hour kind of intrinsic biological clock. So there is cellular crosstalk in that from your suprachiasmatic nucleus, you get signals to every single tissue. But should you take out the tissue and throw it in a petri dish, it will still work as an intrinsic biological clock because of its own BMAL and clock genes. So I think, and also, for example, between the pancreas and the liver, food is one of the major signals that gives you crosstalk between these two and the adipose.
Yes.
Example, between pancreas, liver, and adipose tissue, food, triglyceride levels, free fatty acid levels, sorry, not triglyceride, free fatty acid levels are things that again influence the genes in these. So there are chemical as well as neural messengers, extrinsic and intrinsic, that give you crosstalk between these tissues.
Thank you, ma'am. Thank you.
Answers that.
Thank you, Dr. Bushra. We'll strictly abide by our instruction to go to bed a bit early today. Chandrasekhar.
Yes, sir.
We'll follow her instructions. Yes, at least today.
Yes.
I think doctors are the worst offenders of the circadian rhythm.
I think over to Dr. Mohan, like it's time to deliver vote of thanks. It's already getting late. So kindly unmute.
Yes, sir. It was indeed an excellent day, sir. We'll never forget this day. On behalf of D Club DisiCon 2022, we thank our speakers, Dr. Chandrasekhar, who excellently alluded about neurodiabetes, Major Dr. Gauri Shankar on distress, depression, diabetes, Jayant Panda on diabetic neuropathy, Professor P. Parandaman on autonomic neuropathy and diabetes, Dr. U. Vijay Shanmugam on vision and diabetes, Dr. Krishna Seshadri on cognitive impairment, cognition and diabetes, Major General Professor S. Komaravelu on stroke and diabetes, last but not the least, Dr. Alagiri, who spoke on sleep and diabetes. It was really an excellent session. We thank our live wire, passionate speaker, workhorse, man with the lion's heart, Professor Chandrasekhar, without his support, who was a man behind the show and instrumental in organizing this conference. We also thank Dr. Dhanamitran for his constant motivation and the news updates. And also we thank Professor Parandaman for his, in spite of his personal commitment, emergency, he had given a talk live from airport. Dr. A. Natarajan for his refreshing ideas, Dr. Kannan for his exuberance and enthusiasm, Dr. G. Jaykumar for his updates and latest information on technology and other information, Dr. Arvind Babu, Dr. Kamalakannan, Dr. Ramkumar, Dr. Victorvale. And also we thank Ms. Sri Priya for the RX events, Shruti and Nirav for the smooth conduct of this event. And also we thank Mr. Vasant of Sanofi and Ipca Laboratories. Above all, we thank all the delegates, nearly around 550 to 600 delegates have logged in. And also we thank all the healthcare professionals who are logged in spite of the busy schedule. Let us rededicate ourselves for the upliftment of our people who are suffering from type 2 diabetes. And this is a wonderful session. Like often we heard about only heart failure or diabetic kidney nephropathy and all these things. This is the first time we are talking intensively and had an intense discussion about neurodiabetes. And over to Professor Chandrasekhar to close the session.
So I think we all had a good academic session today, and I thank all the faculties who readily accepted to grace the occasion with their expertise, and all the delegates. I think we hope we'll join you soon with another DCC-Con, another concept, maybe on the diabetes and the lifestyles exclusively on one session. So we thought of doing it because lifestyle is another thing that is not been much emphasized. We talk about, again, organ specific, but lifestyle measures exclusively, I thought we'll do that in another 3 months' time. Thank you all for joining with us. Thank you and good night.
Thank you.
Good night.
Good night.
Thank you. Thank you.
Thank you.
Thank you.
Gauri, good night, Gauri.
Sir, good night, sir.
Good night.
Phone
Good night.
பண்றேன் இருங்க.
Thank you.
Bye, 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 boss.
Sir, good